reduction screw that we have developed is working. Okay. And after that, we are going to do our first case that is just intubated, and the spine fellows are opening it. And our plan is, to expose it right from occiput up to C4. So that is our standard practice. For every CVJ case in which we are planning C1, C2 fixation, you must expose till C4 spinous process. Okay. Now I am going to cover up a little bit about how the reduction screw works, and then we'll shift into theater. Okay. So I think we were using that 10 years before. Now, not used right now. Cables, wire, all have their places. Still use somewhere some parts of some clinical condition like when you are operating on children, we have the lateral master. Still people are using this type of cables and various you must have seen okay, the cardiac people are using that. So sometimes we are using that in very small children in which impossible to put the lateral mass, sport, and the pedicle scope. This is one thing that actually that we recognize and that is developed by Professor Atul Goyal Saab, and this is his system. The problem of this is that if you see, this simply depends on pushing the screw inside the T1 and T2 over a plate. So there is no central rotation, there is no counter rotation. This screw is not locking itself, it is only going inside that way and that way. There is no central rotation. It still can come out and okay, so see, this system actually has the flaw that there is no check to extension, as I have told, because it still can, come out posteriorly, and there is no check to rotation. It still can rotate by itself in anti-clockwise manner. Okay, so there is no check to rotation, there is no check to extension. Very solid fixation in flexion only. And चेंज नहीं हो रहा यार. अच्छा, हाँ ठीक है. हाँ. Okay. So see, this is how this system was put inside. First, you have to make a point for putting up your C1 screws. This is our case. I have used this system, a couple of cases where you put your first screw inside the C1, then over the plate, then drill a part of parts to make a room for your C2 screws, and then you have to put your C2 screw inside in subfacetal manner or half pedicular manner. That is the technique of putting this plate and screw system. Very good technique, especially for the mobile AEDs, where the space is very constrained, because this doesn't require a lot of space to put inside. But the problem is, by concept, if you understand that CVJ anomaly is basically the anterior end downfall of occiput C1 complex over the C2. Okay, so by concept, for reducing it, you have to pull the C1 occiput complex back and up. Okay, and this system solely depends on pushing the C2 down and anterior, because here what you are doing, you are putting your C1 screw first, you are totally locking it, and then you are pushing the C2 down and anteriorly. And as I have said earlier, there is no check to extension, there is no check to rotation. So this type of system fails sometimes. There is a very good clinical improvement in all these patients, no doubt about that. But I thought that I could have achieved better. It's not perfect alignment. It's not perfect alignment. I could have achieved better. Radiologically, they are not that much improved, but patients are improved clinically. Okay. And I have seen, the horrible pictures. This is not operated by me. This was operated by the master itself. Okay. The biggest master. We all are knowing him. So see, this screw is filling. Okay. C1 has come out. C2 has come out. So this happens, and this happens a lot. Nobody is showing that, but this happens a lot. I am taking referrals from, from the Maharashtra itself, where this C1, C2 system actually has failed in couple of patients. So then comes this system. We all are aware of this. Okay. So this is the system where there is a polyaxial head in a screw and the rod system. This is the most versatile and most perfect system. Okay. Beauty is it provides check to all type of movements, because the rod is locked inside the head, and when you tighten it, this polyaxiality will be lost. It will lock itself over the remaining part of the screw. So it provides check to all type of movements after fixing, after tightening, into extension, into rotation, into flexion. And this is the most versatile system. The beauty is that it provides a chance to do the multi-planar correction also. You can rotate and then you can fix. In the previous system, it's not possible. It is pretty fixed. There is no polyaxiality. So you can only fix, but you cannot do any type of correction. Okay. So this is the best system that we all are using for past couple of years. But again, there is a problem. If you see, yesterday I have told you, like, how to put C2 pars screw and C2 pedicular screw. This is the entry point for our pedicle, pars, and the subfacetal. Okay. So see, this is a normal C2 pars scenario. And I have put a C2 pars screw here and a C1 lateral mass screw here. If you see in the sagittal alignment, what is happening? You can simply see the distance in the sagittal alignment between the heads. One head is lying here and another head is lying approximately 1.5 centimeter back. This is a normal scenario. Consider a scenario where AD is dislocated anteriorly. Okay, where the C1 is lying somewhere here. This distance will increase like 2 centimeters. And it becomes so difficult for you to manipulate, to put up your rods. You all are facing this problem, I know. Because if you are doing this, practically in many cases where there is a fixed AD that you cannot correct during intraoperative surgery by your maneuvers, putting up rods and correcting is almost impossible. And what you do, you leave a part of C1 screw behind just to maintain or just to connect the rods. That is a problem. That is a practical problem. And if you see, if you are using a C2 pedicular screw, this is the C2 pedicle, this is C1 lateral mass. And you just assume this constrained space. This is a normal scenario. This is a normal model of a CVJ. This space is so much constrained. If this C1 lies here, in that much constrained space, you cannot put your rods. Very difficult. So what we did, that I have told, okay, so this is the normal screw that we were using previously, and we have just improvised it by increasing the head size with a breakable profile. We make a groove. After correcting it, after completing your rod tightening, you just can break it off. Okay, that is the concept. So how it helps? Okay, this is a 3D model of a case. Okay, you see one side is like sagittal inclination is almost 100 degree. Here it is more than 160. Okay, the sagittal inclination is too much. Grade 3 as per Professor Sarat Chandra Sahab. Vertebral artery one side is at stake. And now here is your lateral mass. And see what is happening. Okay. Now we have put our reduction screw into the C1 and a simple subfacetal screw here. Okay. And see if it would have been a normal screw. It will lie here and the C2 will be here. You cannot apply the rods. It's very difficult. And now see what is happening. Both are almost at the same level. In sagittal plane, it is so easy to put up your rods. We put up our rods and simple tightening will reduce. And you see the AD complex is totally reduced. The canal is opened up. Okay. So this is how it helps. Because for, getting the full correction, our concept is to put this screw head close to the surface of the lateral mass. Here we have put it very close and we apply rods, it automatically lifts it back and up. Okay. Let's go again forward one slide, please. Okay. So there are, many examples that we have put inside that you can see in between. Rakesh, I think you just go through these slides in between. Okay. This is one case. Sometimes you may require, to apply some sort of hybrid fixation. It's not necessary that you stick to a single plan. Like in this case, there is only one single vertebral artery. Okay. And that is making a loop through the joint. Most of us, get afraid that this is very dangerous scenario, but it's not. When you see a loop, okay, don't be afraid. Loop are the easiest to mobilize. If it would have been a straight course, then it's a matter of concern. Loop, you can very easily mobilize the loops. Okay. So how? What I did, I just mobilized the VA. One side, my reduction screw and the C2 pedicular screw is taking care of the reduction. It completely reduced the BI and the AD component. And then what I did on the opposite side, you see, I mobilized the vertebral artery loop, and instead of putting a polyaxial screw and rod complex, I utilized the Goel system. Okay. That is lying, the plate is lying beneath that vertebral artery loop. So there are no chances of irritation or compression of the vertebral artery on that side. And we got a very beautiful correction. You can see the syrinx is almost resolved. Okay. So you may require to adopt a hybrid philosophy. It's not necessary to stick to a single philosophy. It's not always you want to go for C1, C2, one type of fixation. You may adopt a lot of techniques. So if you are entering inside the theater, you should have your plan A, plan B, plan C ready all the time. Okay. This is one case of rotatory AD. Now see, this is the scenario. Okay. If I would have not used this reduction screw, my C1 screw head would lie somewhere here. Okay. And that is the C2. It is a fixed rotatory AD. Okay. Post-traumatic. You have to adopt unchecked maneuvers of pushing your C2 down using your thumb. But I applied all 4 screws and then I put my rods on both sides. Simple, gradual rod tightening, 2 mm here, then 2 mm there. And I achieved a very beautiful correction. I broken the extra head length. Okay. And we got a very, very beautiful correction. Okay. You got the concept? Okay. See, this is another case of neglected C2 fracture. That we'll discuss in between. Okay. These cases we'll discuss in between. And yesterday we were, somebody was asking me about the vertical joints. Is this screw is able and good enough to, to correct the BI and AD component with vertical joints? You can see totally vertical joint here. Okay. The concept remains the same, that you have to pull your C1 back and up. Okay. And see how beautiful correction we have got by simply doing the C1, C2 fixation.
Mouse.
That is the intro picture of that case that I have shown. Again, you can see after tightening the rod, very beautiful correction. And that is the post-op, that is the pre-op. This is again one case where you can see there is a segmentation anomaly of the C2. There is only one vertebral artery that is passing through that free floating segment of C2. And unless you remove that part of the bone, you cannot achieve reduction. You have to. It's not, possible always to, the skip dangers to the vertebral artery. There are scenarios where you have to deal with it. You have to learn to mobilize your vertebral artery, almost vertical joint on both sides. This is the free floating segment that is lying here. Okay. This is the bone segment. And only single vertebral artery that is passing through it. Unless you remove that bony segment, you cannot achieve a reduction. Okay, so we made a 3D model of that. This is the bony segment, only existing vertebral arteries passing through that. Okay, and we completely mobilized the vertebral artery, drilled that bone segment off. And next slide. Next slide. Okay, we completely mobilized the vertebral artery. We drilled that bony segment off, make an entry point into the C1 lateral mass. And now you see this segment is gone. Okay. This segment is gone. And we achieved a very good correction over here. This is the pre-op, this is the post-op. There are instances where your post-op radiology is not that good, but still you get away with very good clinical outcome. This is a 6-year-old boy. Okay, my initial plan was he came to us with neglected C2 fracture that was malunited. So our initial plan was to go and do transoral decompression, remove this part, and then do posterior C1 C2 fixation. One of my residents pointed out during the rounds that child is only 7, his weight is only 7 kg. He was having this trouble for almost 1.5 years and is neglected from a rural setting, and he was only 7 kg weight. So obviously, my plan was different, but when he told me, sir, he is only 7 kg, I refrained from doing transoral surgeries. You cannot do transoral surgeries in obviously their pharyngeal wound will give up. So I only did posterior C1 C2 fixation in that child, and you see only that movement, reduction of that much space in the post-op has opened up the canal beautifully. And you can't believe that boy, spastic, has started walking and running inside our ward only in 3 days' time. Okay, I have not done anything else. I simply sent him home, and right now he's like I think 9 years, it's 3 years down the time, and he's completely fine. So it's not always necessary that you stick to a single plan. You have to change accordingly as per your patient profile also. Okay. I think I have covered all the pertinent points, and now we should discuss our case. Okay, so go for case 1. Okay, I have shared the radiology on the group. All of you have seen it. Okay, so what's the plan? You simply tell me, Pankaj, what should be done? Okay, मैं radiology पे जाता हूँ सीधे. This is the MRI that I have not shared. This is MRI, nothing special in that. Okay, there is only compressive pathology, no ACM, no syrinx. Okay, it's simple case of BI and AD, and this is the mid sagittal cut, and this is our 3D. Okay, this one side, the vertebral artery is very thin. Okay, it's not causing any problem. The only dominant side is on the left side, and that is the extradural pica. Okay, so now tell me what's the plan.
Sir,
आराम से बैठ के बता यार.
Sir, this is having a basilar invagination with AD.
Yes.
And compression is quite severe along with myelomalacia at the level of cervicomedullary junction.
Yes.
we have got just a single vertebral artery on the right side, I think.
Mhm.
And left side is hypoplastic.
Yes.
And there is a,
This is the left side.
Ji, sir. And there is anomalous origin of pica as well from that right side only.
Yes.
So
this
we will
outcome.
have to be very cautious for that.
Hmm.
Left side is no problem, sir. We can go for C1 and C2.
Right side.
Right side, we can go for C1 and C2.
Good.
Left side, we will have to be careful regarding the origin of this vertebral artery as well as the pica.
Good.
So during joint manipulation, it will be, we will have to be more cautious.
Sure. So my initial plan is to, put C1 lateral mass and C2 maybe pedicle, maybe subfascial screws here, depending on what comes out during surgery. Okay. And then I'll try to reduce it on right side first by putting up my rod. And then automatically I'm thinking like that. Okay. That's my plan A. That automatically will, distract and reduce the joint on this side also a bit. And my dissection will become a lot easier. And for putting up the C1 screw, I can utilize that much space. Okay. Because I want to remain close to the joint. Maybe I'll drill a part of C2 this process, a part of C2 facet here to not go upside and avoid any chance of injury to the pica. Okay. And I'll try to negotiate the joint somewhere from here. Okay. That was already distracted by C1, C2 screw maneuver here. So I think I will be able to put C1 lateral mass and C2 screw here also. But as you have said, obviously there is a danger. It's a loop. So loops are easily movable. I think I will be able to mobilize this, pica complex little bit lateral and up. And I'm sure that I'll get a, very beautiful opening of that C1, C2 joint also. But again, if you are feeling not comfortable enough and your one side fixation is giving, good intra-op reduction, you can always supplement it with your occipital plate and cross translaminar screws. One side C1, C2, that will do the job. And then you can supplement it, putting an occipital plate and both side translaminar screws. There's a new concept of 3-point fixation that is coming around. So if you are dealing a difficult BI and AD case, a simple C1, C2 fixation, I have seen this thing. They are coming to us after 2 months, 3 months with settling. Even C1, C2, not only occiput C2. So if you are dealing with a difficult case where the BMD or the bone is brittle, the bone quality is not that good, it's always better to do a 3-point fixation. Apart from C1, C2, occiput lower down cervical or occiput cross translaminar C2 fixation. Okay, so 3-point fixation is a new concept. We are trying to give more details in our future publications. So that is one thing. And if you see,
sir, one question is there.
Sure.
On both the sides, the foramen transversatum at the level of C2, it is looking a little bit medialized.
मैं उसी पे आ रहा हूं, दिखाता हूं. So C1 is quite good, both side. Okay, C1 is quite good. Lateral masses are quite prominent. You can easily put your C1 screws over here. Okay. And interestingly, the problematic side, okay, that is the left side. The problematic side has a very good C2 pedicle. The problematic side. This is the left side. This is the right side where our vertebral artery is, hypoplastic, non-dominant. And here the pedicle is at stake. Pedicle is not that good. But on the problematic side, pedicle is very good. If it was reversed, the pedicle is good here, then my job was, very simple. But it is a problem. So what I am planning, I'll show you. Joint orientation is like grade 2, it's almost 130 to 160, both sides, but it's not a big deal. We'll deal with that. My plan is, There are some people who have developed a technique of putting up, a mixed match of subfascial and pedicular technique. They say this medial part of the vertebral exits foramina. This part, because vertebral after origin from the here usually turns laterally. Okay, so this part is quite good to put up your screw. So on that side, what I am planning, I will drill and make an entry point from here. Okay, I will feel it during surgery. I will make my entry point somewhere here and I will put in a pedicular manner. That will give a very good purchase. And I will try to create a distance between my C1 screw head and C2 screw head in sagittal angulation, so that when I apply my rod, it will correct. If I'll put more subfacetally, I mean, if I'll put my C2 screw from here, in sagittal angulation or in sagittal plane, both screw heads are, like very close to each other, and my reduction maneuver will not work. So in sagittal plane, I have to create a distance between my C1 screw head and C2 screw head, so that when I apply my rod, okay, reduction maneuver will happen. For that, the best screw in the C2 is pedicle. I have told earlier, yesterday also. But here the pedicle is quite thin. So maybe I'll try to put it from somewhere from here. Okay. And I'll try to push my C1 screw as close as possible to the posterior surface of the C1 lateral mass. So that's the plan. So any doubts, any questions? चलो तो स्टार्ट करते हैं. Yes, sir. Sorry, discuss topic. चलो कोई भी क्वेश्चन मत आए, just communicate with Rakesh.
ठीक है ठीक है मतलब पहले बार मैं प्रिंट ही कर रहा हूं.
Hello, Arun, anyone from theater now? Hello, Arun,
Yes, sir. Yes, sir.
are you able to hear?
Yes, sir.
Yeah, at what stage you are?
Sir, we are opening the case from
Okay.
occiput to C4, sir.
Okay, that's fine. Sir is joining in 5 minutes.
Yes,
Okay,
sir.
okay. दिवाकर मैं जो बेसिकली डिस्कस करते हैं वो कहाँ मैं इसको उस पे लगवा लैपटॉप कोई बात ये सर का प्रेजेंटेशन आता है तो वो लगवाओ तो कुछ केसेस है ना जिन पर डिस्कस करते रहेंगे. अच्छा ठीक है ओके बड़े वाले ठीक है. तो चेंज कर रहा है ये पूरा चेंज हुआ इतना ही. ये कौन सा प्रेजेंटेशन सर वाला KGMU हमने सर ने प्रेजेंट किया वो वाला अरुण में करा दे लेकिन वो चूंकि सर बोलते कि एक्सपोज करने के बोलो ना सर विल बी देयर देन दोनों वो डिस्कस कर ये तो इसी केस का है जो अपन कर रहे हैं अभी तो उसी का था ये वाला केस
हेलो हाँ बॉस हाँ हेलो बॉस आवाज आ रही
हेलो
ये लैपटॉप क्या प्रेजेंटेशन है, से चल सकती है ना वीडियो इस पे। दिवाकर, yeah, please give me the pen drive. Slide change कर दे। इधर है कि उधर? इधर ही है ना? आओ, गुड। ये ये कि ये जो बाहर है ना, बाहर यहाँ पे केवल उससे इंस्ट्रूमेंट और ये दोनों अगर रखवा दोगे तो इट विल बी वेरी नाइस कि somebody wants to like do hands on so they can get demonstrate there or you can utilize some other space because मैडम लोग यहाँ पे 12:30
मैं तो यहाँ इसलिए लाके रख दिया था मैंने कहा अगर
हाँ कभी
आप लोग
दिखाना
को
होगा तो
demo
ये
दिखाना
हाँ, लेकिन वो टेबल वहाँ लगाएंगे ना अपन थोड़ा तो
वो तो मैं कर दूंगा।
इंस्ट्रूमेंटेशन के लिए
मंगा रहा इंस्ट्रूमेंट एक्चुअली एक सेट ऊपर जमा है दूसरा सेट ऊपर।
हाँ वो हो गया। चलो पर दिया बाकी सब कंप्लीट। चलो गुड गुड 12:30 बजे आएंगे टेबल। क्या हाल है? गुड मॉर्निंग। गुड मॉर्निंग। और थकान उतर गई? लगाओ। इसमें वो हाइब्रिड वाला पेशेंट है।
हाइब्रिड वाले पेशेंट
हाइब्रिड वाला है ना? चलो सर जो भेज
नहीं, ये 4 पेशेंट्स है, वो पेशेंट्स है जो हमने इस केस के मतलब कॉन्क्लेव के लिए रखे थे, वो 4 सर ने बताया नहीं।
Hello? Hello? Hello?
Hello.
Rakesh, are you able to hear me?
Yes, yes.
Okay, good.
Please shift this on the theater one.
So
Visual.
Vipin and Arun is opening the case, and I
Yeah.
think they have opened it. They have exposed it right from, occiput. So,
Sir, actually, your voice is coming very minimal. I will ask to adjust.
is it good? Hello?
Yes, sir. We are doing some adjustment for voice. थिएटर से जो आ रहा है वो कम है.
इसका एक्सरे मंगा देना चितेश, जो प्री ऑफ एक्सरे.
Yes, visual is fine, but the
Rakesh, are you able to hear me?
sir,
Are you able to hear me?
no. They are still doing some adjustment. विजुअल बहुत डार्क है.
माइक में तो नहीं बोल सकते.
और विजुअल भी बहुत डार्क है ना.
हेलो.
हाँ.
हेलो. Hello.
Yes, now it's better now.
Better?
Yes.
So Dr. Kuldeep is here, and he is, where is Dr. Kuldeep?
Actually, everything is dark. Yes. Now it's fine. Good.
Now it's fine?
Yeah. Perfect.
Okay. So one of my colleague is available on mic itself here. So maybe if there is any problem, he will take up the questions.
Yes.
Okay, and he will answer.
Yeah. Now voice is better.
So we'll develop a two-way communication.
Perfect.
If you're not able to hear me,
Yeah.
Dr. Kuldeep is here, Dr. Farhan is here.
Yeah.
Okay.
Yeah.
And they will communicate. Okay.
Okay.
So Dr. Kuldeep is here. Kuldeep,
Yeah.
If they are not able to, establish a two-way communication with me, you are always able to,
Yeah.
free to answer from that mic itself.
Sir, just a one request. Actually, all the colleagues want to see some adjustment, like a theater adjustment where position and everything. So,
Focus on one important thing first,
yeah, please.
that, where is our camera? Okay. So you see, guys, before starting your surgery, okay, you got your MRI, you got your CT, okay, and one important thing that we are missing up is our X-rays. Okay,
Yes.
and why it is important? That I tell you why it is important. Because sometimes your whole surgery is based on fluoroscopy, is based on X-rays. Okay,
Yeah.
and during surgery, sometimes you lost up where your lateral mass or anterior tubercle is. Okay, in CT
Yeah.
scans, it's very easy to mark, but in X-rays, it's a bit difficult. So before going into surgery, it's always a good exercise to have an idea of where your anterior tubercle is. Okay, so that you may not get confused during surgery.
Yes.
Got it?
Yes.
So that is our anterior tubercle. Okay,
Yes.
so that is my anterior tubercle that I will try to target while putting up my C1 lateral mass screws.
Yeah.
So this is very one,
Yeah.
this is one important tip that you must keep in your mind, that before going into a difficult CBJ case, always have a look at least lateral films of CBJ.
X-ray.
Okay.
Yeah.
So lateral films, very important. You should always see that before going into, especially in difficult cases, to have an idea where your anterior tubercle of C1 vertebral body is. Okay, so C1 anterior tubercle is lying somewhere here.
Yeah.
And now we will try to see it during surgery also.
Yeah.
Got it?
Yes.
So this we have already discussed.
Yeah.
And now we proceed into surgery. And Rakesh, what you were saying before?
Sir, actually, they want to see the arrangements in the theater. So just ask cameraman to. Yeah.
So first I'll tell you about patient position.
Yeah.
So we put our patients at bolsters, like in a routine case. Okay. We
Yes.
try to avoid compression over the chest and upper part of the abdomen,
Yeah.
so that the venous chances of venous bleeding are not there
Yes.
and venous pressure is not there.
Yeah.
Our head is almost neutral,
Yes.
and we have applied the tongue with 2 kg weight,
Yes.
just for sake of, maintaining the stability during surgery.
Yeah.
We don't want to achieve reduction using the tongues.
Yeah.
Okay. It's
On the
just to
horseshoe.
maintain the stability.
Yeah.
And this is the position of our C-arm.
Ask cameraman to zoom out, please.
So show the C-arm.
Yeah.
From here.
Yes. Whole of the structure arrangements.
यहाँ ले आके.
Yeah.
आप एक बार ये पूरा setup देखो.
Go back. Go back. Yes. Perfect. That's
Okay.
good. Yeah.
So this is our C-arm.
Yeah.
Okay.
Yeah.
And I will stand up here.
Yeah.
Okay.
Sure.
This is my projection of C-arm.
Yes.
That I will see. And from opposite side,
Microscope.
my
will come.
microscope will come.
Yeah.
The nursing assistant is standing here.
Yeah.
Right to me.
Yeah. Yes.
And that is about the whole OT setup.
Yes. Beautiful, sir.
Patient is on,
Yes.
the neuro monitoring.
Yeah.
So anesthesia guys have not given him relaxant.
Yes.
Okay. And we'll
Yeah.
keep doing MEP during our correction maneuvers.
Okay.
Okay,
So just a quick question. So we will be checking with the while correction only or while the instrumentation?
No, not while instrumentation. When
Yeah.
I will, when I will apply the rods,
Yeah.
then only I will check it. Okay. It's
Okay.
not required before.
Okay. Okay.
Okay.
Thank you.
I have taken pre-correction MEP.
Okay.
Okay. MEP ले लिया है ना? They have taken MEP. Maybe in between also I'll take 1 or 2,
Okay. Just check.
MEP pictures, and I will keep you informed.
Okay. Any question right now?
Sir,
regarding the-
I have got one question.
Yeah.
Okay.
Do you keep your navigation system ready for the surgery or you don't use it?
No.
No, I don't use navigation because I don't have OARM. Okay.
Yeah.
So for CVJ navigation,
Yeah.
it is not possible to do on C-arm. 3D C-arm systems are not good enough. Hello.
Yes. Yes. We are hearing. So I will just let you know, Pankaj, in 2018, Medtronic person asked me to do C1, C2 with the navigation. Okay. So we have a 3D C-arm. So usual sort we take all these things. It will take around 1.5 hours. And then we started doing. So ultimately the result was
यहाँ पे पहले वो
it is
लगता था
much,
boss,
much,
पैर
much
से दबा
better
के
to
हाथ
do
बोलने वाला,
anatomical
लेकिन वो
Then navigation. And then they took all the pictures, like 45 pictures, to show other guys in the country that we have done C2. Is it possible to put the C2 pedicle? It is good. But honestly, as a surgeon, performing surgeon, I will say, don't use. Anatomy is the best. Is the like straightforward screws are there. So you don't need to do, take all the 1 crore, 3 crores and you are doing all this.
अच्छा, अरे monitoring.
Sorry?
मजा आएगा तो, और सामान भी अच्छा मिलेगा कुछ.
That's right. In the very complex
वहाँ
cases,
तो मंगा लीजिएगा.
if you feel it is fine. Otherwise, on routine basis.
पर जो आ जाता है ना, आ जाता है.
But for demonstration purpose, or
Hello?
some complex cases we are using.
Hello.
Yes, sir.
Okay, so about the navigation.
Yeah.
Navigation in CVJ and cervical spine is good enough only with, real-time CT scan.
Yes, sir.
Okay, so you
Agree.
must have OARM at least,
Yes, yes.
or some mobile CT scanner.
Yeah.
Because otherwise the pedicles and the lateral mass, the pars is so thin that even a problem of 0.5 mm can create havoc.
Yes,
Okay.
yes.
So unless
sir,
you
there is
have a
one.
real-time CT scan or OARM inside your theater,
Yeah.
there's no benefit of putting up navigation there.
Yes, sir. Sir, there is one question from Rahul. Rahul, please go.
Yes.
In many cases, you're done foramen magnum decompression.
Hello, Rakesh, I'm not getting you.
Okay, just a minute.
Hello.
Please
Sir?
on mic. Your mic is not on most probably. Yeah.
Hello.
Yeah.
Sir, in many cases, you have done foramen magnum decompression. So in the PPT I have seen. So when you will actually do it actually, because we are confident on our reduction maneuver. So is foramen magnum decompression? should be
Okay,
done?
so if the patient is, too much compromised, if his clinical status is not good enough, then only in that cases, and when I accept, difficulty during surgery, that I have to do a lot of maneuvers, maybe then I'll, start with foramen magnum decompression first. But in this case, I am sure that I will get, very correction very easily, and I'll do foramen magnum decompression later on, if I'll feel the necessity of doing that at all.
I think there is a simulation, so maybe require with the usual like
Because all my maneuvers,
Yeah.
they are going to open up the canal. When the semen will come back, it automatically will open up the canal.
Yeah.
Okay.
Yes, sir.
So maybe I'll do it later on. It's not required right now.
Honestly, Rahul, it is like a
But
clinical.
but for
Okay.
safety, but for for
If you feel,
newcomers, maybe you can do it.
yeah. So that's why, sir, I was telling them, try to do it early. It will give you a leverage for
Maybe
more
if
than 5
you want
manipulation.
at the start.
So
but
be a safer side.
I usually don't do it at the start,
Yes, sir.
because I just don't want to, waste my energy
Before doing the main stuff.
before doing the main
Yes.
thing, before opening up the semen situ. It's
Don't
an
waste
exhaustive
time in
thing.
foreplay.
And if you want to do it, I let my, residents and my fellows to do it before venturing into the semen situ joint exploration. But for me, I always go to the semen situ. That is the most important thing. But
Yes,
you
sir.
can started with, foramen magnum decompression. No problem.
Yeah, Pankaj, please.
Sir, after final positioning, do you take a C-arm shot to confirm the proper alignment, or you start your surgery?
Pardon?
Sir, after your final positioning,
Yeah.
do you take the first shot from the from your C-arm to check the alignment, or you go for surgery?
See, it's a pretty fixed AD, okay? So the X-rays before, okay, when the patient was conscious, X-rays taken before, it is very clear that this is not reducing. Okay. So when you put patient under general anesthesia, don't try to correct it by putting your heads in different positions. Got it?
Yes.
So it's an unnecessary maneuver. You should not do it, because now the patient is unconscious. You can do it whatever you want with his bone, but patient will not be able to answer what is happening. So any maneuver, any, flexion extension maneuver during surgery is not going to open up the canal. That is pretty sure. If it is not opening up before, it will not open up during surgery unless you open up the joint, unless you remove the ligaments. Okay. So it's better to, tackle. It's better to tackle, the ligaments to joint first, and then only try to reduce your AD. Got it?
Yes, sir. There is one request for cameraman. It is very blur, and we are not able to appreciate the structure. So he can
So,
adjust some.
okay. I will, explain and I will orient you.
Yeah.
This is our occiput.
Sir, sorry,
Some-
sir. Actually, we are not able to appreciate properly here. So cameraman can adjust some contrast so that it will be much.
Okay. Take the microscope.
Yeah. Okay,
Sir,
sir.
take up the microscope.
Okay.
लो microscope.
Yeah. इसमें appreciate नहीं हो रहा ना ज़्यादा. अच्छा नहीं हो. Yes. Okay, okay. Okay, okay. People. Yeah, thanks.
Thank you.
Please, please. Rahul Boss is here.
Sir, good morning.
Morning.
Sir, as you said earlier that there were some patient who came with settling.
Yes.
So do you have any predictors that couple of these patients may come with settling and we should go for a 3-point fixation?
Not,
or-
proven predictor, obviously, but now I have a practical feeling during surgery where, there is too much strain over my construct. There is no objectivity to it. Okay.
Yes, sir.
There is no objectivity to it. But wherever you feel that your construct is under too much strain, wherever you feel that your construct is under too much strain,
Yes, sir.
okay,
Yes, sir.
you can always plan for a, sort of 3-point fixation.
Thank you, sir.
Dr. Kaf is there, I think.
Yeah, we are here. We are taking all questions. Don't worry,
So
sir.
Dr. Kaf is, also in, he's done lot of CVJ surgeries. So I think lot of questions he himself will answer.
Thank you so much. I don't think I'm in a better position to answer these questions because of your experience. And
No, we'll supplement. The experience will be supplemented by
it
sir.
can be only supplemented. Yeah.
Okay, so I have taken up the microscope for better visualization.
Yes,
Yes,
now
sir.
it's better.
Okay, is it
Yes.
better now?
Yes.
Okay, good.
Now orient, please, first. Yeah.
Yes, sure. And my colleague, Dr. Kuldeep is here. Now onwards, he will take up every question. Okay,
Yes, sir.
and then I'll try to answer. My senior Professor Rajiv Bose and my friends Farhan and Khurshid both are here. Okay. So, number 4. So this is occiput,
Yes.
C2 process,
Yes.
C3 lamina,
Yeah.
C4 lamina.
Perfect.
In C1, C2 scenario,
And this is more for left side, sir.
this is left
Yeah.
and this is our right.
Yeah. Perfect.
Okay.
Yeah.
So in a normal scenario where I plan C1, C2 fixation, my opening is, from subocciput till C4 spinous process.
Yes.
Okay. That is
Yeah.
the standard opening.
Yeah.
And they have opened into midline, subperiosteal manner.
Yeah.
Okay.
Yeah.
And all the posterior elements are exposed now.
Yeah.
Okay.
Yeah.
Just don't try to violate joint of the C2-3 or downwards. Okay?
Okay.
Don't try to violate this.
Yeah.
Okay.
Yeah.
So my area of concern is now first, because right side, the VA is hypoplastic
Yes.
and it has a normal course.
Yeah.
So I'll try to go on the right side first.
Yeah.
And then I'll see what is happening on the left side. Okay.
Okay, sir.
Sure. So that is how we are mobilizing. I believe in, slow dissection.
Yes.
So
No heroic attitude here,
Good enough.
please.
Colorado. Okay, so this is the Colorado needle I am talking about.
Yes, sir.
Okay.
Yeah.
So see how easy it is right now. I do my dissections using this.
Yeah.
This is pretty good. So patient is under, there is no relaxation.
Yeah.
So maybe he'll jump a little bit when I coagulate the muscle.
Yeah.
Bipolar.
Yes. The second. Yeah.
I will clear this soft tissue
Yes.
and then I'll reapply my retractors so that the soft tissue, will be all
So
mobilized.
C2, then we are going towards the up. So, yeah. So this is like there is a few some important points. So when you have to use mono, when you have to use bipolar, it should be very, very clear. So just follow like, okay, mono by switch. Yes, yes. When you are confident, like it is bone. So then, yeah.
Okay, so तुम्हारे पास कर्ड वाला है क्या? कर्ड मोड करो. Bipolar number 4.
We are trying to find out the joint. Yeah.
Okay.
Yeah.
So now I will have idea where my pedicle is.
Yeah.
And then I'll keep dissecting over there only. है ना?
Yes, sir.
So number 4. This is the lamina, superior border.
Yes.
And I'll follow it. And this is our, pedicle is.
Yeah.
Okay.
Yeah.
So this is my pedicle of the C2, which is going anteriorly. And I'll try to follow it. Okay.
Yes.
Now. And I'll clear all this soft tissue from, the C1, C2 joint.
Yes.
I'll just follow the bone. And
Yeah.
that is required.
Yeah.
I'll coagulate. There's no fear of vertebral artery. Vertebral artery is quite lateral here, even the hypoplastic one.
Yeah.
Okay.
Yes, sir.
And then I'll cut under the maximum magnification. I'm going for maximum magnification now.
Yes.
Okay. And
Yeah.
now I'll cut monopolar. Okay, good. अभी स्ट्रेट वाला ही दे दो, अंदर जब काटेंगे तो काटेंगे.
This is the area where you need to have maximum concentration.
Yeah. And its best demonstration is like when you are using the magnification, when zoom out, zoom in, mono, bipolar. So this is the main thing to learn here. Yeah.
Okay, so if you are encountering a hard structure that looks something calcified,
Yeah.
okay, now
Yeah.
that is your root.
Yeah.
This is the root.
Yeah.
Okay, this is the root.
Yeah.
Because I was not able to cut it using the monopolar.
Yeah.
Okay, maybe, and I am entering inside the joint.
Yeah. You can easily appreciate the joint if you're there. Yeah.
And one thing you must remember that if you encounter any bleeding, okay,
Just back.
don't leave it on anesthetist.
Yeah.
Control it first.
Control it first.
Control it first. Okay. So this is all C2. This is all C2. Okay.
Yeah.
And now I am cutting it completely, this root. I am clearing the whole soft tissue. I have no fear here. On the right side. Monopolar.
And this is the technique to cut.
Yeah.
With the collar.
Yeah, yeah. Don't go into the gutter, okay? Your exposure should be from above. Do some bit of subperiosteal dissection. This is your root, okay?
And then you'll cut.
And then you cut. This is
Yeah.
your root,
Yeah.
okay? If there is any confusion, sometimes you get confused whether it is a vertebral artery or a root. Okay. For new people, they get confused sometime. So take insulin needle.
Yeah.
Take it and see before cutting. Okay.
Yeah.
There are scenarios where you get confused.
Yeah.
Okay. So take an insulin needle, pick it and see.
Yeah.
Okay. It's always better. But since I'm pretty sure, so now I'm cutting it. Okay. I'm gonna hill right.
Sir, can I request you to shift some microscope setting so that it will, the working area will come in the center. It is on the corner,
Sure,
top
sure.
corner.
Sure,
Okay.
sure. Is it better now?
Yes, perfect, sir.
Okay, I will, demagnify it a bit
Yeah.
so that you will able to appreciate it. Okay.
Yes, sir, please.
So this is the root. Okay.
Yes.
This is the root.
Yes.
Okay. Now I'm cutting it.
Yeah.
Roots are difficult to cut using monopolar because they are a bit calcified.
Yes.
The wall is a bit calcified over here. C2 is a very big prominent root.
Yes.
So I am cutting the root. Bipolar.
In between, always control with bipolar. A small bleeder can distract you. Always control and then proceed further. Yeah.
Mono.
Yes, it's fine. If you want to be a like neurosurgical technique, so burr, scissor, so, but it's fine. Actually, then these kind of patient was everything is like so anterior.
See, I am removing a part of the nerve root, not simply cutting it.
Yeah.
So that I will have a very good working space.
Yeah.
And I will
then-
not,
then-
fight
sir.
with, the cut ends of nerve root all the time.
Yeah.
Okay, so I am cutting it laterally. And
Now it is
I'm
cut.
cutting it medially.
Yeah.
And I am creating a good space because this screw will remain,
Yes.
my strength till I will be able to put screws on the other side.
Yes.
Okay, so I'll try to put it in best possible manner.
Yes.
Okay. Maybe I have to resort to plan B. Then also, this will become the only source,
For realignment.
that will realign it. Okay.
Yeah,
So I'll
realignment.
try to put it in best possible manner.
Yes, sir. Agreed.
Okay.
Yeah.
So I'm clearing the whole, soft tissues here. And this is the projection of the C1.
Yes.
Okay. The
Yeah.
lateral projection of the C1.
Yeah.
I will now realign my microscope again,
Yes.
more cranially.
Yeah.
And
Yes. Good. Yes, sir.
okay.
Yes, sir.
And mono.
Yeah. That's it is lateral. We are going up. A simulation is there, so we are trying to find out one. No, this is it is hypoplastic. Everything is lateral.
Number 4.
So don't try to look. Don't try to look. Yes, you just follow the bony anatomy. Don't try to look for vertebral. Honestly, कोशिश करोगे तो injured होगी 101%.
Okay, so this is the soft tissue of the joint. This is the capsule of the joint.
Yes, sir.
Okay, I'll just remove this to make everything clear.
Yes.
Mono.
So at what setting cautery is working now? That is important.
So the setting is
Yeah. Is 35 or
15.
30?
Okay, 15 for coagulation,
Yeah.
and for cutting it is 25. Okay,
Okay. And what is mono?
mono is 25.
25. Okay. This is very.
प्रणाम आइए दादाजी आइए
Now I am removing the soft tissue from the joint.
Yes.
See, the C1 is very anteriorly dislocated.
Yes, sir.
So see how constrained space is this? How much constrained is this space? Okay,
Yeah.
and
We are basically over the joint trying to find out the lab.
हमें लगता है इनको घूमना
Yeah. This here.
number 4.
Yeah. But the main thing is this
Fine,
is
fine.
assimilation. This is not normal. So when assimilation is there, so ideally है कि normal से जो normal आपके anatomy है उससे abnormal जाओ. Yes, yes. And if you are doing decompression first, so you can come from like medial decompression, then lateral. Yeah. Yeah. और उस पे focus करोगे अगर, so you will see like assimilated everything is coming just up. So, no, no, no. You just fill it and then just rotate it. Yeah.
छोटा section देना सर.
Yeah. 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 So just rotate it. You will see the.
So this is my lateral mass.
Yes.
Okay, I am now able to get a peek inside, and
What's your
any confusion in that? To anyone? So far, any confusion?
No, sir.
Okay, so
Any
my
question?
lateral mass is exposed now.
Yeah.
And now I'll ask my assistant to have a number 4 dissector मोटा वाला. Okay,
Yes, sir.
Vipin is holding this
Yeah.
here.
Yeah.
Okay.
Yeah.
And I'll try to expose that in full length just for sake of demo.
Yeah.
Okay, you need not to,
Mhm.
because you have seen your entry point.
Yeah.
Your joint is there.
Sir, just a quick request. If you put a number 4 in joint, so
Sure,
that
sure.
yeah,
Now I'm going to do it.
yeah,
Okay,
please.
I'll prepare the joint.
Yeah.
Okay.
Yeah.
So that
It's
is
like this.
your joint. Okay.
Yes, sir.
I'm opening it.
Yes.
Are you able to see
perfect.
it? So this is the joint. Okay.
Yes, yes, perfect.
And I will drill a bit here.
Yeah.
Okay. To remove a part of C2 superior facet, the posterior aspect, so that I can put my screws easily. Okay.
So where, just you can give a.
And see, here is the exit of the vertebral artery.
Okay.
I'll show you.
So do you prefer to drill the joint first and then put in the screw, or you put the screw and then drill it?
I'll prepare the joint.
Okay.
I'll prepare the joint. Then I'll make all the trajectories for C1 and for C2.
Okay.
And then I will put some bone graft in between.
Yes, yes.
Then I'll put my C1 screw and C2 screws, then tighten it
Okay.
after, preparing the joint.
Mhm.
And after final correction, I'll again resupplement it with lot of, natural autologous as well as artificial bone graft.
Okay. Perfect. Perfect.
Okay.
Perfect.
So here is, the vertebral exit for Amina.
Yes.
I am poking my, micro dissector inside,
Yeah.
but I need not to because I have a feel now.
Yeah.
So this is my vertebral artery exit for Amina.
Yeah.
Okay.
Yes.
So this is my vertebral artery exit for Amina. My C2 screw will come somewhere from here.
Yes.
Okay.
Yeah.
And C1 screw is, it's not much rotation in this case.
Yeah.
So my C1 screw will go pretty straight,
Okay.
or maybe with 5-degree medial angulation.
Yes.
Okay.
Yeah.
And now I am able to, feel the lateral aspect of the C1 lateral mass.
Yes.
This is the lateral aspect.
Yes.
And this is the medial aspect.
Yes.
Okay, I'll not expose it, but I am feeling it. Okay.
Yes.
So this is the medial aspect. Okay?
Yes.
So my screw will lie somewhere here.
Yeah.
Got it?
Yes, sir. Perfect.
बर दे दीजिए. ये पिन तुम लगा के नंबर 1 रखो. नंबर 1 दे दो. कटिंग दे.
Yeah, we will use.
3 mm का केज प्रिपेयर करके दो मेरे को. 3 या 5 mm. 5 mm.
Can you please show the burr so everybody
sure,
is interested? So
Sure.
Yeah.
ये पिन पकड़ो बताना.
no, it's match is cutting. Yeah. Yeah. You can.
I have taken a simple 2 mm burr right now.
Yeah.
Okay, because I am going to drill this part only right now.
Yes.
Okay.
Yes.
So one important trick while you are drilling this part, don't come midly.
Yes.
Okay. Otherwise, you will, weaken the already thin pedicle.
Yeah.
Okay.
Yes.
So drill where it is actually required.
Yeah.
Right?
So lateral drilling is mainly thing.
Lateral drilling away from the pedicle.
Yes.
Away from the canal.
Yeah.
Your lateral side is protected by this number 1 penfield.
Yes.
And medial side, I always put my section. Okay.
Yeah. Yeah.
Somebody was asking me
Yeah.
yesterday, I think Avinash was asking that question yesterday, that for preparing the joint, whether you put traction. See, that is how I prepare my joint.
Yeah. So a small osteotomy.
I drill a part of the C2 and I'll enter directly inside the joint. Okay.
Yes.
You need not to. Mono. Without any unnecessary maneuver. Now I'm removing the soft tissue again.
Yeah.
Of the capsule.
Yeah.
Okay.
Also, you can easily appreciate. Yeah. So
And-
everything is in front of you and cutting. You can cut everything. And then you can drill with, like, you can use diamond bar to just prepare, or you curate a small curate, it's fine. So you'll just.
And here is the
No,
lower
we are not
point
doing it.
of the lateral mass. Okay.
Just show you and then we'll.
I'm clearing all the soft tissue from inside.
Yes, sir.
Okay. I'll realign the microscope
Yeah.
so that I should have a parallel alignment with my joint now.
Yes.
And that is, this is a joint.
Yeah.
Okay.
Yes,
So
sir.
this is my joint. Okay. विपिन थोड़ा खींच कर रखो. हाँ, soft tissue. मोनो दीजिए. हाँ. Hello? Okay, so that's how I prepare my joints. Okay, so I am going inside. Okay, this is a 5 mm case.
सुन लिया प्रिया
Rakesh,
अपने
are you
हिसाब
able
से
to
मत चला
listen?
कर
Yes, sir.
Okay, this is a 5 mm case.
तूने एकदम से डिसाइड किया कि
Sections
परांठे
on
बना
both
रहे
sides, and that is going inside and outside couple of times. Okay, and removing all the soft tissue from inside.
अरे ठीक है मम्मी यार,
चल
इतनी
ठीक है कोई
बड़ी
बात
गाल
नहीं चाय
को
पिला रही है ना
हाँ ठीक है, वही तो बोला ना, वही कह रहा हूँ कि जेतरी ओतरी रियल में एतरी प्रॉब्लम कौन थी इंडिया जेतरी सोच रहा था वो दिख इंडिया वे सुटो थी ना तो तू चके हाँ माप थी हला या मुझे लाया बढ़िया
So with the help of the 5 mm in interjoint spacer cage and the serrations, the joint space is prepared and all soft tissue is taken out. So the fusion chances of
Okay,
fusion
so I am
may
preparing
increase.
a good space.
Yeah.
For putting up my bone.
Yes, sir.
And now I'll make an entry point for my C1 first.
Yes.
And I'll change my burr from 2 mm to matchstick now. Okay.
Now you can easily appreciate both. There's lots of space by which like you are doing the traction, without injuring anything, you are able to appreciate everything. And especially everything is like down. So when it is up, it is very like it's a big space there.
So this is the center of the lateral mass. Okay. And here you can see your posterior arch is coming down and merging with the lateral mass. Okay.
Sir, can you please show burr first, and then because everybody wants to see this.
Yeah, just showing.
Sure. I'll show you.
Yes, sir. Thank you.
So this is a matchstick burr. Okay.
Yes,
This is a
sir.
matchstick burr.
Yeah.
Okay.
Yeah.
You can have diamond, you can have cutting,
Yes, sir.
whatever you want.
Yeah.
Okay. So there are two important things. One is entry point.
Yes.
Okay.
Yes.
So that will be my entry point. And since I want, a good correction, so
Yes.
I'll keep it little bit lower, somewhere
Yeah.
from here.
Yes.
Okay.
Yeah.
And after making it, after decorticating this cortex,
Yes.
okay, I'll take a shot.
Yeah. And
And then
redirect
I
accordingly.
decide my sagittal angulation.
Yeah.
Okay?
Accordingly. Yes.
So
Perfect.
now I am making my entry point. My coronal angulation is almost 5 to 10 degree. Got it?
Yes, sir.
Pretty straight.
Yes.
And now I'm making my entry point. Okay.
Yes.
So this is the entry point.
Yes.
Okay. And now I'll take a shot
Yeah,
X-ray
amen.
to see
Yeah.
whether I am going.
Yes, sir.
तुम ये अपना ना इसको ले उधर की तरफ से फोकस
इतने पटियाला थे लुधियाना थे अच्छा
ताकि वो दोनों पीआईपी में we will be able to show.
Yes, sir. That will be nice.
सवेरे सवेरे 5:30 बजे
लेकिन तो पकड़े ना in microscope sometimes it becomes difficult to appreciate your coronal angulation.
Yes, sir.
So always peek outside, okay, and see what is your coronal angulation. Okay,
Yes, yes.
it's very important.
Yes.
Or ask your assistant whether my coronal angulation is good or not,
Yes.
because you are seeing in this
Yeah.
and in the fluoro. मेरा चश्मा दे दो.
Yeah. Yeah.
इसको अंदर घुसाओ
Okay.
सर, इसको अंदर
So the main thing is mid or below. Don't go up because there is foramina. So mid and below. So the same rule is
Short लो.
only translaminar.
Short लो.
You love up, otherwise everything is down.
Okay, so this is our
Yeah.
PIP में दिख रहा है. Put this in PIP. Put the X-ray in PIP.
Yeah, enlarge the PIP.
Yeah.
And
So switch.
always,
I will,
in
yes,
difficult
perfect.
cases,
Perfect.
always
Perfect.
go to the C-arm.
Yeah.
Okay, and
Yes.
see where your anterior tubercle is.
Yes.
Okay, it's very important.
Yes.
So in this case,
एकड़ो थींदा धन एकड़ो थींदा मजबूती ॿिन्हिनि में थोरो सो डिफरेंस थींदो आहे
It is going
हाँ
up most probably. Yeah.
अपना ये C-arm हटा लो. अपना ये हटा लिया. Take a picture again. Okay. So you can see your C1 anterior tubercle is somewhere here.
Yeah.
Okay. It is somewhere here.
Yes, sir. Yes.
Got it?
Appreciate. Yeah.
Maybe it's bit rotated,
Yes.
but it is somewhere here.
Yeah.
मैं वही बोल रहा हूँ
Yeah.
डिजिट पे इंसान को
Yes,
ध्यान
yes,
रखना
yes.
Shadow.
Yes.
मन में
Yes.
One
शांति
shadow
आती
is
है।
Yeah. That.
shadow.
Yes.
So maybe one side is
हाँ
more
मैं
like
वही
this,
आपको समझाने की
another one
कोशिश
Yes,
in
sir.
the That, but most probably it is lying somewhere here.
Here.
Okay?
Yes, sir.
So I will target this point only.
Yes.
Okay?
Yeah.
Any confusion?
No, that's fine. Anything. Yeah.
Yeah.
So just target it on the medial, like
Sure,
downward. Downward. Yeah. Yeah. Yeah.
इसके काम करना थोड़ा सा इसके
एड़ों को वधो कम तोड़ना है.
Low. Ideally is like this is tubercle, boss. Ideally like this is tubercle. Up and down. Down.
उसको और करने के लिए
Down.
आप लेना शॉर्ट Okay. थोड़ा सा आगे हो सर हाँ वो मास का जॉइंट है बस ये होगा
We can easily appreciate like
Short.
here. This is the assimilated part. So we are starting from here and
दोनों शेडोज आ रही हैं थोड़ा सा इसको एक काम करो इस चीज को नीचे लेके जाओ हाँ अब लेना
sorry.
ज्यादा बढ़ गया उसको कम करो
Yes.
उसको कम करो उल्टे एंगल में और जो
नजदीक जाके
जो मैक्सिमम है
जा रहा है.
ओके
I will not able to appreciate.
थोड़ा सा टेबल को इस साइड
Yes,
रोटेट
now
करो
you can see. So ideally
उल्टा
here is the
टुवर्ड्स मी
overlapping tubercle. This will be
इसलिए
the
ना
lower
दोनों शेडो ओवरलैप कर रही है
And
ये
this
शेडो
is
ये शेडो है ना
the lateral
हाँ,
mass.
थोड़ा सा मैं तो रोटेट
So
करो
we'll target the lower
आप लेना,
margin of
short
these
लेना.
two buttons, white buttons, lower margin. Just.
ओके इट इज नाउ कमिंग इनटू
Sir, वो ऊपर होगा.
और करना
That's why we are not going up.
और करना टेबल रोटेट
So tubercle के ऊपर होगा.
हाँ अब लेना रुक जाओ
जो चीज बेस्ट थिंग बस ये है कि जहाँ
ये
जाना
है
है
ना?
उस रास्ते पे
दिस
देखना.
वन ओके
Don't
आई
know,
टारगेट
don't
दिस
think.
वन ओके
आप सोचोगे it will be create a lots of question in your mind. So you know it. This is the right path. Follow it. Medial lateral equilation के लिए सर ने बताया depending upon like pre-operative you will see how much is rotation. It is almost a straight. So this is almost a straight. There is no rotation. It is always slip. So 5.
दिस इज
Yeah.
So, you know, you have to reconfirm your anterior tubercle many times maybe because in congenital cases,
It is.
sometimes it become very difficult, you know,
But it
to
is
appreciate
very unpractical.
the anterior tubercle.
Don't-
And there lies, you know, the importance of the pre-operative X-ray. Got it?
मैं बात करता हूँ 2 मिनट रुको मैं उनको पूछ.
Hello?
Yes, sir.
Okay, so now I'll put it. Vipin, put your pencil. So take a shot. हटा लो सर, एक मिनट हटा दो. ऐसा नजदीक हो गया मुझे दिख नहीं रहा. Shot. Okay, so it is going in
Yes,
right
sir.
direction. Maybe a little bit lower.
Yeah.
Okay, but otherwise fine.
Yeah.
So for demo shake, नीचे shot. ठीक है?
Yeah. Now.
हाँ?
We'll see.
नहीं आपने ठीक है. वो actually क्या है? It is okay. It is okay. Okay, so I am not, you know, I'm not let my assistant, you know, put the sector over so that you can easily see where my, you know, this drill is going.
Yeah. Please.
Okay.
Yeah.
So my coronal angulation is approximately 5 to 10 degree.
Yeah.
Okay.
Yeah.
And hypoglossal canal is very away,
Yes.
and I'll put it.
Yeah.
Short. Okay, so I'm going inside.
Yeah. Can you switch the clinical picture and the radio up? Yeah, the perfect.
Fine.
ये was ठीक है. We
Short.
want to see this.
Okay, so I'm
Yeah.
going inside.
Yes.
And I'm always feeling, that there is bone all around.
Yes. So enough. Like,
There is good solid bone all around.
yes,
Still,
yes,
short.
yes.
Okay. So now I take a ball probe.
Yeah.
And now I'll take a manual drill.
Yes.
Manual drill. Short. Short. You see, I'm able to increase it by here only.
Yes.
Okay, it's very good drill.
Yes.
Short. Okay, so
It is bicortical, I think.
it is bicortical.
Yes.
Because of slight rotation, it is looking that it has purchased, but
Yeah.
I will always fill it using my,
Ball probe.
ball probe.
Yes.
So it is bicortical now.
Yes.
Okay.
Can we take
It
one
is
picture?
Little bit of bone weight. 22 है. So 26 का score.
Good.
Number 4.
So that's why I was trying to tell you this is the margin. Okay.
I will put a little bit of bone wax so that by time I'll do, other things, it will not keep on troubling me. And an important tip to put bone wax here is
Yes.
put a bone wax and take a cottonade.
Yes.
Okay.
Yes, sir.
And then just press it here. Okay.
Yes. Perfect. No. Just to stop and then we'll do second one. The screw. We'll fill it after making the 2 entry points like.
Number 4 देना.
Sir.
So it is good.
So, yes.
And now I'm going to make my C2 trajectory. Okay.
Then we'll fill the joint because we have prepared the joint and fill the bone and then we'll apply the rod and we touch it at one.
Now I'm going to make my C2 trajectory. Saline.
Because we need some space to
Section बढ़ा दो ना.
take those variations. That would have to be for life.
बाद में निकाल देंगे चलो इसको. Okay.
Yes, sir.
So now my C1 trajectory is ready.
Yeah.
We have measured it. It is coming out 22 mm.
Okay.
And we'll keep 4 mm screw. I mean, keep a length of 4 mm to maintain the polyaxiality.
Yeah.
And so I am going to put 26 mm screw here.
Okay.
And now I'm going to make the trajectory for C2.
C2. Yeah. So this is
Okay.
very important point here, sir has mentioned using a reduction screw. So 22 is like fine. Okay. So bike purchase there. So add according to the patient perspective, like 4 mm, sir think that there was a 4 plus is fine. So we'll use 22 plus 4 is 26 mm screw. Yeah. Because that's why sir has appreciated. So 4 mm is like the main thing which you want to pull. Otherwise, like if you will tight and everything will come very. So over, yeah.
So this is the exit foramina of vertebral artery. And maybe it is going like that.
Yes.
Okay.
Yes.
So I'll ask my assistant,
To hold.
to hold and rotate everything laterally.
Yes.
Okay.
Yes.
Like this.
Yeah.
And in downward fashion.
Yes, please. Yeah.
And I will take the advantage of this part. Okay.
Yes.
This part.
Yeah.
Of the exit foramina.
Yeah.
And I will try to keep maximum bony purchase. Okay.
Yes.
I'll try to take maximum bony purchase.
Yes.
So
Hello.
this is the medial angulation of the pedicle. Okay. This is lamina. It is turning into pedicle. Okay.
Yes.
That I will feel all the time.
Yes.
And I'll try to, remain parallel to this superomedial margin of the pedicle. Got it? I will start somewhere from here. And I'll put my screw in a medial trajectory.
Yeah.
Okay. So that is my entry point.
Yes.
In line.
Yes.
Can you give a shot to me?
Yeah.
Sure. That is just for demo purpose. Number one.
Yeah.
See, I am running
Yeah.
parallel to the superior margin of the pedicle. Can you
Yes.
see it?
Yes.
Good.
Honestly, it's the anatomical screw. So just for demonstration. Otherwise, we always see and go
Every time feel. Okay.
every time. Yes, sir.
Feel.
Yes, sir.
Short. And now you see you are entering inside the body.
Yes.
Okay.
Yes.
So what you have done, actually you have crossed the exit of vertebral. You are
Yeah.
safe.
Yeah.
Okay.
Yeah. Yeah.
So you are inside the body now.
Yes.
So I'll again put it in bicortical manner. And this is bicortical now. Okay.
Yes, sir.
It is going to be very small screw.
Yeah.
Short. Okay.
Yes, sir.
Now I'm hitting the anterior cortex of the body.
Yeah.
And I will perforate it. बोन तैयार करा लो शॉर्ट बोन तैयार करो short. Okay, so now I have perforated the anterior
Yes.
cortex.
Yes, we can appreciate it.
Because this is going to be my side of concern. So
Yeah.
I'm putting both C1 and C2 in bicortical manner here.
Yes.
Okay, so it's bicortical now.
Yes.
Short. It's good.
Yes.
14 ये मेरे हिसाब से हाँ तो इधर तुम 16 का स्क्रू देना और उधर चलो ओके डिपेंड यहाँ लगाओ फिर से नंबर ऐसा नंबर 4 लगा के रखो and now I'm going to make a space for my C1 screw head.
Yeah.
Okay.
Yes.
So that it sits perfectly over here.
Yes.
Okay.
Yeah.
Mono. काव्या से कह दो थोड़ा सा वो ले लेगी ब्लड ले लेगी यहाँ ब्लीडिंग करा के नहीं लेंगे
This is the assimilation part. So you have to drill it. Just to sit properly there.
Done. Then तो चेंज कर दें
So this is the overhanging posterior arch of C1.
Yes,
which has
that's why I
been,
was telling.
which has been prepared for drilling.
Yes,
That will let the head of C1 reduction screw
Yes.
settle
Yeah.
in with
Yeah.
flush.
Yeah. If you not drill this, then you have to add some more length to the screw, but it is not practical. So
So now I am drilling this overhanging part,
yes, sir.
as Professor Kuldeep has said,
Yes.
because I want my lateral mass screw
To fit
as close
properly.
as possible.
Yes.
Okay?
Yes. Yes.
You see how it opened up now?
Yes. You can
got
easily
very
appreciate
good space
the
now.
space needed.
For getting reduction, this is required.
Yes. Perfect.
ले लिया, blood ले लिया? बना लो, bone बना लो.
When you are dealing with this point, it is very important to ask your assistant only to hold, because there. No,
थोड़ा सा बना के
yeah,
दे दो,
so
थोड़ा सा.
lateral.
बाद
So
में बना के
everything
दो.
is lateral. So you want to protect
नहीं, नहीं,
even
दे दो, क्या दो, दे दो.
there is
अभी
slip,
bleeding जो होगी लेते रहना.
especially when you are
थोड़ा
using the
सा
cutting bar, it is
उसको ना push करके
jump.
थोड़ा सा दे दो.
So always protection. Yeah.
थोड़ा सा ही चाहिए अभी, पूरा नहीं चाहिए ना.
Yeah, please.
टैप दे देना तब तक के लिए.
On करो.
टैप टैप.
उसको press करो.
Okay, now I'm tapping it.
Yes.
Only few mm.
Yeah.
Because there is a difference in dia of your drill and your screw, so you have to tap it.
Yes.
Okay.
Yes.
Because you are going to put a 3.5 mm screw.
Yeah.
Your drill was 2.7 mm only.
Yeah.
And this is 3.5 mm dia tap. Okay.
Yeah.
So you need to tap it.
Yeah.
Otherwise it gets fractured.
In normal. Normally follow the same. Made
Bone.
junction or below.
Now I'm putting some bone in between. You know, these are
Yes.
artificial
Yeah.
bone fragments. Later on, I'll supplement it with autologous bone also.
Because no, that's right. Yes. So yeah. So sir, if you can appreciate the drilling, like you are always leaving a medial part of the bone. Look here, even the C2. So joint and everything is intact, like it is already preventing anything to migrate. Yeah. So that's why you are leaving that and you are drilling is opening all this lateral one, and then direction will be straightforward. Yeah.
26 reduction.
So
Yes,
artificial bone graft has been placed
So
inside.
now I'm
Yes.
putting my screw.
Yeah.
Okay.
Yes.
C1 reduction screw going
This
in.
is C1 reduction screw. Short.
Yes. So that is the protective phenomenon, sir.
That is going into intended direction.
Yes.
It will not go anywhere else. And I will try to short. I'll try to
put it flush
Yeah.
with the posterior surface of the
I can
lateral mass.
appreciate the
Okay.
problem. Yeah. Sure. Yes, sir.
Sir, I have a question.
Sure.
Previously, sir, we used to have a different kind of a C1 screw for lateral mass, and
Okay.
that was unthreaded in upper 10 range, I think.
Okay. Okay.
And we used to leave a little bit part, unthreaded part outside the lateral mass to protect the C2 nerve root ganglion compression.
Here you are cutting.
Okay. Okay. I'll tell you. Okay. Let
Okay,
me
sir.
check.
Here
it
there
out.
is no irritation.
The ganglia is not there, so I don't,
Okay.
don't think.
So my C1 screw is in right position right now.
Yes, perfect.
And to the Pankaj question.
Yeah.
If you leave your C2 nerve root intact,
Yes,
then
sir.
only that type of screw is required.
Yes, sir. Yes. That's why I explained to Pankaj.
Prevent irritation of the C2 nerve root.
Yes.
In this case, what I am doing, I am not leaving any part of the C1 screw outside.
Yeah.
You see, it is completely inside.
Yeah. Flush.
And I have already sacrificed the C2.
Yes.
So there are no chances of irritation.
Yeah.
And I'm telling you, now we have, we are preserving the C2 nerve root in many cases, but I have not encountered any case of C2 nerve irritation clinically.
Yeah.
In post-operative period.
Yeah.
So I don't know whether
There
it
is
is
no-
correct or not, but we have not encountered any case of C2 nerve irritation. Dr. Kev, you have
No, sir. No, sir.
encountered
Same here.
any
Same here.
case?
Yeah. No, same.
As close to the tulip should rest on the C1 lateral mass as close to as possible.
Generally, there is no any difference between threaded and smooth screw as far as C2 nerve root irritation is concerned in practice.
Now you see, in this case is actually easy, but I have not removed, the concept
Yes.
of the C1 lateral mass.
Yes. That's I was trying to put out. Yeah.
That is used for retraction.
I'm just using it as a lever.
Yeah.
Okay. And I
So
am
this is
putting
very
my
important point. Yes.
16
So
mm.
after
Sarah has
delivery.
started also.
Yeah.
On the cutover.
Yeah. Now look. Yeah. Yes.
How nicely too.
So it is under control.
Yeah.
So you are controlling and then you are putting the C2.
Sure. Okay. So it's good.
Yes.
I'll push my C1 a bit anterior.
Yes.
And now you can appreciate the difference in the sagittal alignment of C1 and C2 screws. Okay.
Yes, sir.
I'll
Yes.
make it a bit lateral for you to understand what I'm saying.
Yes, yes.
Okay.
Yes, perfect.
So this is the breakable part.
Yeah.
Okay. And this, you see, this is the top of the C1 screw after breaking.
Yeah.
And this is the top of your C2 screw.
C2.
It is practically very difficult to put your rods
Yes.
without pushing it down.
Yeah.
You understand?
Yeah.
Now I'll show up. Now you can see in this case where your heads are now.
Yeah.
It's
Yeah.
almost parallel.
Yes.
Got it?
Yes, sir.
Chalo, iska nikal do. Now I am, going to put my
Now
rod
the
on
main
this side
climax will
first.
come when we put rods. So everything will come straight up and out.
Actually, it is impossible to put a rod without this patented reduction screw, as everyone can appreciate.
It's a very easy way. There's a very simple thought, very simple
Okay.
technique, replicable and
And
everything.
now I am removing my traction.
Yeah.
Traction hatwa do.
So take the traction 2 kilo, which you applied for the alignment. We'll take this off.
Now I am
This is
removing
an
my
also important step.
Yeah.
and I am going to apply my rods.
Yeah. And here is the important point is the length of the rod. Sir, can you please mention it?
Sure.
Yeah.
And there is another important maneuver that you may require to do sometime that I call occipital locking of the rods,
Yes.
because your rods are so much anterior into the C1
Yeah.
that you may not get, a good segment outside. Okay.
Yes.
So you may need to drill or make a gutter inside the occipital bone.
Yes.
Okay.
Yeah.
That we are calling occipital locking of the rod.
Of the rod. Yes.
You will very soon find out in some of our papers.
Yes, sir.
Okay.
Yeah.
So before doing that, I will इसको छोटा और छोटा दूं.
Just drill bit small drilling to just to get locked. Yeah.
Before doing that, I will just, plan where should I drill my occiput.
Yeah.
Okay.
Yes, sir.
And it may be somewhere here.
Yeah.
Drill दीजिए sister. Diamond. Sorry. Diamond चाहिए.
Here.
यहाँ लगा लो.
So these are the small ticks when you have to switch, when you have to do so like is.
Okay, so
Yes.
I am drilling a part of the occipital bone in whole depth. इसको यहाँ पे लगा दो. एक नंबर 4 दे दीजिए. नंबर 4. चलो ठीक है. रणविजय सर आ गए कि नहीं?
रणविजय बॉस तो नहीं आए, अनूप बॉस हैं.
अनूप बॉस आ गए हैं?
हाँ हाँ.
मोस्ट वेलकम सर.
We are.
Thank you. Thank you, Deepak.
Any comment boss or any suggestion?
It's a beautiful depiction that I was discussing with the Dr. Cap also. How you make it totally, completely an avascular surgery.
Yes, boss. Actually, that's the crux. I mean, we should keep, we should spend some time.
Huh.
There is no need to hurry. There is no point in hurrying.
Yeah, I had seen Professor Atulgal sir with a blood loss of 1800 ml. And he was putting the screws. Huh.
He is a master actually. So we need to, take all the good points from him and then improvise by ourselves. What is good for our patients in our setup. There are people who are blessed actually. Professor Goyal is blessed.
Red color is life. Red color is black.
You see,
It's
this
beautiful.
is
It's beautiful.
very important maneuver because you need at least 5 mm of your rod above.
So main thing is here because you will tight C2 screw. Okay. So you need some length to slide it up. That's why we are creating the space. So you lock this C2, you will leave this much so that it will come up, realign, then it will go this way.
Farhan, any comment?
This is very important. Otherwise, क्या होगा कि आप टाइप करोगे ना, then you ये तो अंदर चला जाएगा.
We have
So
recently
additional
developed
length
this
you have to
technique,
plan.
to provide
Yeah.
more security. इसको 5 mm और कम करो. इतना काटो. इतना काटो.
Yes.
इतना.
And then it will give a leverage for screw C1 screw. When it will come back, it will go forward.
यहाँ ज़्यादा difference नहीं
So
है.
like BI
It will
and
create more
AD
difference with
component.
this side.
So it should
Huh?
come back and
Your
move forward.
direction achieve करें.
Yeah.
Okay, so छोटा रह गया लग रहा है ये. हाँ, इसको सुनो थोड़ा सा और बड़ा करो.
Yes.
इससे
That's why we are pointing out.
ये कटती इतना ही देता है. ये गलती है. So you should be very cautious about your rod length also.
Yes, sir.
Okay, because there are X-rays I have seen in which the rod length is
Almost
long and
close.
it is actually putting unnecessary irritation over the C2-3 facet. Okay, and
Yes.
that will be disease later on. So you should not violate your C2-3 facet joint.
Yeah.
First thing, and you should your rod should stay somewhere here above the C2-3 facet. That is very important.
Yes.
So try to keep it of minimum length possible.
Yeah.
not minimum, I should say adequate length.
Carefully tailored, the length of the rod is very
Okay, so
important.
I think this is good. I think this is good. Okay, screw. Any?
We can well appreciate the
See
increase.
how simple it is now. As Dr. Kuldeep is saying, Kuldeep, please explain.
We can very clearly visualize that some extra millimeters of rod.
Now,
can
now
be-
you can see how easy it is. Okay, got it?
Yes.
I'm not doing anything silly. But what you may require some time, that this rod itself will create an angle. So
Leave and then,
maybe you should apply your C2 first.
yes.
Okay, C2 ini.
Yeah.
Okay. And then I'll ask my assistant to put a pressure. Number 4. Number 4. Okay, so that it will go in my intended gutter. Okay, and I'll now tighten the C1 screw. Push karo na फिर? Push करके उतना बता. Now it is inside my intended gutter. And now we'll finally tighten it. I will lock this first. Not complete tightening because I have to do my surgery on the opposite side also. And
Can you take a X-ray, please?
sure.
Yeah.
Let me go up to my intended length first. And then I'll take an X-ray. X-ray, shoot. You see it is coming now.
Yeah. It
And-
started. Yeah.
Started and
Yes.
very soon you will see when I'll complete it on opposite side, it is completely reduced. Okay.
Yes, sir. Gradually, we will witness the magic of correction.
I have not, tightened it fully now. And now I'll do
Yeah.
it on
It
opposite
is good.
side.
Yeah. So you can appreciate from, yeah.
We'll do a scan also immediately after surgery.
Sir, Cab boss is asking, can we do continuous fluoroscopy just to,
Continuous fluoroscopy that will do on opposite side.
okay, that's fine,
Okay.
sir. Okay.
Sure. So now I'll go on opposite side.
Opposite side. Yeah. Is the dominant side.
Yeah.
Yeah.
It is the problem side.
Yes.
Okay. Bye. Buddha. Good thing is that the pedicle is good here,
Yes.
and but that much of traction or that much of correction only on the right side, has stretched every soft tissue on the left side,
Yes.
and that will make my life a lot easier.
Yes, sir.
Can we take MEP? Then okay, so MEP is okay. There is no changes.
Yes.
Okay,
Yes, sir.
it is all intact. So now I'm going on the left side.
Yes, please.
Sir, I have a situation. I think you are the best person to answer. Excuse me, sir.
Pardon?
Yes.
Sir, I have a situation.
Okay.
Last week, a 7-year-old boy who was having pot spine at CVJ.
Rakesh, can you take up that question?
Yeah, please.
The
Yes,
last week, 7 years old boy who
Yeah.
presented with spastic quadriparesis.
Yeah.
And he was having a CVJ pot spine.
Okay.
Everything was distorted. On the left side, the C1 joint was absolutely eaten up by the pots.
Yes.
On the right side, it was very small lateral mass.
Okay.
So we went first on the right side. We properly made the trajectory.
Yeah.
But while putting the screws, I think screw size, the minimum size we started 3.5, but it broke down.
Everything settled down.
It
Yeah.
broke down.
Yeah.
And on left side, we did not had any option.
Yeah.
So finally, we went for occiput and C2.
Yes.
And luckily, we were lucky enough. The child improved very well, and we got a very good correction.
Okay. So what were the quantity, quality of C2? Because
Sir, C2 was good.
C2 was good.
C2 was very good.
Yeah.
So my question is, we have got lots of rescue options in C2.
Yes.
But what about C1? If we are not able to cannulate C1 lateral mass, so apart from occiput, do we have any other options? Because I have seen few people doing sublaminar hooks at C1.
So look, if you just want to stabilize that thing in C2,
Simple number.
okay? Yes, that's my question. So in POTS spine, you are doing all these things. You want to put some good construct, hold, and then take time like 4-6 months to refuse everything, either the soft tissue or bone. Okay. So that option is not there.
Sir,
So-
in such cases, only occiput
Yes.
C2 is the option.
Yes, practical option is that one.
You know, lateral mass is a pretty good bone. It's a pretty thick bone.
Yeah, but sir, see, he is asking about like there was a one POTS spine and there was no lateral mass one side and second side bone quality was not good.
Okay, okay.
And-
then
and-
obviously you have to
Yes,
take
yes, that's why I'm
occiput.
telling. Yeah,
Yeah,
Yeah.
then you have to take occiput.
yes, sir. Yes, sir. Thanks.
If you are operating on a infected spine, like a POTS spine, okay, only simple fixation will work.
Yes.
Okay, so occiput C2 or occiput C3 for lateral mass are very good option in
Yeah.
POTS spine. Okay,
Yes.
but if you are doing, only occiput fixation in CVJ, congenital CVJ,
Yes.
always try to put, your cage inside.
Yes, that's I was discussing yesterday with a few colleagues. They have asked me regarding this. What are the indication for us currently to use the cases? So that was my
So-
my
So if you are doing a simple occiput C2 fixation,
yeah
you should always supplement it with,
yeah that
know,
that was
cases.
my answer, sir.
yeah, sure. Because it is very difficult, I'm telling you.
Yes, sir.
It will settle down.
Yes,
It will settle, definitely it will settle.
that we have discussed yesterday. So only indication for right now us is to put cage. Somebody was asking about cage. So when we are going occiput C2 or C3 with the settling everything BI is there, then cage, and then we'll do the 3-point fixation what we're trying to come with next one.
That's वो वाला दिया करो temporary क्यों?
Yes, so opposite side is
Now
yeah
it is rigid. So just to make it a bit mobile,
yeah
so I can explore it on, left side also.
yes, sir.
I am slightly loosening it.
Yeah.
That's the beauty of this reduction screw. You cannot do this thing where you put your simple screws. Okay.
Yeah. So you are approximately in the joint.
Maybe
Yes, sir.
I'll let you know. So this is the joint,
Yes, sir.
but it is pretty fixed now because
Yes.
of the right
Opposite
side.
side.
Yeah.
Yes, yes, sir.
But I'll mobilize it. Okay.
Yes, sir.
I'll
Yes, sir.
mobilize it.
Yes, sir.
I will loosen it up again
Yes, sir.
because I have mobilized my extradural pica.
Yes, sir.
It is very, very far. You can see in the 3D CT
Yes, sir.
that is looping more on the lateral side
Yeah.
towards the joint. Okay.
Yes, yes, yes.
And in medial side is pretty free.
Yes, sir.
Okay.
Yeah.
So this is my joint. Okay.
This side, sir, yes, because already pica is there. There is a
Yeah,
little space.
yeah. So I will drill it
everything
with
we
here.
taken up with the subperiosteum.
So
We are
this is
just
my
as per
joint.
the plan. Yeah.
You can now see, appreciate it clearly.
Yes, sir.
And I'll ask my assistant
To hold it.
to hold it
Yes,
like
sir.
this.
Yeah.
Do we have root detector?
Hmm.
Root detector है खुलवा लो. Vipin,
So
you
we are
have to
taking the leverage of opposite side to bring it back. And then we are doing the same thing. There was a little space. So it's a planning. So that's why it is planning is very important in complex spine, especially CBJ. Sir has planned, okay, so I will mobilize because there is a space where we want to put the C1 lateral mass. No, we don't want to see. We have mobilized anything, everything. So Paika, sir mentioned that we have mobilized everything up because in 3D, if anyone can put the 3D one, or we can ask someone so that boss will also appreciate. So we'll put the 3D.
Okay,
because
so
this
I have a very good.
Paika have the extra dual.
Okay,
opening, and
so
then
I have a very good space for putting
Yes.
up my.
So that's why we have mobilized
Even
the
lateral
Paika,
mass.
one lateral mass. And then,
This much space I will utilize. Okay,
yes, sir.
and and I am now feeling the lateral margin
Yes,
of the
sir.
C1 lateral mass.
Yes.
I am feeling the medial margin of my C1 lateral mass. Okay.
Yes, there.
This
Yeah.
is my joint.
Yeah.
Okay, this is my joint.
Yes.
It's pretty tight now.
Yes.
Okay.
Yes.
It's very tight. Very,
Yes.
very tight.
Yes.
Okay. So I'll make a space for that.
Yes.
Okay. ऐसे पकड़. You have to put it like that. Okay. नहीं फिसल रहा है तुम्हारा थोड़ा सा.
Yeah. That is.
नहीं अभी diamond.
If you will be in the plane, there is natural protection
पकड़ो यार.
for
मेरे
every.
लिए फिसल रहे हो.
As
ना मेरे लिए फिसलना नहीं है ना. मेरे लिए फिसल यार. नहीं यार ऐसा नहीं करो. रुको. तुम इस साइड से खींचो.
That's why.
Your assistance is very important. Okay.
Yes, sir.
Because you have to make your all points here. यहाँ पे ऐसे, है ना? Good. So now I'm taking.
Actually, what nature used to do, nature used to protect the vertebral with the venous plexuses. And here the dissection should be done with the monopolar. Once you start getting venous bleeding, that is your limit.
You
You
can
have to
appreciate
stop there.
in your 3D
This
scan.
is the crux, how to protect this vertebral artery.
This is a bony prominence.
Yes. Perfect.
Okay.
Yeah. So
that is quite visible in our.
this is the same thing.
3D scan.
Exposure. So we always, sir, always say that also superior C2 short osteotomy, leaving a leverage for the medial one lateral. So it will direct you directly into the joint.
Okay.
Yes, sir.
So I am drilling that part of projection of the C2.
Yes, sir.
That is coming into my view.
Yeah.
Now I'm realigning my microscope for a better visualization and
Yes.
focusing it.
Yeah.
Okay.
Yes, sir.
एक micro dissector दीजिएगा. This is my joint. You
Yeah.
can see the mobility here.
Yeah.
Okay.
Yes.
And
C1.
I will drill this part
Yeah.
so that I will have a good entry point inside the C1.
Yes.
इसको ले लो, soft tissue को. हाँ, good. Okay.
Yes, sir.
I will drill this part so that I will expose it more.
Yes.
You must understand that C1 lateral mass is angulation is, down
Yes.
here.
Yeah.
So you can get entry point, from pretty down.
Yes.
You can get entry point from drilling the C2 superior facet itself.
Yes, sir.
So here you see how I am protecting my C2 nerve root.
Yeah.
I need not to cut it.
Yes.
I have not cut it. Okay.
Yes, yes.
And still I will be able to make my
One
entry
and
point into the C1 lateral mass.
yeah.
And I am exploring my joint.
Yes.
Okay.
Yes.
Got it?
Yeah.
I am not damaging the medial part.
Yes.
I am not going laterally. I am staying in the middle.
Yeah.
Okay, so that is the soft tissue of the joint.
Yes.
Good. And and this is whole lateral mass. Okay. This is the lateral mass. Can you see it? This is the lateral mass. Okay.
Yes, sir.
Okay. So now I'm going to make my entry point.
Yes.
Within एक यहाँ पे एक यहाँ पे. तुम अरुण इस side हो.
Sometimes
इसको
you will
उठाना
need the
है,
two
हाँ.
hands, assistant,
तुम्हारे
two
उल्टा
hands,
पड़ेगा.
like two persons. Like one will
कर लो?
focus on one,
हाँ, मैं
second will focus on the other.
Okay, so now my assistant, Dr. Vipin, is holding, all the soft tissue. अरुण को साथ पकड़ा दो इसको, तुम्हारा हाथ आसान हो जाएगा. छोड़. हाँ, अरुण तुम पकड़ लो इसको. छोड़, ठीक है उसके लिए. और तुम एक पकड़ लो ना, और रिट्रैक्ट करके रखो. See, my assistants are holding the retractors. Okay.
Yes, sir.
And I am feeling the medial and lateral margin of my lateral muscle.
lateral muscle,
And
yeah.
I will make my entry point somewhere here.
Yes.
Because the loop of the pica is down here.
Yeah.
So I will try to remain here. Okay.
Yes, sir. Yeah. Perfect.
So, Arun, you just hold it like this. Okay. Hold it like this.
So, Pankaj, someone was asking about the venous plexus bleeding.
Chal, ठीक.
So,
Jildi na?
look here. So, the main important thing is you have to be in the natural protective plane. Okay. Second thing is venous,
Okay,
they are
so-
venous plexus. They're
I am taking,
not supported.
making my angulation
Yes,
in the
sir.
coronal plane.
Yeah.
Okay.
Yes, sir.
And when I will make my entry point,
Then we'll take the CR.
I will ask
Yeah.
them to, remove
Yeah.
their retractors
Yes, sir.
or the dissectors, and then I will realign everything accordingly.
Yes, sir.
This is
Perfect.
my coronal angulation. I am checking it again.
Okay.
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 My coronal angulation is perfect.
Yeah.
And I have asked my assistants who are not looking into the microscope to always keep a check on my angulation. Okay.
Alan, yes, sir.
And remind me if I am not going into the right direction.
Yes, perfect.
Because I am looking inside the microscope.
Yes, sir. Yes.
Arun, it is hanging.
So here you are working with 4 eyes.
6 eyes.
Oh, thanks. Yeah, I forget to mention.
Ah,
6 eyes.
Arun, Dr. Kuldeep is.
He is boss, so it's considered as the like God eyes.
Sure. Kuldeep. अभी रुक जाते हैं थोड़ा सा 10 मिनट, बस 10 मिनट. 10 इसको मैं कम से कम स्क्रू डाल दूं, है ना? स्क्रू पड़ जाए उसके बाद. ठीक है. कोर्नल एंगुलेशन, ठीक है. कोर्नल ठीक है. ऐसे.
So who is
Coronal.
standing outside will direct you. Yes,
Somebody
your
direct कर
coronal
देना.
angle is fine or not.
Okay. So I'll take a shot now, and I'm asking them to remove their dissectors. Vipin, Arun. Okay. Take a shot.
Sir, actually, what we
Okay, it is,
you are right, but here pipe
going
is coming on the left
a
side.
bit up.
We have reflected everything.
So I will redirect
That's
it
why I wanted to
a bit down. Okay. But it's almost fine. ठीक है, थोड़ा डाउन कर देते हैं डायरेक्ट, बाकी तो
Just have reflected. We are trying to preserve everything.
Okay.
To the left mass.
So reapply.
Yeah. Upper medial quadrant, sir. It is, sir. It is not preferred. So, yeah, sir. आप देखो. इस पे हम देखो.
ठीक है.
इसीलिए सर मैंने अभी 10 मिनट वो
ठीक है.
ठीक ही होगा. तो इसलिए सर आपके पास उतनी ही जगह ही है. आप अब उसमें मार्क करोगे ना प्रॉपर्ली, तो सिर्फ मीडियल का जो छोटा पार्ट बच रहा है जिस पे आप जा सकते हो, उससे इसलिए हम लोग करते हैं. और
शॉर्ट
in general, so try to avoid
ठीक है, सही जा रहा है.
preferably I will,
ठीक है. ठीक है.
because
नहीं ऊपर नहीं,
if
ठीक
you
है.
break
से
it,
कर रहा जा रहा है.
you have no option.
Okay, so I am going into right direction.
Everything, and there is chance of injury.
हाँ,
So try
ठीक है.
to-
अंदर है हम लोग, शॉर्ट कट आ गया है.
Yes, sir. Middle point is ideal point.
अरे तो बहुत लेटरल आ गए हो. नजदीक रहो. नजदीक रहो. हाँ.
Yes, sir.
बस बस ठीक है.
So that's why we have to see there are 3 called improvement for one. Okay, but the crux is posterior arch. So feel first lateral medial.
Ball.
Mark middle. Mark middle. And then see the junction of posterior arch. Meeting point, the best point. 1 or 2 mm below, depending upon the slip and the correction we want to do. So if you want to do more correction, you have to move like down towards the joint so that you will be able to take everything out. You will go up, you will leave leverage. So there will be no leverage. So midpoint and below. That's best.
ऐसे पकड़ लो, मीडियल मतलब मत जाना है ना, कॉर्ड प्रोटेक्शन पकड़ लो. Okay, now it is settled. The head is over there.
Yes.
And short. Okay, so it is almost going parallel.
Yeah.
Okay. Short. Yeah. Short.
Yes, sir.
Okay. भैया तुम लोग अप्रिशिएट करते रहना ना, हमारी तो आंखें जो है दिख ही नहीं रहा हूँ. ठीक है. शॉर्ट कहाँ पे है? अच्छा अभी है ना, काफी है. ठीक है, अभी अंटीरियर आर्च आई एम लेकिन है ना. तो सॉरी टेबल कर शॉर्ट reached.
Yes, sir.
So
We are almost there.
almost there.
Yeah.
But I think still I am not. I have not this,
Yeah,
anterior
yeah.
cortex.
Yes, sir.
So it's all tactile feel.
Yes.
And now I think I am into the anterior cortex. It is very tight.
Yes.
Short. So now I think I have, taken control of the anterior cortex also.
Yes, sir.
Okay.
Yeah.
And maybe I'll go 1 mm more. Good.
Yeah, it's almost there, sir.
So now I will feel all the 4 walls.
Yeah.
And bicortically, one important thing.
Yes, sir.
When you remove your drill,
Yeah.
keep your sheath like that.
Yeah.
Okay.
Yes, sir.
And then derotate it. Otherwise, the soft tissue will, get tangled.
Yes, sir. Yes.
So now I have removed it and now I'm removing my sheath. Okay?
Yeah, protecting the soft tissue there.
Ball probe. Now you blood लेने थोड़ा सा काम आएगा.
2.7. Length will depend. That's why we are measuring, seeing in the SIAM. Previous was like.
I am taking that blood,
22,
to activate the hydroxyapatite crystals. That is required for bony fusion.
Yes, sir.
Okay.
Sir, how much do you use this bone graft?
Bone graft, as much as possible.
Artificial grafts are 10 cc or
10 cc.
10 cc. Usually the 10 cc.
Okay, so I'll feel my. Depend यहाँ पकड़ो. ला बेटा बॉल दो. और हटा दो, तुम्हारे ना. हाँ ऐसे बिल्कुल बिल्कुल. Yes, good. अहीं इतना नचा रहे हो यार, ठीक है ना. Okay, so this is my trajectory.
Yes, sir.
And I have a good, solid bony margin all around.
Yes.
And it is bicortical. Okay?
Yes, sir.
And the length is 24.
So same, I will say like
I'll
22.
put like 26 to 28 screw here.
Yes,
Okay.
yes,
And now on this side, what I will try?
yeah,
I will try to have a solid pedicle screw.
yeah, because
Okay,
pedicle is fine.
that will come from like here,
Yeah,
and I'll try to create, a lot of sagittal difference,
okay,
and then only I'll get a very good reduction.
okay, okay.
Okay, that's
Yes,
in more, more like in subfascial manner.
yes, yes. It was, yeah,
That
it was.
I will try to keep in pedicular manner.
Yes, sir.
Okay.
Yeah,
So,
appreciated.
and everybody, has seen that this side pedicle is quite good.
Yeah,
Left side pedicle is quite good.
yes, sir. We have
So
discussed.
I am supposing that I'll get a very good, pedicular purchase on that side.
Yeah, yeah. Please.
Okay.
Yes,
so,
sir.
So that's how you protect your root. That's how you protect your,
Yes,
the vascular structure.
Yeah,
If you want,
yeah,
you can drill more.
yeah,
You drill more and more here.
yeah,
Okay.
yeah.
So that you need not to retract this also.
Okay, okay,
Okay.
okay.
You can drill here only.
Yeah,
Drill more, but again, more and bone loss.
yeah. It will.
So if it's not required, just
Yeah.
don't do it. But
Yeah.
otherwise, it's a very safe maneuver. Okay. So again, I am having a feel where my pedicle is.
Yes.
Okay. So this is my pedicle. Okay. This is my pedicle. And I'll try to put, this is my vertebral artery origin.
Yeah.
And this is quite good. Okay.
Yes, sir.
So I'll try to put it from here.
Yeah.
Good. Match stick. नंबर 4 फिर से दे, फिर से मैं उसकी फील लूंगा.
So look again here.
Right.
How anatomical is this? Do you need anything? Everything in front of you, your feeling is fine. Visual navigation is already working. Brain is working, and tactile feeling is there.
Because even a 0.2 mm of navigation.
Yes, sir. That's why I was trying to
Can create
convey. Yeah.
devastation in these cases.
Yes.
So it's very important to have.
And for drilling technique is always in and out, in a feel. 2 mm feel, 2 mm feel,
Short.
feel, and then go.
So see, so where I am going.
Yes.
And I am taking full purchase.
Yes.
Now I am going and trying to take the full purchase.
Yes, sir.
I'm inside the bone.
Yeah.
I'm always feeling it
Yes.
that I'm inside the bone. Short. क्रॉस कर गया है क्या पोस्टीरियर कॉर्टेक्स पे या भी नहीं इधर एक्चुअली बड़ा है ना थोड़ा सा इधर नहीं आया था ना नंबर 4 मेरे को वो दीजिए मैनुअल सेक्शन कर दे बेटा
अब देखिए तो ये वाला कंप्यूटर थोड़ी नेविगेट कर रहा है सब रखा है क्योंकि नेविगेशन एक्चुअली डिमांड करती है वही मैं बोल रहा हूं यही प्रैक्टिकल चीज है क्योंकि आपको कहना चाहिए मुझे मुझे क्या बताना सना बहुत ही बेकार है लेंथ के लिए आप कोई अगर कुछ कैरोटिड वगैरह है तो वर्क करने के लिए टोटल कर रहे हैं तो थोड़ा सा
शॉर्ट शॉर्ट
ले लिया आपने
कहाँ पहुंचा अभी? पोस्टीरियर मार्जिन पे है ना अभी तो? ठीक है. So I have crossed the vertebral foramina.
Yes, sir.
Now I think I am safe.
Yeah.
You can appreciate in on X-ray that I am at the posterior margin of the vertebral line.
But yeah.
Okay.
Yes.
So I think I have crossed the vertebral short. Mid body. Okay. And this is very robust, you know, this is very going to be very solid screw, I think.
Yes, sir.
Short. Almost crossed. Crossed, no?
Yes, almost.
So it's almost 22 mm.
Yeah.
And now I am taking control of the anterior cortex. I can have a tactile feel.
Yeah.
So good. Again, you see, I'm removing the inside part first.
Yeah.
And then I'm
taking
removing my sheath.
outer
Okay?
sheath. Yeah. To protect everything there.
To protect everything there.
Yeah.
And feeling it using my probe. There is
Yes,
good
sir.
solid bone all around.
Okay.
Okay.
And
Now I'm going to tap it because here, you know, my screw entry point is from lower down. I need not to do that maneuvering technique here.
Yeah.
That occipital locking, because I'll get a good space for putting up my rods.
Yes, sir.
Okay.
Yeah.
So I'll tap it now.
Yes, sir.
Sir, regarding 3D models.
Yeah, that okay.
Sir, do you order for 3D models in complicated cases only, or it's a routine that you take it for each and every case?
No, we don't do it routinely. But obviously, you know, if you have difficulty, you should have your 3D model inside your brain. Okay. Because you cannot keep on looking. I always believe in the flow of surgery.
Right.
Okay. But it's a very good thing to have if you can. And see, I have seen people, you know, measuring the length of screws, you know, before starting on 3D models. 3D models are not for measuring the length of screws. That's a pretty bad teaching that I am seeing in few centers, that you can measure the length of the screws. It's not for measuring the length of the screws. It is to, you know, have the anatomy before you all the time during surgery.
Right, sir.
That is the important thing.
Yeah.
Okay. That you should know from where you need to enter, where is the danger. Otherwise, your screws should always go, you know, as per your intra of findings. You get it bicortical, then measure, and then put up your screws. Few mm here and there, your entry point and your screw length will change.
Yes.
So it's not always possible that as per your 3D model, you will decide the length of your screws.
Yes,
it's
sir.
not possible.
Yes, yes.
Because your entry point may be not there.
Yeah, yeah. Perfect.
ऊपर की तरफ स्क्रू जहाँ पे इसके सिरेशन है ना वहां पे लगाओ. हाँ, तभी इसको सेफली निकाल सकते हैं ना.
प्रैक्टिकली ये होता है जब ब्रीच कर दो मैं बता रहा हूँ ना इसलिए तो जो भी
Okay, so
तो इतना मार्जिन होता है वहाँ पे.
see, I have loosened it up on the right side. That's why it is easy to remove. Okay. And now my screw is ready to go.
And ready screw.
ऊपर कितना किया तुमने?
आप until unless की ये
24 किया था ये तुमने कितना दिया अच्छा लेकिन देखो बेटा इसके मेरे साथ उसको 26 दे रहा है 24 किया था ना उसको I'll take 26 mm screw here, only 2 mm extra.
Yeah.
Because I want to take maximum. Okay, let it be 28. Okay, let it be 28.
So
Okay.
in this also, sir, we are taking 22 plus 4, 26.
Yes, it's 20. It's 24. So I am taking 28.
Okay,
They
okay.
have just said that's 24.
Yeah, yeah.
So I am taking 28. Okay.
Okay, sir. Okay,
4
fine.
mm extra.
Yeah.
And again for couple of millimeters.
Yes, yes.
I will take help of my assistant, so
Yeah.
that soft tissue will not get entangled. Okay.
Yes, sir.
Dr. Vipin is helping me out. Vipin, ऐसे पकड़ लो बेटा ना, for a couple of minutes only. Screw 28. Yes. Start. ठीक है ना? Short. Okay. ठीक है ना? Okay. So. Short. Is it there at right place? और अभी स्पेस है अपने पास है ना, थोड़ा सा स्पेस है अपने पास है ना. Okay, so short.
Sorry.
Okay, so it's okay. And now I'll put the C2.
Was usually लेते नहीं हैं
22
उसको. हाँ. Sir.
हाँ.
Is bone graft in between this one or
No, it's not in between.
Okay.
Because it's not possible.
Okay, okay. So there's no space.
There's no space.
Yeah. So you have just decorticated and you are
Yes.
fixing it.
After reduction,
Yeah.
you'll see that I'll get a space.
Okay, okay. Okay.
So now my C2 is in. Okay. Short. Good. And
yeah,
now I will take the advantage on this side also. Remove both heads.
और उसको यूज सेकंड करने के लिए चलेंगे. Yes. जब वो आएगा, yes, तो जो hold, then आपको हमेशा एक क्या हो. हाँ, ये तो ऑलरेडी उधर से आपने खींचा तब ये दिख रहा है आपको ऐसे. अब जो थोड़ा बचा है जब दोनों सेट करोगे तो एवरीथिंग विल बी पॉसिबल है. और आप अप्रिशिएट कर सकते हो कि हमने जब पूछा मतलब
ठीक ही है. ओके, लगाओ. अरुण लगाओ. सीवन में लगाओ तुम.
लैटरल जैसे आप के नीचे मीडियल पे लैटरल
फ्री देखना, फ्री जाए है ना, फ्री है.
मीडियल टू
चलो सीटू में. टाइट कर दो.
जिस जगह जाना है उसी जगह ये नहीं गोदलिया जाना है और सिगरा का रास्ता जाना.
ओके, ठीक है साहब मेरे हिसाब से. हाँ, टाइट कर दो उसको. ठीक है, चलो ठीक है, ज्यादा मत करने, दोनों लड़ेगा वहाँ पे, जाने नहीं देगा.
तो दो चीज एक्चुअली इम्पोर्टेंट है, एक है लेंथ
करके थोड़ा सा और जाएगा यार ये, है ना?
ये बहुत ज्यादा है।
ओके, मैं थोड़ा सा और अंदर पुश करना पड़ेगा।
सॉफ्ट टिश्यू
पुश करो बेटा।
हाँ
मैक्सिमम मैं लॉक कर देता हूँ अभी।
बिल्कुल।
Okay, so I'll take a fluoro now.
Yes, sir. Please.
Short. Okay.
Yes.
And you can see your C2 is down.
Yep.
Okay.
Yeah.
It's totally down.
Yeah.
And the CT scan will come out beautifully. You'll just see it. Okay.
We are all.
I still have a pretty much space.
Yeah.
And I'm just tightening it down.
Yeah.
Now I am shifting my focus on opposite side.
Yeah.
Okay, let me do it a bit more. And
It is
then
already appreciable.
It is well appreciable that
We have
massive
started
amount
from
of
this.
reduction has
Gap
been
was
achieved.
this, and now
You can compare the pre-operative and post reduction
we'll
pictures.
do a CT scan immediately. And
we always
then
do
we'll
CT
see.
scan in post-op.
Okay, and as I have
So everything
said,
should be clear.
I always believe in the divergent screw fixation.
Post-op से निकलेगा फिर CT कराएगा तब और
यार तुम ये हाँ
we'll check everything.
ठीक।
ये कहाँ रहे हैं?
So I am locking my C1 screws.
Yes, sir.
Sorry, C2 screws.
C2, sir.
C2
Yeah.
screws.
Yeah.
And that I'll try to keep in divergent manner. Okay.
Yes.
My construct both.
Yeah. Yeah.
So my
So
C2
look,
is fixed now.
now
And now
it is-
I'll
this is for check of the rotation.
tighten my C1.
Yeah.
Okay. So my this side C1 is almost done. And that I will again do after breaking the head.
Yeah.
And now I'm tightening it on left side. Okay.
Yeah.
Take X-ray.
Please.
Okay.
Yeah.
It is. You see that is the pre-op.
Yeah.
And now you can see
The-
post-op.
So everything is up.
Now the C2 is down.
Yeah.
And in post-op CT scan, you'll see that is almost, got stuck with your C1.
Yes, sir. It is appreciable here now.
I am doing the final.
Thank you very much, sir.
Okay, so I'm taking MEP now.
Yes, please.
Okay, so MEP is fine.
Yes, sir.
Okay.
Yeah.
And now I'm going to break this head.
Yes, sir.
Okay.
Yeah.
So I'll tighten it more and then I'll break. Okay.
If you can appreciate the pulsation there. Look at the pulsation. So this is a one indication for like, okay, so we have done the adequate decompression is there. So you don't need, now you are asking about taking out the C1 arch assimilated. If this is there, its pulsation is there, cord is well pulsating, no need.
चल ठीक है निकला हुआ है ना देख लो हैं दिख रहा है ना ठीक है no okay so I have asked my assistant to see that both side rods are there okay so both side rods are there तोड़ने के लिए जुगाड़ तोड़ने वाला and now I am breaking it okay
yes
so it's very simple maneuver just do it and it is out. One side is out And the another blade is, I am cutting it, okay?
Yeah. Yeah. Out.
So it is gone. And now it is converted into a simple polyaxial screw.
Usual C1.
I am again doing my correction on the tightening of
This,
the.
always we cheat with complex CVJ stuff.
दिख रहा है?
we will say. Yeah.
तो tight करो. Divergent.
Yeah.
कर दो, tight कर दो, complete tight कर दो.
Yeah. Like.
So my assistant is tightening it on another side. Okay.
Yes.
So I will tighten it more. Let me
Yeah.
break it first.
Yes, sir. Yeah.
Okay, and so it is gone.
Yeah.
One blade is gone. निकाल दो, निकाल उसको. And now I'm cutting the extra head length on that side also. Okay.
Yeah.
So it is done. And now I am augmenting my fusion. First, I will remove a lip of the, C1 posterior, occipitalized C1 posterior arch.
Yes.
And then I will augment both the joints.
Yeah.
And
With the bone.
first,
Yeah.
I will do a final tightening. Again. Okay. Of all the 4 screws.
X-ray. Okay. So, sir, can we take a X-ray without retractors?
Sure. There is no retraction.
No. Outside the soft tissue.
Sure. Let me tighten it.
Yeah.
Let me tighten it and then we'll take a final X-ray.
Yeah. So that everybody will able to appreciate the.
We'll post
correct.
just, try to do a CT scan as soon as possible.
Yeah.
And before, finishing the second case,
Yeah, will so.
we'll try to have a CT scan. Okay.
Yes, sir. Yes.
So now you can appreciate even the BI has been corrected.
Yeah.
In the X-rays.
You can already see, the cord,
Yes.
how beautifully it is open now.
Yeah.
You cannot apply, your
Yeah.
so you need to keep it on C2 and then tighten it. Okay.
Yeah.
So all done. And now I am going to do decompression. Now I'm taking the X-ray. Okay.
Yeah, please.
So let the pre-op X-ray there, and the final X-ray we'll put alongside. Take a shot. Okay. So now you can appreciate the difference.
Yeah.
Okay.
Yes.
Okay. So
Yeah.
we'll take
So
a CT
here is
scan
the
also,
final.
and
Without-
there you'll see a very beautiful reduction.
Yeah.
Got it?
Everything is out. So that is. Thank you very much.
It is pretty down. I understand it's very difficult to appreciate, but I'll tell you what is there. You
Yeah.
can simply see
Yeah.
how you will see.
Yeah.
You see the pedicle margin of C2 in the pre-op X-ray.
Yeah.
That is the pedicle margin.
Yeah.
That is the pedicle margin. Okay.
Yeah.
That is the pedicular margin. Okay.
It's almost kissing.
Okay.
Yeah.
And this is your
Yeah.
tubercle.
Yeah.
Okay. Now you see my screws are a bit up.
Yeah.
Okay. My screws are a bit up,
Yes.
but there's no problem. I'm very much away from the hypoglossal canal.
Yeah.
Now you can see your pedicular margin is here.
Yes.
You understand?
Yes, sir.
So that much of difference actually you have created.
Yes.
It's almost kissing there.
Yeah. That's why. I was-
So you appreciate the difference from here,
Yeah.
and it's almost fixed. We'll
Yeah.
see it in, post-op scan.
Yeah. Perfect, sir. Thank you very much for a lovely demonstration.
Cutting नहीं चाहिए, diamond चाहिए.
Thank you so much from OT side.
बड़ा दिन है. You can appreciate, your distraction from here also.
Yeah, yeah.
Okay.
Yes, sir.
See how
Yes.
beautifully it is distracted
Yeah.
there.
Rahul, both.
They're cutting it there. Cutting it there.
No.
Siam हटा दो. We are removing the Siam, okay?
Yeah, please.
And ask them to,
We are always
second case.
overprotective. So
Second
that's
case
why
can
we
do
are doing the decompression here. Okay. We don't want to go inside again.
कह दो 5 मिनट रुक के.
And also we'll
आपको
use this
ठीक है?
bone as a
उसका दिन
some supplementation
करें,
in the next one. Yeah.
हाँ हाँ दिलवा दो. Now I'm asking, I have asked the anesthesia guys to give the relaxant.
Yes.
They are giving the relaxant
Yes, sir.
so that extubation will be a lot smoother.
Yeah.
So you can appreciate even in difficult scenarios. 2 mm. You can put your lateral mass screws pretty easily.
Yes, sir.
It requires
Patience.
a bit patience and very good assistance.
Yes, of course, sir. I forgot to mention it. Apologies.
Yes.
Yes.
It's very good assistance
Yeah.
is required because you see
The very
how
vital.
beautifully they have retracted every soft tissue.
Yes, sir. Yes.
ये बोन सब रखते जाने. Only problem of targeting the upper part of anterior tubercle is injury to the hypoglossal canal. Otherwise, there is no problem. After occipitalization, your basic occiput and anterior arch of C1 is a single segment. Okay. So, if you know the position of your hypoglossal canal, there is no problem. You can always go up. And now we will take, after that case,
Yes, sir.
a small break. Okay.
Yes, sir.
And
we'll discuss the radiology of
yes,
the next case.
discuss the radio. First, I'll try, to put a small overview of occipital fixation.
Yes, yes.
Why
That will
it
be
is
nice.
needed
Yes.
in some cases.
Yeah.
Many people are saying that it should be abandoned. But
Yes,
you
yes.
cannot abandon it. Okay.
Yeah.
So I will take a small lecture, a presentation
Yeah.
on relevance of occipital fixation in current times.
Yeah.
Okay, and then we'll discuss the radiology of the second case.
Yes.
शालिनी को लेना है, शालिनी सुनो, शालिनी को ना, शालिनी को लेना है. Then we'll discuss the radiology of the second case.
Yes, sir.
And by that time, our anesthesia colleague will induce the second case.
Yes, sir.
And I just forgot to mention,
Yes.
my regards to my anesthesia colleagues and especially my fellows.
Yes.
Professor Dr. Manoj Tripathi is in charge of today's theater
Oh,
of anesthesia, and I am highly thankful to him.
thank you very much, Manoj. If you are listening me.
I don't know he's inside here or
Yeah.
he's sitting outside.
Yeah.
But second is blood ले लिया, blood है अपने पास. There are two PDF, PDCC candidates
Yeah.
of neuroanesthesia, Dr. Kavya and
Yeah. She's very good, sir. Very
and
sincere.
Dr. Nalini.
Yeah.
Dr. Nandini, sorry. Dr. Nandini and Dr. Kavya. So they are both doing their PDCC neuroanesthesia, and we are truly blessed
Yes, sir.
that we have them. उठा लो यार, निमिषा का फोन तो नहीं है, देख लो
Sir.
मैडम को. I am keeping all that bone, with me for doing fusion.
Say first find the posterior.
In fact, you
lateral
can
side.
take out
Always
the
there
spinous
lateral.
process of C2 if you want.
The bone. Take it out. No 3+3. No. मैं वही इसलिए पूछा कि वो आप उसी लिए पूछ रहे थे. तो बस
कौन है बेटा?
Take it out. बस.
Drill. ठीक है. निमिषा नहीं थी ना? 48 नंबर नहीं है ना लास्ट में? अरे तुम देखो अंत में 48 तो नहीं है.
Sir, hopefully in 10 minutes you will be finishing your case.
Yes.
And then you will come here and then we can start discussing the second occipital one.
Yeah, sure.
Yes, sir. Good.
Sir, one last question.
Yeah.
What is your strategy for ACM?
Pardon?
Sir, for carry malformation, what is your strategy?
Okay, so right now, in all ACM cases, we are doing C1, C2 fixation. But that we augment with posterior bony decompression. Okay? We are not opening up dura because I have cases of post-operative CSF leak, and we are getting good results only with C1, C2 fixation and posterior decompression.
So no intradural work now.
No.
No, we are not opening up dura even in ACM cases right now, and we are getting very good results.
So
very good results.
Sir, foramen magnum decompression and C1, C2.
Foramen magnum decompression.
Okay.
Along with C1, C2 fixation, we are doing bony decompression only. Bony foramen magnum decompression. We are not doing duraplasty. We are not opening up dura.
Okay, sir. Thank you.
The beauty is because I have seen, and actually I have done it one of our sawbone models, that even in a normal person,
Have some micro.
there is a 3 mm space
Yeah.
between the C1 and the C2,
Yes, sir.
the anterior tubercle and the odontoid.
Yeah.
And when you put C1, C2 spacer, C1, C2 screw and fix it, there is opening of anterior CSF space. Okay.
Yes, sir.
So that is the philosophy behind C1, C2 fixation in ACM. What Dr.
Yes.
Professor Goel is saying, that the cause of ACM is C1, C2 instability. But that is not true, because if that would have been the case, we will find ACM in
Okay.
every
I will
case.
reply. Don't worry.
Okay. But this is not happening.
Yeah.
Even in most of the ACM cases, there is no mobility.
Yeah.
Okay.
Sir, there is one question from on Zoom because we are on live.
Yes.
So question is from Prashant Singh. He's asking, should we have to decompress the foramen magnum first, then have to go for C1, C2?
See, I have my MEP with me.
Yes.
I have, very good technicians.
Yeah.
So I am doing it. Now I am relaxed. Okay.
Yeah.
I have done all my things.
Yeah.
So I'm quite relaxed now.
Yeah.
I don't want to waste my energy.
Yeah.
Initially.
Yeah.
But again, if you don't have MEP,
Yeah.
you can do it as a first step.
Yeah, that's why I was trying to answer. So the thing is actually it depends upon the situation and stuff is available for protection and safety. So if you are going without MEP, so try to do it like especially in the assimilated cases, do first decompression and then all the maneuver. Otherwise, if you are confident that you have done with the MEP and it is already checking, then you can go in this way.
So I have my MEP and EMG recording all the time.
Yes, sir.
So that's why I didn't do it as a
Yes,
first
sir.
step.
Yes,
Obviously, if you don't have that, you can do it as a first step of your.
yes, sir. Yes. Thank you, sir.
Okay.
Any question? Audience? दो मिनट में गाड़ी का ड्राइवर का नंबर बोल देता हूँ. 2 मिनट में सामान.
Now it's, it's quite safe also because canal is already opened. Okay.
Yes, Dr. Deepak. Dr. Deepak, just wanted to know one thing.
Yeah.
Was there any change in your results that convinced you to start this C1C2 fusion in ACM cases, or just because of this, the radiological parameters you just discussed the thing?
See, when you do duroplasty and posterior decompression,
Yeah.
you are opening up only the posterior CSF spaces. Do you agree to that?
Yes.
Okay. And you try to establish the CSF pathway from the posterior side.
Yes.
But the problem is there is tonsillar herniation there. There might be lot of arachnoid bands which can promote retethering. And there are cases you must be seeing that the syrinx is not resolved. You know why?
Why?
Because your CSF space get obliterated again. Because of.
But in many such cases, we used to do subpile.
Let me finish.
Yeah.
But the anterior space, anterior CSF space is virgin space. There is no pathology lying there. Okay.
Yeah.
So if you open it up, it will remain opened up. And I am telling you with my personal experience, I have not a single case of ACM failure or syrinx not resolution. All the syrinx have reduced in the cases in which I did C1, C2 fixation along with, I'm not doing it alone, along with posterior fossa decompression, only bony decompression. So that's my philosophy, because the anterior CSF space is virgin. When you open it up, there are no chances of getting it blocked again.
Okay.
You have to open the CSF space. That is the philosophy of the ACM surgery. Okay? So
Okay.
that the CSF pathway is established and your syrinx will reduce.
Actually, that also remain the reason behind the augmentation duroplasty also. That is why you are going to put this graft and you do this Y-seped and
Yes,
whatever.
you can do duroplasty, but when you put lot of screws, there is always a danger of getting a CSF leak and infection. So there is a lot of controversy. There is no doubt about that regarding ACM. Okay, whether you do only bony decompression, whether you do,
Yeah, there are lots of philosophies
arachnoid
behind that.
dissection, tonsillectomies, lot of things are there.
Yeah.
I can only tell what we are doing. We are doing bony decompression along with C1, C2 fixation, and we are getting very good results.
You don't open the dura and do
No,
nothing.
I don't open dura. Anupas is there, I think, no? Anupas is asking that question, I think.
Yeah, exactly.
Okay, boss. So, boss, we are not opening up dura.
Okay.
So, we are doing only C1, C2 fixation along with posterior fossa decompression, bony decompression.
Thank you, Deepak. Thank you.
You see, now there is no kink on the CVJ, okay?
It is well opened. It is
Yeah, boss.
the entire CVJ is well opened.
Well opened. Exactly.
You can see the occipital dura as well as the
Yes.
cervical dura
Yes, yes, yes.
and a beautiful angle in between. Transition of that angle. It's beautiful, beautiful. A very honest submission, Deepak. This is the first ever I am seeing the minimum amount of blood loss I can appreciate. This is a very appreciable thing.
Sir, the beauty is, and I can say you with, proud that all the residents who are trained here,
Yeah.
okay, they are doing very good job as far as the CVJ pathology is concerned. And I am getting very good pictures, from all across the country. They are operating in Pune. One of my, resident is in Sikkim. They all are, the flag bearers of this CVJ surgery. My two residents are here in Lucknow only. And I'm getting pictures from them. And I can proudly say we have developed this, technique of doing almost bloodless surgery. And
sir, that's why the main aim for this workshop was to spread our wings and hands
Yes, yes.
with the colleagues, and we have such a awesome dedicated colleagues. So I am sure that in next month what we are getting is like 100 cases of complex CVJ with the all like using very everything is fine and doing all this stuff across the country.
yes. They now have an idea of how
Yeah.
a bloodless surgery is done.
So now they have faith, I think.
Yes.
Idea was there, but they were not faith. They were not able to recognize, even see that, okay, so there may be this surgery can be done in like 100 ml of loss, and reduction can be easily achieved.
Okay,
and
so
all.
our posterior decompression is also complete.
Yes, sir. Yeah.
Okay, and now I'm going to put a lot of bone graft.
Yeah.
Okay.
Yes, sir. Yes.
So first I will wash it up with antibiotic saline.
Yeah.
And then I will put my bone graft.
Yes, sir. Please.
So wash karo. And you can now appreciate, okay? Let me
sir,
show you.
Yeah.
Now you can appreciate the open joint here. Okay, distracted joint here. You see? See, this is a C1. This joint is almost open now. You see? Left side. Rakesh, can you see it?
Yes, sir. Yes.
So it is, you see, like 1 centimeter distraction is here.
Yeah. And you
Okay.
can use this.
And I'll put lot of bone here.
Yeah. Which was not possible before
Yes,
this.
yes.
Yeah.
It was not possible before.
Yeah. Sir, Rajan sir is here.
Okay.
Sir, you are welcome.
Most welcome, sir.
Sir, we have just update. So we are about to finish our first surgical demonstration, and hopefully in 5-10 minutes, sir will be here, and then we'll.
Professor Bhatnagar, sir, is professor and head of the department of anatomy department, and he's always very supportive to us.
Yes,
and
sir.
Right now is the chief medical superintendent of our institute.
Yeah.
And he has promised to us that from next year onwards,
We are doing here.
we will do all the cadaveric things at least.
Yeah.
in-
Definitely. Absolutely.
Thank you, sir. Thank you so much. Wash. Side, not over the call. उसे मैच मिक्स कर लिया ना सर। हाँ। मैडम तो अभी आई नहीं है, क्या तो सर मैं 10 मिनट में आ जाए, मैडम भी आई नहीं होंगी। नहीं सर 12:30 का मैंने बोला था मैम, बोला था तो होने वाला सर, क्या तो 10 मिनट में आ जाए, बैठ लेंगे 2 मिनट वहां पे और क्या करेंगे। Dr. Manoj, anything specific about the anesthesia point? Can you hand over mic to Dr. Manoj? Anything specific about anesthesia in CVJ cases?
It's not very specific. Actually, the thing is, we have started neuromuscular monitoring. So the relaxant is not being given in this case.
Yeah.
And we have continued the whole anesthesia without relaxant with the help of propofol and dexmedetomidine and inhalational agents.
Okay.
That is the only thing.
Okay. Okay.
Thank you.
Thank you, Manoj. Thank you.
And what about intubation, Manoj? What about intubation?
We didn't wanted to, give a lot of movement at the neck C1 C2 because the surgery is on the C1 C2.
Yeah.
So we have done manual MILS manual for that.
Yeah.
And intubated the patient in that way.
Okay.
It may be a bit difficult, but we have done it.
Okay.
So we have all the modern gadgets in anesthesia department also. We have video laryngoscope. We have, all the modern gadgets. So they can safely intubate any patient.
Yes, exactly.
So Manoj, Rakesh here.
Yeah. Yes, sir.
Yeah. So just asking what from anesthesia point of view, what are the indication for particularly going for fiber optic like intubation points? So is there
we could have done fiber optic intubation in that patient.
Okay.
But we had easily done it with the MILS and normal intubation.
Okay.
Because
Okay.
the airway was not difficult in that patient.
Okay. Okay.
But in that patient, we could have done fiber optic intubation if there was any difficulty in airway.
Okay. So like main thing is pre-operative assessment of your airways and the opening and everything.
It was nice and
Okay.
the patient was MPS grade 2.
Okay.
So we didn't have got any problem in intubation with MILS maneuver.
Okay. Thank you very much.
Okay. Thank you, sir.
In the second case, we are going to do a hybrid fixation. Okay.
Yeah.
Because I will see the radiology and I'll tell you why.
Okay, sir. Okay. The second thing is we are also on YouTube and Zoom.
I think.
A lot of things from other places are joining there.
छोटा मोटा मसल से है वो तो
Very nice, sir. We are
Okay.
getting the
चलो,
questions.
phone.
and everything. So- Yes, sir. Yes, sir.
Number
So उसपे भी इनको करा दिया है. Yes. Yes, sir.
पिन उठा डालो माइक उससे डालो
Yeah.
इस कोऑर्डिनेट रख लेना
Which solution, sir? It's most probably amicus in where you gentamicin most probably.
See, this is the main step. Okay. You
So
have
now-
to put a
now
lot
an
of
appreciation
phonograph in
joint,
between.
which were not before, and then we will able to put all this to fill it properly. Fill it. And during this, I don't know you have noticed or not. So you have to put a medial a cottonade. Yeah. So no expillage in the canal, and then we will put everything down. Yes, sir. Yeah. Yeah. So it's a mixer because we have mixed it from some bone. We have done the assimilated part. We have taken out, and then again.
बचा है अभी उधर देते किधर ही हो जाएगा अभी और हाँ कराओ कराओ बिल्कुल कराओ
Try to full everything like in joint and around the C1 we have created because there is a raw bone there also. So everything should be in one go.
जैसे ही क्लोज होगा इसका ट्रैक्शन हटा को लगा देना ठीक है माइक्रोस्कोप सेट करा देंगे सारा सिस्टम से बनाओ मैं नीचे से 10 मिनट लेक्चर लेके आया ठीक है ठीक है लाओ इधर ले लो अभी तो है काफी है ना अभी काफी है और लो
Yeah. Yes, the crush.
Yes, Rakesh.
Yeah, no, there is one request. So recorded video will be available. Yes, it will be available.
We will give it to you.
Yeah.
Don't worry.
Yeah, don't worry. bone graft.
Lot of bone graft.
So we have taken bone graft we have cut the assimilation or the decompression mass.
You can always take,
the
bone
picture.
graft from the iliac crest and from the rib.
Yeah.
I have taken, it from the lip of occiput.
Yeah. So the
And-
decompression part we have done and we have
Yes,
utilized
and
it.
I
Yeah.
have mixed it with,
Yes.
artificial bone graft,
Yes, sir.
and I am putting in between.
Yes.
I am getting very good results with, the master graft of Medtronic.
Yeah, it's good.
So it's a bit costly,
Yeah.
but your ultimate aim is fusion. So don't hesitate, to spend couple of bucks more, because especially in women, because most of our population is osteoporotic and they don't have a tendency for good solid fusion, and that is one reason of settling after a couple of months.
Yes, sir. That is the ultimate goal for all the fusion surgery.
Okay, so I have completed it on right side, and now I am going to put bone on the left side. Okay. So I will remain a bit gentle here because my vertebral is there laterally. No.
नहीं वो काफी प्रेस करता है अल्टीमेट ये मत सोचो कि इसको होल्ड करके रखे
Couple of months back, I got a nick inside the vertebral artery from this bony spicule itself. So, if possible, buy a bony mill. I don't have it.
Yeah.
And make a paste. That will be a lot easier to apply, and that definitely has a better fusion potential than these, chunks.
वो एकदम सीधे रास्ते वाले आदमी हैं। हमें सबसे अच्छी बात लगती है कि कहना वाला नहीं है एकदम सीधे रास्ते जो इजी हो काम होना चाहिए एम पक्का है अपना भाई ये करना है ये
So if you are buying a Medtronic drill,
yes sir,
ask them to give a bony mill also. When I was young, I bought these things. I was not aware. Later on, I realized that I should have bought it, and definitely I'll buy it in future. Okay. If you are into spine, you should have bony mill.
yes sir.
So my surgery is finished now,
Yes sir.
and I will remove the microscope.
Yeah please.
And it's very standard closure over a.
Yes sir, everyone.
Okay.
Yeah, everyone is very familiar with this one. So
Okay. So
yeah, thank you very much sir.
thank you.
Thanks a lot.
But I'll join in a couple of minutes. Okay.
Yeah please.
Okay.
Thanks a lot.
Right. Thank you.
Next. Divakar.
इसको
Just
mic-
prepare
mic off कर दो इस वाले को।
case
हाँ, हाँ,
already for radiology discussion and all. So sir,
वो टूटेगा।
sir,
मैं आ रहा हूँ बस अब।
hello. KD.
Yes,
Any-
yes, Rakesh.
Yeah. So next case, which one we are taking? So Salini.
I am taking, the girl,
Yeah.
which has one vertebral, fenestrated vertebral through which is joining again through the, after passing through the pedicles,
Okay.
and one side is hypoplastic. That is Shalini.
Okay,
So
that's
if
fine.
you can put up the radiology of that.
Yes, yes. That's why I am asking.
Let them discuss.
Yeah.
Okay, and let have the views of the viewers.
Yeah.
So what's their plan?
Yeah.
And I will come down and I'll discuss my plan.
Okay, sir. Okay. Thank you very much. Thanks. Okay. Vishnu, ask everyone to come inside and we'll serve coffee here. Okay. Yeah. Slide इस पे डालो. I will request all of you to take seats so that we will start the second case. A very interesting case. Good. So this second case, which is being intubated for a surgery today, is a 26-year-old female presented with pain and restricted neck movement since 3 years, with progressive spastic quadriparesis since 3 years, and difficulty in performing fine movements with both hands. So it's like all the spastic quadriparesis event. Then this is the sagittal mid-sagittal image. So I will run through all the images and then we will start discussing, so that everyone has a all like broad picture, and then idea will come what is your opinion and everything, and then lastly we will disclose our final thing what we are going to do. Okay. So this is the mid-sagittal image, and we'll appreciated this, and this is the 3D. So everything is there. Okay, you can appreciate we are not able to say surely that which one is the dominant side. You will see the caliber. So like usually what we find is like one, you can easily say, oh, there is no, so this one is the dominant, this one is the non-dominant, but this, I'm not sure which one is the dominant. Okay. And everything is sitting in front of you where you want to go. This is the CT. Okay. And again, and this is the picture of one thing. Yeah. Yeah. So in this, it is a very interesting finding the radiologist, especially Nihama has mentioned, I was not aware honestly, about the right fenestrated vertebral artery behind the joint. Okay. Then another anomaly. So I don't know, maybe you, sir, will also comment. Sir, I would like to comment from you, because we have, because I was reviewing the last approximately 150 cases. Okay. And then I found that if there is some vertebral anomaly, even the one joint, usually what we get is this robust natural protection of posterior element. So, and it is 2 and 3 fused. So now we are going in reverse, trying to find out, is there any significant particular relation? So if you'll find just in the X-ray, if you'll see the 2, 3 is fused, then what percentage we are getting the anomalous particle? So we are, this is a research topic, just ask. And this is a very significant find. Even you will see the X-ray in OPD, and then you say, no. There should be something wrong. So just like anticipation, sitting in the first time you are seeing X-ray, and then you can anticipate, no, there should be something else. So I will like planning and everything will be according that. Okay. So next is bilateral C1. So 2 ms right and left lateral mass. We can appreciate a good lateral mass, but whatever anomaly is there. So I don't know anyone will try to do or not. Okay, let's discuss. Then this is the particular images. One side is a good pedicle C2. One side you are not able to even a paper, like just a paper thin, which Dr. Neha has mentioned yesterday very well. Okay. And look at the orientation of the joint. So it's already slipped anteriorly. And this is the actual picture of 1-2 joint orientation. So one side is vertical, almost vertical. Okay. Then We'll go back. Yeah. So in this picture, with all this anomaly, what will be like a main thing for the management, regarding management? Anybody, like you should say, okay, so I will do this, I will do this. This is my concept, I will do this. Occipital C2, C3. So you are going to utilize, like you are counting this one as 1 and 1 below, or you are like, because 2, 3 is fused, so posterior limit. So you will consider this one as a 1 unit and then go back. Like, so this one below 1 and then occipit. Yeah. And anything, sir, for this vertebral stuff for fusion purpose or? Yes. Yeah. 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 Okay. Yeah. Just a minute, sir. एक और दो. Mike, please. That's what I wanted to point you to tell your opinion. It's a very good point.
Obviously, and the second thing, on the right side,
Yeah.
C2 purchase cannot be there because of very thin.
Yes, it is.
We cannot place a screw in that.
Practically,
That is out of our question.
Okay.
So occipit, C2, C3,
Yeah.
and C4 bilateral.
Yes.
Even if this this construct will not appears to be appropriate during surgery,
Yeah.
then we may add further one spine below that.
Yes,
Also.
of course, of course.
Oh.
The main thing is, sir, there is two components, as you mentioned properly. So BI, and especially the orientation of the joint. One is fine.
Totally,
I mean,
it is completely vertical.
Yeah.
This joint is completely vertical.
Yeah. So one side is vertical. The main like bullet point is we are trying to find out something which we can use to bring it back.
To bring it back.
Yeah.
Yeah.
So if you'll see, one is vertical, so you are not able to do anything there. I think. But what about the other point, like other side? Do you want to? This is absolutely is like a 45 degree.
That I one occipital plate, then
Yeah.
C2 left.
Yeah.
And then C2, C3 is already fused.
Yes, sir.
And then a C4 bilateral.
Yeah.
And C5 bilateral.
Okay.
This I would this long construct because we are not getting we are not having C1.
Yeah.
We are not
Yeah.
having that is C1 is out
Yeah.
of question
So-
because of that
Yeah.
this vascular anomaly.
Yeah.
And C2 is only half.
Yeah.
That is available to us.
Yeah.
C2, C3 is only half of that available to us. And then C4 and C5.
Yeah.
This
So my straight question for you is,
Yeah.
do you want to use a spacer in this or not? Straight.
Spacer how it will
This one. This one, to reduce BI. That's what I'm asking. So you can't use that side, but there is a space to use. Yeah. So right or left.
on the left side.
Yeah. Because for
But-
BI, it's a significant BI. So that's what I'm asking.
But there is vertebral artery just in front of us.
So look, this is fine. This one is like, this one is right or left.
Joints appears to be appropriate, but it is the vertebral is overlying on this.
And which side is the predominant, do you think? About the vertebral? Just asking that. We are not sure which side is.
Because of the larger lumen of the
Yes.
left side.
Yes. So
Larger lumen is on left side.
left side. So most probably we are planning for occiput 2 and 3 or 4, whatever.
Three or four. Well, yeah. This will be my planning.
Okay. Yeah. Because sir, there is nothing to do. Not even you should try on this side.
We cannot even handle that part.
Yeah. We are not doing this.
We cannot handle. C1 is out of question and C2 left, C2 right side is out of question.
Yes.
So we have just C2 left
Yeah.
and further below spine, subaxial spines.
Okay. And sir, do you, my third question is, do you want to take something like a pedicle? Look at the pedicle here.
Which
Opposite
pedicle?
So C2.
C2
Yeah,
pedicles.
one side is very fine. So you can lever it. Yeah, you can engage it. What was the opinion? Like you were
Yeah.
leaving two segments.
No, C2 pedicle, we are going to put a screw in the C2 pedicle.
Okay, so one side unilateral.
Unilateral C2 pedicle.
Perfect. And so opposite side, sir?
Uh,
Would you like to take some
C2 right pedicle is out of question. It cannot be.
other any option for transplant? I was just wanted to know
Then the
for anchor point on the opposite side.
lamina.
Translaminar is
I have never put it, so I will not
that's
tell.
fine, that's we are
Pedicle is a good thing
Yes,
where we
of
have
course.
a proper
First option
strength.
is- Yeah, first option is.
So and below C2 you have pars and everything. You
Yeah.
can put pars, you can put pedicle, but
About past, we have to see the CT.
trans.
2, 3.
But that is not going to reduce your C2. Point is to reduce the C2 for anchor.
ये तो opposite का है. This one is fine. Vertical. Then 1.
To reduce the C2, we do have only one option. This
Yes.
This left C2 pedicle.
Yes. Sir, this
As I think so.
left CT, as you mentioned clearly, one side pedicle is fine. We are taking that one. Opposite side, I'm asking to, do you want to take one additional?
You want to say this see, because the C2 C3 is fused,
Yeah.
and we have navigation.
Yeah, and it
So so we can put this pedicle up. This we can use the pedicle of C3.
C3 pedicle. No. So, sir, my question is like we are suppose we are using this. So here we for this left is one, left side.
Hmm.
Right side there is no pressure for pedicle. Okay. Then right side opposite one we are not able to take. And one is going with opposite to one. So additional point of next point of opposite you are getting.
C3 C4.
C4. Okay. So in between this, especially you are taking both like PI, good side PI there.
Significant VI.
So you need some good like
To reduce that.
in between. Otherwise, there is a chance for rotation and settling. So then what option next? So that's why I'm asking you. So the next option is yes, soft facet, I will say there is anomalous arch and everything is there. So don't go for soft facet. Okay. Yes. So the main thing here is like option available is a robust. Ma'am is yes. Ma'am, good afternoon, ma'am. Please. Thank you, ma'am. So, ma'am, we have finished first case, and we are discussing the second case, radiology, and DK sir is coming in between, and then we'll proceed. So, with due permission, ma'am, we can continue discussion. Thank you, ma'am. Thanks a lot. So that's why I was telling you, if you leave two segments in this complex patient with significant BI and AED, 100% there should be some kind of settling or tilting or rotation. Okay. So what we need is we have a good anchor at one. So we will go again in the same principle. So if both sides, definitely there is natural protection. There is. So God is great. So he will provide a one wrong thing. Definitely he will give you a one positive thing, a strong thing. Same here. One side vertebral is anomalous, opposite side anomalous. One side there is almost no pedicle, nothing, but opposite side you see they're robust body. So utilize that one as an anchor. and just supplement with the second one, which is transmantle. Like lamina is big, massive lamina. So just for taking like breezing this, so occiput 2, 3, and then yeah. So translaminar, I will say. Yeah. 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 So sorry, sir? Transarticular. Because practically speaking, in these kind of patient, it is very unsafe. Okay. and we don't want to wiggle too much with this complex bony vascular. Like when I first see this patient in round, so I was like, what is this? Like both sides, where we are going. So like both side is dominant vertebral and it is on the way. Like vertebral is sitting and preventing you. No. You are not going to put a screw here. This much is like clear-cut indication. And we are not sure. Either we have to do some intervention first if you want to very sure that this is predominant, this is non-dominant. So you have to block one intervention, block one vertebral. Even after that, there is 30% chance that you will block one side. You will get posterior fossa, everything. So brain, everything. Even 30 minutes of block. So ideally is like you go, you block, you inflate balloon, and you will see patient because it will be done in the local intervention. And you'll ask patient that everything like fine or fine. And then 30 minutes is fine patient, then you can block this vertebral, it is fine. As per literature. But 30% there is chance that you will get neurological deficit even doing after that. Okay. So don't complicate. Simple way, simple thing, patient should be fine, patient should be safe, and discharging a patient from neurosurgery is always a great event in life.
Sir, what about the reduction of BI in this case?
Yeah, so then what that's why I was thinking there is one side alignment of the C1, C2 joint is fine.
Joint you need.
Okay, so we will try to put something, especially bone graft like thing, because it will, we are not expecting too much of distraction. If you go for the distraction, I will show you here. Look at this joint. Okay. So the main thing, that's why I was asking with Anu boss, BI ka kya karna hai? So BI ka simple, BI you have to push back, down. Otherwise, you're not going to do things. That's why Sarachandra technique is like you'll put a spacer, bring it down, and then you lever it. So this is a technique. Okay. So and the same thing we have discussed yesterday also in the meeting, that only indication for us to think even is the occiput subaxial fusion. Okay. So now we'll try to put something, bring back, and then lever everything to anchor. Okay, sir. Sir, we have sir basilar invagination, ma'am. So the invagination. So invagination was the C2 inside the foramen magnum, like the compression on the craniovertebral junction. Yeah, we have discussed and we are just.
I think every one of you have got a very good idea how to do a bloodless surgery. And I'm pretty sure you have seen it from masters, you know, from across the India, and lot of blood was there. Okay. And it is like a bloodless surgery that we have demonstrated. And we are going for, you know, I just got a word from the anesthesia guy that patient is being extubated right now. She is all fine. And we are putting her for CT scan. And before finishing this case, we will show you the post-op scan also. Okay. So
just for your information, the case we are discussing or we have done first case, it was one of the like complex cases of CVJ. And honestly, everyone sitting here can easily appreciate the ease, like less than 100 ml was lost. Usually we have in the my residency period, one of the great CVJ surgeon of India, I will not be going to take name. He operated 4 cases. And 3 were die at the evening due to blood loss. And one was like 8 units of blood, and we are rushing at the rate in blood, and it was hell. Same happened in the Delhi conference also. So the main thing is
chair pe karke.
yes, so ma'am, that's why we have shared the trick. There. Sir, ma'am, I will just brief you here. So this is like 3D model for the posterior one. Okay. So you will appreciate this is the like some fusion is there. This is occiput part here, and one is occiput like assimilated fused with the occiput upper part. Okay, and this is 2 and 3 fusion. So once there is anomaly, the bony anomaly always comes with beloved one with the vascular anomaly. And you will, this is a very rare type of picture and very complex picture because you can see the 2 loops here. And the same loop is coming here. So it is usually lateral. So vertebral will be lateral and then inside and then pica will find. In this case, both are coming at the joint. So we don't have any opportunity to drill the joint, to fuse some, support some screws and all. So that's why we are wiggling all these things. What is the like best safe way? And this is the second case. Unfortunately. Yes, ma'am. That's right. If they want, yeah, no, we are going to operate this one. We have finished the first one. Okay. Sir, you can. Yeah.
So accordingly, we have done that everybody will get a chance to see what we are doing on the cadavers. And on the second day, on the similar concept, what we have learned yesterday, we have done this slide shaping. So that we get accustomed that what was being shown there, they actually have an idea on the practical system. So that's yesterday.
Yes, ma'am. Yes. Yeah.
KGMU. So we have like 70 people here from all across, all CVJ interested, and we are doing it live on YouTube and game also. And there is a YouTube channel that
Yeah.
us live on that also, and a lot of people are watching and asking questions.
So good afternoon, everyone. So it's a great opportunity that our respected director, Madam Professor Sonia Nityanand, is among us to bless us. So I would like to, what can I speak about her? But there are very few things which I would like to re-emphasize again, that she has a long career of being a very esteemed researcher, which is spanning more than 3 decades. And it is because her able guidance and constant motivation that we had planned this workshop here. So I would request our director, Madam, to please take a seat on this seat on this stage. So I would also request our respected Bhatnagar sir, our Chief Medical Superintendent, and a person who is always there to, who is a troubleshooter, who is always there to help us, to guide us. So I would request Professor Bhatnagar sir, who is the CM Chief Medical Superintendent and Head of the Anatomy Department, to please take a seat on this stage. We have also among us Professor Malviya sir, who is the Head of the Department of Anesthesia Department, and he is the ex-director. And under his able guidance, we all started our program here. And his support and motivation has been constant, not only in providing anesthesia, but also as a senior, as he's a father-like figure who has been constantly motivating us. Thank you, sir. Thank you, sir, for coming.
So, respected ma'am, Bhatnagar sir, Malviya sir, I just want to get, give an overview of what we have planned, and we'll try to make it as an annual event, and we'll do it again on, large scale. And since, there are a lot of people in India, neurosurgeons, who are not very much accustomed with that difficult surgery of CVJ, we are trying to make, since our department is doing very good job in spine, and Rakesh has joined, he's good in deformity, and our CVJ program is also going up. So we have planned to do it, and by your motivation, your support,
We did a cadaveric workshop yesterday, and we are doing a live surgery demo today of two very, very challenging cases, and that is being telecast live across the India and across the world. And Madam, thank you. Sir, thank you. Malviya sir, thank you. And I invite you please to do a ceremonial light, lamp lightning for that, to, a formal inauguration of this workshop. Please, ma'am.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। ओम गणपतये ओम गणपतये नमः। ओम गणपतये नमः। ओम गणपतये नमो श्री सिद्धि विनायक नमो अष्टविनायक नमो गणपति बाप्पा मोरया।
I just request Director Madam to say a few words of blessings and guidance to us.
Dr. Malviya, Dr. Bhatnagar, Dr. Deepak Singh, Dr. Kaif, Dr. Rakesh, and all other esteemed faculty members of the Department of Neurosurgery and in the audience and all other participants. A very warm welcome at the outset on behalf of Dr. Ram Manohar Lohia Institute of Medical Sciences. It's very heartening to hear from Dr. Deepak Singh that people from all over the country have come and are participating, and there are also people who are online. So it's actually very heartening to observe that. And I understand that the CV junction surgeries are difficult and challenging, and very specialized, need a very high level of expertise. So this whole concept, I think it's a wonderful concept of, generating human resource in this area by people who already have a vast experience through first cadaveric demonstration and then a live demonstration. So congratulations, Dr. Deepak and your team for this concept of going about demonstrating the difficult surgery. And I hope, like you said, that every year you continue this event, because it's institutes like this who are, tertiary care institutes, which must, spread or give the expertise to other people. So I understand that you're doing 10 to 15 surgeries per month, and all of you have gathered a huge amount of expertise in this area. And it's a good thing that you have the desire to spread it now to other neurosurgeons of the country. And what I also, for some time, I used to, I got to see a few patients of rheumatoid arthritis, and I know that a long-term complication is a CV junction abnormality. And we used to dread at SGPGI where to refer the patients and what to do with the patients. So it's heartening to see that there are approaches now to treat this in a bloodless manner, in an avascular, without damaging the vascular structures around. And you have mastered that technique. And I know that Dr. Deepak Singh has a patent also for a screw, and he has a lot of experience using that screw also, which makes the surgery more easy and more with lesser blood loss. So congratulations again, all of you. And I hope you continue this endeavor in the next year also. Every year this endeavor is continued. It's a very wonderful concept. Thank you very much. And I hope you have a great day of learning.
So I would like to propose the vote of thanks. Thank you all for coming. And I'm really blessed to have all our seniors, our guide, our mentors here. Thank you. I request you to proceed for the lunch now. Thank you.
Sir, since we have finished one case and there will be time gap in between, so we have planned the lunch, and our second case is being intubated right now by Manoj, and then we will start up.
Who's operating the second?
Second line. Four cases actually I am. So we both are very complex cases. So I think in that manner, we have shown our technique of CSC2, and second, we are going to demonstrate our hospital. So it is the plate that we have devised. So both are patented. At KGMU, we have said the problem of rheumatoid arthritis, actually we got all outside from the state itself. They are getting a lot of patients for CVD pathology of rheumatoid arthritis. They don't have even congenital. It's a problem of all countries. Now we are seeing much improvement towards it. But they are getting CVD pathology after rheumatoid arthritis. There's a very indication in the West. And the problem is
long-term RA.
Yes. The destruction. When this drug came, and it was like everybody was thinking there is a medical problem. And now again, when cycling is revolving. So we are again at the 12 o'clock, and everybody says, no, there is a long-term complication with the years and years, and this is the problem.
So they have actually a lot of failures. Pre-existing, hospital based system, there is no internal locking mechanism. So in our state, we have overcome that problem, and now there is internal locking, so it won't, put out. And for that only, they have taken our design and the process of getting FDA approval. And maybe with time, we will get an FDA approval also, and we will do
this plate.
So that is in process, and I think I will be able to demonstrate you how I use it in the second case. So let's proceed for lunch then.
Yeah, of course. So you need that now.
Everybody appreciated when we are planning for everybody saying over then there is a thin line, although you could discriminate between academic, educated, and we could make them like a cooling. So you don't have any designation, faculty could start. So much of question, basic question, lead question. I know every when I started with the country and everything was free. सबने किया You know what is program training making? Now it is dedicated now.
Hello, hello, hello.
Hello, mic check. हेलो
हेलो, हाँ ठीक है। हेलो, 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 हेलो। क्यों नहीं आ रहे? देखो, नहीं नहीं, हेलो, हेलो, ठीक है। तुम बोलो उधर से, माइक पे आओ। आवाज चेंज हुई ना, ओटी चेंज। हेलो, हेलो, हाँ, एक मिनट दिखाओ हमको। ओ, टीवी पे आओ, टीवी के सामने आओ, तुम कैमरे के सामने आओ।
हेलो 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 माइक चेक हेलो
ये तो, हाँ, अरे नहीं आ रहे यार, ये तो।
हेलो हेलो मैं क्या इसकी आ रही है हेलो
हाँ, इसकी तो आ रहे हैं।
2 मिनट के इधर ही से बैठ जाइए हेलो हेलो माइक चेक हेलो हेलो हेलो
हेलो,
हेलो माइक चेक
हाँ,
कलर माइक चेक है
कलर में क्या आवाज दब रही है यार।
हेलो हेलो दब रही है
हाँ, बढ़ाओ थोड़ी,
हेलो वेट
बढ़ाओ थोड़ी, इसको बढ़ाओ, बोलो,
हेलो हेलो
और बोलो।
हेलो
तो हमको कैमरे सामने आओ, देखो कलर माइक कहाँ लगाया हो।
हेलो 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 माइक चेक हेलो
अरे इसको थोड़ा आगे से तिरछा करो, फोल्ड करो हल्के से, आगे से बिल्कुल आगे से, बिल्कुल माइक के पास से, मुंह की तरफ करो वहीं से।
हेलो
हाँ,
हेलो
चलो,
हेलो हेलो
हल्के हल्के से और बढ़ाओ,
हेलो हेलो
और बढ़ाओ।
हेलो 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 माइक चेक हेलो 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 हेलो
चलो ठीक,
हेलो
चलो ज्यादा ज्यादा मान मत करो, वो पकड़।
हेलो हेलो चेक ठीक है ना
हाँ ठीक है,
ए भाई
अब यहाँ से ले लेंगे, चलो।
हेलो हेलो माइक चेक हेलो हेलो
दोनों माइक खोले हो फिर, इसीलिए तो ज्यादा खोलने वहां के लिए दिक्कत होती है, जगह नहीं। अरे यार, वहां जब ऑपरेशन चलता दोनों खुले रहते हैं, दोनों खुले रहते हैं ना, समस्या ये होती है। दोनों खुले रहते हैं, समस्या ये हो जाती है ना। एक सर्जन जैसे तुम लगाए हो ना, जो दूसरा ये खड़ा तो इसमें रहना जरूरी नहीं है।
Hello. Change करो. Laptop. Laptop दो. इधर है सर. हाँ. ये अच्छा है सर.
अच्छा है वो जो है पर्सपेक्टिव.
ये सर इसको भी दूसरा लगा दो. यही लगा दो. कोई क्वेश्चन. मॉर्निंग में आपका एक. हाँ
इसका प्रोजेक्शन दे दो. इसका प्रोजेक्शन दे दो.
इसका प्रोजेक्शन दो कंप्यूटर का.
So this is our optical plate, okay? Ask everybody to come inside, please, okay? Please, everybody come inside with your lunch packets. You can keep on having your lunch here only, okay? You can keep on having your lunch here. And we'll show our occipital plate. This is the old version, where for sake of easiness, we have made a gutter, but now it's a simple occipital plate. Here also there is only a single hole. Okay, it is joined together. So this is a short video, only of 2 minutes, and you will get an idea how this is helping. Okay, I am marking my occipital screw points, the central gutter, and the burr hole that I was going to put. These are for outside in occipital screws, and now I'm making the burr hole. I have made a gutter in a key-shaped fashion. This is the gutter through this burr hole. Okay. Using a 2 mm burr, I am deepening that gutter. And now this is the sole of our occipital plate. It has a foot plate. Okay, it has a foot plate which is going inside the occipital bone, and over that I am putting my plate. So you need not to have that gutter in the plate also. You can simply put it over here. Okay, then there is a washer. Now we have changed the design a little bit. Now we are putting our occipital screws first, and then we are putting our washer so that it locks over the occipital screws also. It is available yesterday. So now this occipital plate is there in place, and I have put our occipital screws also, and I am cutting that projected part, and that is how it is locking your occiput from inside out. You got the idea? So it will not come out. It will break, but it will not come out. So that is about the occipital plate. Okay, and is this do you want to see something else, or should I move to the the case discussion? Because I have some videos how to secure the fixation, how this idea of putting the inside out screw come into our mind. I'll just give an overview why this occipital fixation is needed. It's still needed in the present time. Okay, so sure boss, sure. Okay, so do we need that in present times? every other talk you must have heard that, the only thing is C1, C2 fixation. It is not like that. Okay. You may require your occipital fixation in, many scenarios. How? So what should be the surgical procedure? What is your choice? It should be simple. It should be reproducible. It should be risk-free. Okay. So if I am doing something and my student is not able to replicate it, then it's not of worth. It is of no worth. Okay. What I am doing, everybody else can do. Then only it's worth. Okay. I may be extraordinary. Someone else may be extraordinary. But if it is not replicable in your scenario, that it cannot be a standard procedure. That is the first thing. So if I am able to do C1, C2, in a very complex manner also, and you cannot do it, then it cannot be propagated, in teaching institutions. It has to be simple. It has to be reproducible. First thing. So what are the challenges of putting a C1 lateral mass screws? I think I have discussed it. First is vertebral artery. You see the incidence of first intersegmental artery is almost 26% in CVJ scenario. Okay. Then fenestrated 7%, extradural pica 6%, and total incidence is like 40%. It's not always possible, to mobilize the vertebral artery in such a manner that you are able to get a good fixation into the C1 lateral mass. You may develop your technique over the time, but for the initial, practitioners, it is very difficult. So sometimes you may resort to occipital fixation. Sometimes C2 fixation is never a problem. It is never a problem. Okay. And yesterday you have seen the kissing carotid arteries, anterior to the vertebra. So again, there is a problem. If your C1 lateral mass is very thin and you are not able to get a good bicortical purchase, and if you go for bicortical purchase, there are good chance that you might hit the internal carotid artery on the anterior aspect. Veins are not a problem. But if the carotids are coming into midline and very close proximity to the anterior arch, there are chances that you might injure it. Okay. So another thing. You may have, heard it a lot of times. You have seen videos that people are repairing vertebral artery. They got inadvertent injury during surgeries and they are repairing it. Is it risk-free? Mobilization, is it risk-free? Is it not? There is no literature, I searched PubMed, what is happening to the vertebral artery 10 years after, where we have mobilized it, or where we have sacrificed one hypoplastic. If it is not required, why God has made it? There was no need of two-sided vertebral artery then. So if we say that it is non-dominant side, you can sacrifice it, it is not actually true. Maybe we are not, keeping the data also. Maybe after 20 years, the data will come that patients in whom we have, sacrificed the non-dominant one, they are having, more chances of posterior fossa TIAs and most posterior fossa strokes. Okay, because the demand increases with the age. And when the arteries get atherosclerotic, then actually pictures come into view. Okay, so we are not following the data of these patients, what is happening to them after 20 years. So it is not always risk-free to mobilize these vertebral arteries to sacrifice the non-dominant. Okay. When I search the literature, about the cases in whom they have to sacrifice the vertebral artery, like in cases where there is vertebral artery dissection. Okay, it is not related to CVJ. You can see, you can see that in cases where the artery was non-dominant one, still the chances of cranial palsies was 9%, 10%, 2%, almost 20% complication. Even if you sacrifice the non-dominant vertebral arteries, we are not taking care of what is happening to the cranial nerves. Okay, so it is not risk-free at all. First thing. Then lateral mass anatomy, obviously, this is of paramount importance. Like this case, where both sides it is absent. Okay, very hyperplastic, you cannot put it. But again, there is in that cases where the C1 is occipitalized, there is very good solid bony mass anterior and clivus and anterior is fused, and it will give you a very good bony purchase for putting up a sort of basi occiput and what you call anterior arch bony mass. Okay, so hypoplastic C1 lateral mass again is a limitation. This is again a picture of hypoplastic lateral mass. And one thing, this is clivus segmentation anomaly. This is not true AD. It is a pro-atlas segmentation anomaly. If you put C1, C2 screws here, you see it's almost in line. It is not an AD case. So what will happen? It will go more anterior and the compression will increase here. So here you have to resort to your occiput, like in this case, you have to resort to your occipital fixation. You need to decompress this part. Okay, so only thing required is decompression here and a fixation right from occiput to the cervical spine. Okay, so always read your radiology before putting up your screws. This is not a case of AD. This is a case of clivus segmentation anomaly. But you may, get an idea that I'm going to operate on AD, and you simply put C1 and C2 screws. Okay. Again, then the joint alignment. See, like in this case, if you want to put your C1 lateral mass screws, your trajectory should be like this. Okay. And what comes in between? Your occiput. So you should, you have to, drill that part of occiput first so that you can align your screws in the proper manner. But then what will you lose? You will lose your occiput C2 joint, the pseudo joint that Dr. Sarat Chandra has described in literature, that there are chances, like in this case, you can very easily see C2 occiput. Here is the joint. This is the occiput C2 joint. And in grade 3 cases where the sagittal inclination, like in this case, this is the C1 C2 joint orientation. Okay, it is almost vertical. It is more than 165 degree as per his classification scheme. So he will put a spacer here, occiput, C2 cross translaminar, and he will do this here. But if you have planned to put a C1 C2 screw, then you have to drill this part out. Then only you can achieve your, purchase your C1 lateral mass. The trajectory is so. Okay, so if you have planned for DCER, you cannot do it. So you should be very much clear in your thought process what you are going to do, because if you plan DCER, do DCER. If you are planned to do lateral mass, okay, be confident enough that after that drilling, I will achieve purchase into the C1 lateral mass. Otherwise, don't touch it. Because once you lose that part of occiput, you cannot do anything then. Okay. This is the classification scheme given by him. Is joint remodeling possible in all cases? He says where the sagittal inclination is less than, 3 categories, 1, 2, and 3. If he says the joint inclination is that much, he simply put a spacer over in the C1 C2 joint here and do a C1 C2 fixation. Okay. If the inclination is like this, grade 2, he advocated remodeling. That I have to remodel my joint and make it grade 1. Okay. And then I will put my spacer, and then either I will do C1 C2 or will do occiput C2 for DCER. But third scenario, he always uses in that much inclination occiput C2 joint for putting up the spacer, and then he do occiput cross translaminar screws and do DCER. But is this possible in all scenario? This joint remodeling, it is not possible, because your vertebral artery you have seen is at stake in 30% of the case. You cannot remodel it into the coronal plane. Full length coronal plane remodeling is not possible. I'm telling you. You can do it in sagittal, and any literature, you go through it. They only show sagittal angulation correction, and that can be done only in 5 mm bit, 6 mm bit, but in the whole length, the coronal angle, the sagittal angle, joint remodeling is very, very, very good. So you cannot remodel all the time. Okay, so DCER can be done, but I'm not sure that it can be answered to all the questions. Okay, and then again in that scenario,
You are relying on your optical city joint that is far away from the problem. Here the problem is a C1 city joint. And where are putting your screw? We are putting a optical into posterior element. We are putting a person into optical city joint. The problem is here, you are doing everything here. Okay, so this is one thing. That I have explained. Another important thing, we are not taking care of this. You know, it's a vital find the vital. There is very robust data now that if you fix your human system hyperextension, it's a vital find the solution. If you look at that, both surgery will be applied. And that hyperextension prevention is possible only with human system. Because you have the liberty, you know, to leave a part of even screw behind, inside, screw behind, inside. You don't want to fix into hyperextension. Okay, that is possible only with C1, C2 fixation or occiput C2 fixation. You understand? But not with wiring. And if you want to have a long correction, okay, maybe over the time this will become the standard practice. This optical go down slightly side. 10 years down the line, we are not following the protocol. Maybe in all the patients in whom we are doing C1 fixation, only stroke fixation, because you know it's very impractical to correct your hyperextension, you know, in bit lower or more side with C1 C2. It's difficult. Wiring is not possible. Even with C1 C2 fixation, it's difficult. So maybe down the line, this will become the standard practice. I'm not, you know, sure about that, but it is a possibility. When the data will come after 20-25 years, and these patients are poor patients. They stop coming to your OPD after 1 year, after 1.5 years. So data, if it will come after 15 years, then we will be able to answer this question. Okay. So this is one thing. Another thing of importance, they say if you do occiput C2 fixation, cranial settling will happen. Okay, it's not like that. Only thing of importance is that you have to create a different weight bearing segment. Okay, so that is where here you put your spacers. In our practice, wherever I have put spacer inside the joint with occiput C2 fixation, I have not seen a single case of cranial settling. So pure occiput C2 fixation, you should always avoid. And if you are doing that, you have to create another weight bearing pillar. And that weight bearing pillar is that spacers. So occiput C2 fixation without spacer is not a good idea. But if you are getting a good reduction in your AD with occiput C2, if it is a mobile AD, you can always use your occiput C2. If it is a mobile AD, no problem. But always put spacers. Fixed AD, it will not reduce with occipital fixation, but mobile AD, it will reduce with intra-op maneuvers with head positioning. There you can do occipital C2 fixation, but try to put, you know, something here. And then it's hybrid fixation that we are going to do in our case. You see the vertebral artery on one side, it is the problem. I cannot mobilize it. I cannot put my C1 lateral mass screw here. So you just put your C1, C2 screw and see the joints almost vertical. Okay, both in set. So what we did, lateral mass screw on one side, and then you can see in the depth. This is the lateral mass vertical. On left side. On the right side, we put both side cross maneuver and supplemented it with. We have not gone through it. Then only can see the data difference. One side is different shading here of reduction, and the active weight is supplementing for next slide. So this is one idea where you actually require architecture. So these are all cases in the and now we come to all these. Any confusion in that? Okay. I think we have seen the radiology of this case before. So what is the idea? There are two things. This is the hypoplastic VA. Okay. Not that hypoplastic. So we try to preserve it. I will do a bit of here. Okay. And then I try to find a place to put my single letter marks. I will do single letter mark and put pedicle fixation here. I will reduce the joint, reduce the pathology, and I will try to find the okay. I will try to find the space, and if I get a good space here, okay, I will put again a letter mark and a partial space. And if I not get this space, if I make trouble, I will supplement this cross mark. So that's my plan. So any input? So, this side, you see on the left side, here the hypoplastic. I am a very good picture. So I will try to focus on this. So this is going to do the election. So I put my whole energy to get a very solid decision. That's it. And then we see what the data
I just wanted to know one thing. In a routine normal C1 C2, and in cases of occipitalized C1 and C2, don't you find difficulties in the depth which remain very much in occipitalized C1 cases? Don't you feel encounter difficulties in such cases?
And more constant is the space. Okay, but you have to overcome that, that problem. And I think by using microscope,
That hardly matters.
you can actually get into that. And I always use, monopolars. I don't use, scissors, because scissors after cutting, a little bit of bleeding will start. Then you'll again coagulate it, will again cut. So I always would use monopolar to clear up this space. And it is very easy now. Since the day I have started using that Colgate needle or fine tip monopolar, it become very easy, even to explore the depths, and I can easily find the lateral mass even in very difficult scenarios. If I find that, it's very deep and I'm not getting a proper, space to put up my screws or, the retractors for my assistant, I always drill a part of overhanging C2. The C2 that is coming in between my C1 lateral mass and my instruments. That angle I always want, in a straight line. So if there is a part of C2 facet that is overhanging that space, I just drill it down. I avoid only one thing, that I have to prevent my pedicle at any cost. So I don't drill medially, but on lateral part, I always feel free to drill part of C2 that is coming in.
To make the area a little bit flat.
Yes, sir.
To make your
Definitely. So that's the whole idea.
And the second thing, it is recommended that if you are going to perform in cases of occipitalized occipital C2, they used to recommend to make this construct to involve C3, sometimes C4 also.
Sir,
What will be your opinion on that?
Sure, sir. This is actually a different, philosophy altogether. And actually, I am, also collecting my data on that. There are cases in whom there is high grade AD and BI. Even after immediate, very good immediate post-op CT scan and very good immediate post-op recovery, they came to me after 2 months, with failure, even after C1, C2 fixation. So I have actually, thought of, and in few cases, even after doing a very good C1, C2 fixation, I have supplemented it with occipital plate with lower down subaxial cervical spine.
Up
That
to
I
what
have done.
extent? Up to what extent you prefer?
Sir, usually C2. Usually
C,
C2.
C4,
C2. So I have cases with me.
C2, 3, 4, 3.
C1, C2 is different, C1, C2 is a different fixation segment. And then I supplement the occipital plate with the C3 and 4 lateral muscles. I don't, take the C1, C2 fixation with the occipital plate because it's very difficult to align them. Okay. So I C3, 4 separately, I fix with occipital.
And what you prefer in C3, 4, whether it is because you have navigation, pedicle or pars?
Again, C1, C2.
No, subaxial.
No, it's always
Pedicle.
lateral mass.
Lateral mass.
Always lateral mass. Without actually O-arm, it is not recommended. It is not approved also.
That is what I'm asking.
I always use, lower down cervical spine. I always use
Lateral
lateral
mass.
mass or sometimes transverse screws.
Sometimes.
Transverse. So transverse screws also I am using right now, but most of times lateral mass.
What will be your opinion regarding C1, C2 transarticular?
Transarticular, the prerequisite is that it has to be, reduced before putting up your screws. And that is practically not possible in almost all
cases. Most of these cases remain associated with the BI also.
Yes, BI also, and you cannot reduce it. So you have to reduce it first, and then only you are able to put your, this transarticular screw. So it is easy to do it in mobile AD cases and the trauma. But for congenital AD and BI cases, it's practically not possible because you cannot reduce it by your maneuvers only, and you need to drill your joint, and you need to put your screw, and then with help of them, you are getting reduction most of the times. So transarticular is not this. And again, then again, one thing is that you have to, counter the rotation. You have to put wiring, and then you cannot remove that lip. So practically, I am not doing transarticular.
And during last case, when you were operating, we were discussing regarding the ACM and the ACM and syringomelia. How would you justify this? Because the single joint where this rotational movement we used to have, and that is your C1, C2. How would you justify in a patient of syringomelia, because it will be last once you will fuse it? You're getting my point. You were
Point that if it's not, there is no pathology, why you are fixing it.
Yeah.
Okay, because C1, C2 is a highly mobile. But the problem is, sir, that these patients, ACM patient, the symptomatic. Okay, they are in so much trouble. So they are in so much trouble that if you fix your C1, C2 joint also, how many times I'm just asking you this question that they are complaining of, restricted.
They are not having rotation.
Because lower spine usually, compensate for it. Usually compensate for it. They will talk about, some restriction of movement. There is no, doubt about that. We are putting it into stake. There is no doubt about that. But the results of syrinx resolution is definitely better with C1 superposition. In at least what I am seeing. If you are opening up the anterior C1, anterior, CSF space, the resolution is faster and recurrence chances are very, very less. Failure chances are very, very less. So at least in our center, we are doing, I think, fixation in every ACM case, and we are getting resolution in every case.
Complete resolution.
Complete. 1-2 cases are there. There is significant reduction, not complete, but very significant.
It has been said that if you will perform a proper duroplasty augmentation and everything, the syrinx, even if it will lie, even some amount of syrinx will remain there. It is not going to affect, because the resolution of syrinx is not the idea. Idea is the foraminal widening. Foraminal widening.
But But the CSF flow, if you re-establish the CSF flow, you know, the strings will develop itself. That's also.
Thank you.
So, we started, okay?
Yes. Anyone else? If
You go through it, and if you feel anything, you need anything, you know, to understand, to ask, you have to, okay? Chalo, Rakesh,
Yes. काम कर सकते हैं दिवाकर और उसको प्लेट के टेम्पल होगा प्लेट तो वो यहाँ सबूत लाइक प्रैक्टिकल हाँ एक हाँ दूसरा सेट जो हुआ है ना जो खाली हुआ है वो सेट को भिजवा देना प्लेट वाली सेट ठीक है ताकि सब लोग बात देख प्रैक्टिकल जो हो जाए तो देखिए वहाँ पे
Hello, Arun. Anyone from theater now? Hello. Hello, Arun.
Yes, sir.
Where? Hello.
Yes, sir. Yes, sir.
हाँ कहाँ पे हो?
We have started to open the second case, sir.
Started or not?
Yes, sir. Started. Almost completed.
Okay. Because we have finished the discussion and sir is going to theater to join you.
Okay, sir.
Okay.
Okay, sir.
Okay. And KD is here or not? Kuldeep is there or not?
Yes, sir.
Okay. So if SCM people is in theater, so can you request for us to send the first occipital plate or the first set which is unsterile to the hair, so that everyone will see the space like a specimen of the occiput and reduction screw, and then we'll see the surgery. It will give us idea about like hands-on experience and then seeing the same thing. So it will orient us. Okay. उसको exactly So, boss, actually, you are the senior most, so I'll ask one question. No. So, what is your like usual practice in Azamgarh for these kind of like C1, C2? What you are doing? Like, do you have the especially regarding like you are following Atul sir concept, or you are following the
see.
Yeah.
I can just say मेरे ख्याल से सारे लोग मैं I am also here as a student.
No,
लेकिन लेकिन just I wanted to say one thing. There are many and we should be proud that all the concepts, though they evolve with Dr. Meninges,
yes,
who was the first one who started this CV junction surgery in the world. And I was fortunate enough to hear him in one of the conference in AIMS. And he started this CV junction surgery in that era when everyone was considering these CV junction as completely inoperable cases. in way back in somewhere in 1980, 1978, he started focusing himself on this CV junction. And Dr. Menges, he is an Indian born neurosurgeon settled in US. He belongs to Goa, and he in way back in 1965 he went there and he got settled there, and even to the world, the person who introduced the CV junction surgery can be performed with an acceptable level of complications and whatever. That was an Indian, and all the recent evolution in CV junction surgery. From in 2000, Dr. Atul Goel sir, in 2010 approximately Professor Sarat Chandra sir, and 2015 Dr. Deepak Singh. All these four people are Indians. I can say Dr. Sushil Patkar sir, again an Indian. So we Indians always remain a leader in the field of CVJ surgery. So we should be proud for this. And let me tell you one thing, those who are interested in CV junction surgery, because everyone who is sitting in this hall is just because of he's interested in CV junction surgery. When I was resident, I'm talking about in 2005, I started that this surgery I'm not going to perform in my life, because I saw 2 patients, and finally SSR1, the last responsibility were hand over to us, and we arranged the ambu bag, asked with the Charak pathology fellow to arrange an ambulance and oxygen, ambu bag, whenever and we hand over that ambu bag to the patient mother or patient close relative, keep compressing like this, and the patient remain in post of completely quadriplegic. A quadriplegic patient, and whenever the mother was tired enough, because you have to compress it, patient is having complete involvement of completely respiratory involved patient, complete quadriplegic. I thought this I will never do. Then the resurgence of my interest in CVJ when I saw the surgery of Professor Atul Goel. But even that was quite horrible. Well, you can see after completing his surgery, he comes to me and he put his hand on my shoulders. Anup, looks easy. Because sir, in some hands. He laughed at me, but when I returned back from KGM, the first surgery which I performed, let me tell you at what stage. I completed my MCS in 2007, September. And I performed my first CVJ surgery in April of my 2008. So it is not that much difficult. The only dreaded point was the bleeding and the close proximity of the vertebral artery. So we as a surgeon, we used to remain, but if you will see, even we have much more bleeding many of the times in a routine EDH patient if we are not getting if we have not remained very close to the middle meningeal. In some cases of contusions, in some cases of sinus bleeding, we used to have many more amount of bleeding as compared to CV junction surgery, with which we used to remain afraid. You are getting my point. So, and the other thing which I learned from Dr. Sudhir Dubey from Medanta. Anup, whether you have performed enrichment surgery, sir, I am planning. No, it is not required. Planning is not required. Because sir, then what? Just jigra.
Hello, Dr. Rakesh.
Yes, please.
Hello.
Yes.
Yeah. So was I asked to show the variations in occipital plate and reduction screw to show on camera from OT?
No. I asked there is one honest trial set. So if ACM people will send that set to here, and then everybody will see and everybody can get a like hands-on experience.
So I send these things to the lecture
Auditorium. Yeah.
auditorium. Okay,
Yeah,
thank you.
please. Thank you, Ben.
Before sending it, can I show on camera? Then everybody will see
That's
there.
fine. We are going with a very good discussion with Anup sir, so we are happy.
So, okay, I'm straightforward sending it.
Oh, yeah, please. Thank you. Thanks. a
I'm
lot.
just sharing my experiences with you people, just to come out from your fear that it will bleed. One day I asked with Professor Atul Goyal sir, whenever he used to travel from Lilavati to KM to Lilavati, sir, if vertebral get injured, then see how the leaders and teachers, they used to respond to your question. I have injured 5 times. I was silent. Good, sir. Then what? I just tighten my screw. Simple. The patient will be unfortunate that he is getting injury on both the sides. It is his fault. I just laughed. But never happened with me that I injured vertebral on both of the sides. So see, one thing, complications are bound to happen. There is only one way to avoid complication: don't operate. And whatever is going to happen with you, that has happened with everyone who is doing that particular surgery.
Anyone say in any complex, even the simple surgery, that he have operated more than like 500, 200 cases without any complication, I will say he has not operated single patient. Honestly. And this is right. So if you are going to do surgery, there are complications. Even in the best hand, you will see the literature say like less than 1%. 1%, there is 1%. We don't know who is 1%. So
it is, and teachers always used to say like this. In conferences, the people will explain you the beautiful figures and beautiful post-op scans and everything. But you have must heard, every neurosurgeon used to have some, what is called as, some caves, yards.
The more you operate,
the more
land
you
will
have.
expand. जितना ऑपरेट करोगे उतना बढ़ेगा, कोई बात नहीं. लेकिन other than that one, the best picture is you are dealing with like complication. The land will show like how complex you are dealing. So तुम अपना वही chronic SDH कर रहे हो तो ठीक है, खुश रहोगे. It's fine. If you are fine, then you are fine. But you want to operate on CVJ, so definitely there is planning, there is ways, there is learn. Okay, so just try to avoid this. This is part. But you start operating and you will say, oh, 100 ऑपरेट कर लूंगा, एक भी कॉम्प्लिकेशन नहीं होना चाहिए. ऐसा नहीं होगा.
How to avoid pneumocapillus? How to avoid recurrence?
Hello.
These are
Rakesh, you are getting me? Hello.
Sir, are you able to hear me? Hello.
Wait, hello, wait.
ये थिएटर है, ये थिएटर से आ रहा है.
Just to
Hello,
conclude
Dr.
that,
Rakesh.
learn with everyone.
Hello, Dr. Rakesh.
Rakesh, are you able to hear me?
Yes, sir.
Okay.
Yeah.
So again, that standard, opening.
Yes.
Since I have planned, to maybe I need to put the occipital plate also.
Yeah.
So we have, exposed right from inion up to the C4.
Yes.
Subperiosteal, midline exposure. And we will explore the left side first as planned.
We are only able to see the Siam view picture. Otherwise, we are not able to see any clinical picture.
Are you able to listen?
Yes.
Okay. Dr. Kuldeep is here. He will, redirect the question. Don't worry about that.
Okay, sir. Okay. That's fine.
Okay. Thank you, Kuldeep. Again, you know, the OT setup is same.
Yes, sir.
Okay. My
Yeah.
Siam is on cranial end
Yes.
and my assistant is standing right to me.
Yeah.
Okay. I mean, nursing assistant is standing right to me.
Yeah.
And my assistant, Dr. Vipin, is standing very next to me. Let it be here. We'll do it on that side first. So, okay, our exposure is pretty standard,
Yes, sir.
and we are not exploring the right side now. We have left the muscle attachment and everything there. Okay.
Yeah.
And because you see one fenestration, one part of the vertebral artery
Yeah, right. side
is
muscle.
coming from inside the canal.
Yes.
Okay.
Yeah.
And one is going lateral to the pedicle, and they both are encircling the pedicle and joining cranially.
Yes.
Got it?
Yeah.
So if I keep on dissecting, I have to remain very low to the superior border of the right C2 lamina,
Okay.
because I might enter inside
By
the
doing
canal and can injure the fenestrated vertebral artery,
Yeah.
the part which is running inside. Okay.
Okay.
So first I'll dissect the left side out,
Yeah.
and then I'll see what I can do on right side.
Right side. Yes.
Okay, got it?
Yes.
So I am taking my microscope now.
Yeah.
Microscope. इसका हम लोग के पास मॉडल भी बनवाया था ना, आया नहीं वो शायद.
Model is not arrived, sir.
Actually, we have made a 3D model of that for
Yeah,
sake
we
of
requested, but it's not arrived.
demonstration. Unfortunately, that is still in transit, and it didn't come from Jaipur in time. So I will keep looking into the 3D picture again and again.
Yes.
Okay.
Yeah.
And there is no shame in re-looking at your radiology all the time. What you can do, you can, ask your assistant who is on the floor
Yeah.
to keep all the running CT scan videos in his mobile phone. If you are not having any software for that inside your theater, and you can rerun every time if you want to have a look on the width and length of pedicle or your screw trajectories.
Yeah.
So that I have asked. Maybe I'll look into that. Okay, but
Yeah.
now I'm going to do it in very standard fashion. And you can see now the loop of the left vertebral artery is
Sir.
looping medially.
Sir, sorry to interrupt you. We are not able to see the proper clinical picture. So can I request cameraman to see? Yeah, switch.
Okay, I'll just focus it. Okay, don't worry.
Yeah.
Don't worry, I'm focusing it. Okay.
Yes, sir, please. Yeah.
ये चश्मा निकाल देना शबनम, मेरा चश्मा निकाल लो. Okay, so in 3D scan,
Yes, sir.
you can clearly see in the vertebral artery loop on the left side is more on the medial side.
Yeah.
It is dipping caudally on the medial side,
Yes.
and lateral side is quite free.
Yeah.
Okay.
Yeah.
This part is quite free.
Yeah.
So I will target myself, in line to the exit foramina and try to find out my entry
The-
point for C1 lateral master screw there.
Yeah.
Okay.
Yeah.
So let's go and God Almighty is our Savior. Bipolar. Pretty standard.
Yeah.
I'll coagulate and cut. Monopolar. Mono. Colorado. Huh? Number 4 देना दीपक. थोड़ा सा गौर जोश ले दो इनको. Okay, and very easily the soft tissue is so fragile that I have entered into the joint. I'll show you. This is the exit foramina vertebral artery. Okay.
Yes, sir.
I am putting my number 4 penfold dissector over here.
Yeah.
And I'll try to remain medial to that. That is our root.
Yes.
That I'll cut. Mono.
Again, the same maximum magnification is the rule.
So this is our root, okay? This is the root. This thing, okay?
Yeah.
Bipolar. You know, most of time in
Yes.
putting traction over the soft tissue,
Yeah.
root is the only thing which is creating problem. So many a times you need not to remove all the soft tissues. You just cut
Root.
the root
Yeah.
and
It
rest
will
of things
reflect.
you can very easily,
Reflect.
retract.
Yeah.
Because rest are soft tissues, the venous structures. So not always needed. Number 4. You see the joint?
Yes. Now we are.
Okay. So I'll try to, dissect it a bit before asking my colleagues. You see, there is the vertebral artery. Here it is. You can see the pulsation.
Yes, we are able to appreciate, but
Let me show you. This is there.
yeah. No.
Okay.
Yeah.
So I will ask Vipin to put the retractor here,
Yeah.
and he
then we
will
can-
keep the retractor number 4. Sorry, number 1. And I will ask Vipin to keep his retractor in the joint all the time. Okay.
It will get.
And retract it cranially.
Yeah.
And I will complete this drilling thing
Obsidian.
so that I'll get an unhindered
Yeah.
entry into my lateral mass. Okay.
Yes.
Okay. So everything is in Vipin's hand now. पकड़ो विपिन, पकड़ रखना, ठीक है?
So in these kind of patients, the most important thing is like
देखो पतला section.
who is assisting you.
Got it? So I'm reorienting myself.
A very important point which Dr.
Okay,
Deepak had
drill.
just shown.
Diamond.
Be very sure while
आसानी से
cutting
ना
this
तो थक
C2
जाना विपिन, तो मुझे बता दिया करना, ठीक है?
ganglia. Because at times
जब
you
थक
may
जाए ना
have
मुझे बता,
vertebral
ऐसे
just
करो,
anterior.
बिना दीपक
So never cut it
एक
unless
diamond
until you are damn sure, and never cut it without microscope. Here you can see this. Vertebral was just anterior to C2 ganglia.
सही है, सही, बढ़िया, बढ़िया. Okay, so this is pretty mobile. You can see it. This is pretty mobile, and I am drilling this part of C2. I am not going medially.
Yes.
This technique of subfascial drilling we have developed, you know,
Yes.
to put our
Yeah.
C1
So
screws.
exposure is there.
Vertebral is protected by Vipin.
This thing is it will give you direct exposure. it वही पूरा ऊपर ऐसे दिखता है तो आप देखिए.
This is all soft tissue of the joint before me. Okay?
Yeah.
And I will explore it for demonstration purpose. So this is our lateral mass of C1, and I will clear it.
Yeah.
See what I have told you before.
Yes,
That's
sir.
this root will keep coming into your view.
Yeah.
And sometimes you may require, you know, to sacrifice it in a length. So I am going to clear this soft tissue for making my entry point inside the C1 lateral masses.
Yeah.
Okay, got it?
Yes.
So you see how it is keep coming into your view?
Yeah.
Procedure देना micro. पकड़ने काटता ही नहीं है साला. मोनो दे दो. तो पकड़ खींच रखना और में से. Good. So I'm ready with my entry point.
Yes.
Okay. I am just clearing the soft tissues. Okay.
Yeah.
So this is the lateral boundary
Yes.
of the lateral mass.
Lateral mass.
And within hatana, nikal le. You can see the vertebral here. Okay. This is the
Yeah.
vertebral. You can see the pulsation.
Yes.
Okay.
Hmm.
We don't have Doppler, but otherwise you can, you know, always feel it. And this is the medial part of the lateral mass that
Yeah.
I am feeling. Okay.
Yes.
You can always poke a bit to feel. You see,
Yeah.
I have built only the lateral part. Okay.
Yes.
This lateral projection, everything I have left, you know, for sake of strength in the pedicles.
Yeah.
And from medial to lateral, this is the width. And I'm going to put my screw from somewhere here. Okay.
Yeah.
So Vipin again will protect. Vipin. The vertebral artery. And then I will make my entry point.
Yeah.
I have cleared the joint. You can see now
Yes.
how down, how lower your lateral mass is going. Okay.
Yes,
So
sir.
you can drill this much part, still you'll get very good purchase into your lateral masses.
Lateral,
Okay.
yeah.
Good. So I'll ask now my colleague to put to X-ray, to Siam,
Yeah.
and now I will see it before planning my trajectory that I'm able to make up, the anterior tubercle or not in the X-rays itself.
Okay.
यहाँ फ्लोर पे कौन है रेजिडेंट्स में? क्षितिज, इसका रनिंग वीडियो अपने उसमें मोबाइल में ले लो. हाँ, एक बार देखना यार. हाँ, हटना बेटा. मुझे चश्मा दे देना. सुनो पांडे, चश्मा दे. टेक अ शॉट. शॉट लो. गुड. थोड़ा रोटेशन है ना? करेक्टेड. और इधर की तरफ आओ. क्रेनियली, क्रेनियल आओ. क्रेनियल आओ. अब लो. फिर से लो. हिल रहा है, हिल रहा है. लो. ठीक है. जीरो कराओ इसको. ये जीरो नहीं है क्या? ये थोड़ा सा एंगल है. इसको ऐसे करो. इसको इधर लो. अब लेना. है ना? So this bony segment looks like, the anterior tubercle.
Yep.
Okay. थोड़ा सा इसको ऐसे तुमने कर रखा है.
Above that, sir.
इसको हल्का सा उधर करना, नीचे की तरफ. आगे आगे बढ़ा लो. हल्का हल्का सा आगे बढ़ा लो. हाँ, अभी लो.
क्योंकि वो दो दिख रहा है ना.
हाँ हाँ बिल्कुल लो. उसको देखना बहुत इंपॉर्टेंट है. कहाँ चले गए यार? इधर हो ना. Cranial, 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 cranial. Cranial, more cranial, more cranial. Yes, take a shot. Take a shot. Okay.
Yes,
This
sir.
looks like the anterior tubercle. Okay?
Yes.
हाँ, ये parallel नहीं है यार. You make it parallel, okay? There are two shadows of the mandible. इसको डाउन करो, तो से नीचे करो. हाँ, फिर से लेना. शॉट लेना. बढ़ाओ, बढ़ाओ, बढ़ाओ.
It is going in
करो,
different way.
करो, करो. शॉट लो और लो. हाँ, आप करो. हाँ, अभी लो, अभी लो. अभी क्लियर आएगा. Okay, it is somewhere over here.
Yeah.
I think it is the anterior tubercle, and I'll target that point only, and I'll go, anatomical.
Okay.
I'll try to go anatomical.
Okay.
Okay.
Yeah.
Good.
Coffee चाहिए. Everybody. Coffee चाहिए सबको. Everybody is sleeping. Coffee वाले को सबको चाहिए.
यहाँ से देखो तो दिखता है दूर से. चश्मे को चिपका चिपका दो. अच्छा नहीं, निकालो नहीं, निकालो नहीं. उसके साथ ही करेंगे. दबा दो अच्छे से. बस बस. Okay, so Vipin, put your detector now. हाँ खींचो एक मिनट देखो मेरे को एक मिनट आना कीप इट लाइक दैट ओनली ओके हाँ यहाँ पकड़ो
मुझे छुट्टी भी कर देना मैं तब से नहीं छुट्टी फिर कभी मिलेगी तब से कैटेगरी करके आएगा
I'm trying to focus, the surgical field into the center so that you get the good idea.
Yes, sir.
Okay, and now I am going to make my entry point. Okay, so this will be my entry point.
Yes, sir.
And
And
I'll
this will
decide the sagittal angulation after making, the pilot, after doing the pilot drilling.
Yes, yes, please.
My assistant is keeping a watch on my coronal angulation.
Yeah.
Arun, is it okay?
Yeah.
So I'm just doing pilot drilling, perforating the cortex a bit. Please take a shot. And I think I am in right plane. Okay. Maybe I need to go bit down. No? Slightly down.
Yes, sir.
Short. Is it okay? A bit down more. Is it okay? It is. It should be okay. Now. There's bone all around.
Yes, sir.
Okay.
Yeah.
And if you see the C1 in your number 4. Bone wax if you see your C1 in axial cuts, you see there are a lot of black spots there. Okay.
Yeah.
I have seen it. These actually the bony lacunas.
Yeah, and there is a good chance of bleeding.
These are venous lacunas.
Yeah.
And one of the venous lacuna actually has started bleeding.
Yes, sir.
So I am putting a bit of bone wax here.
Yeah.
Cottonide. Cotton is it? Cotton no na yaar. Okay.
Yes, sir.
So you may hit your venous lacunas.
Yeah.
Then pack it with bone wax.
Yeah.
Okay, then go again.
Yes.
It is there if you revisit. Okay.
Yeah.
If you revisit the radiology, you will find in the right side, left side of the C1 lateral mass,
Yeah.
there are a lot of black spots, lot of hypodensities are there, and these are the venous lacunas. Yesterday, Dr. Neha was showing this thing in
Yes,
one
sir.
of the scans.
Yes. Yes. Yeah, we remember.
So these are the venous lacunas.
Yeah, perfect.
So good thing is they always stop with bone wax.
Yeah.
Bone wax. Cottonide. Dissector low. Dissector. Cottonide. The technique is, to put the bone wax and then put your cottonide from above.
Yeah. Can you
Okay.
please put just for 1 minute this one on there? इसको उस पे एक बार रखो. Yeah. So sir is just trying to say this one. If you see this black, it is black. And while drilling, you will get bleeding. Change color, please.
वही डिसेक्ट करो, डिसेक्ट करो इसी पे वैक्स लगा दो, वैक्स बना दो।
No, no, sir, if you know this,
क्या करते हैं करो होगा नहीं जा तो पाए
वो सर रहते आता ना, पता नहीं कहाँ से
So it is not the venous plexus, epidural venous plexus
Yeah.
that treats always. Okay,
Yes,
it can be the bone also.
yes, yes.
So you must be aware of everything.
Yes, before going to nail
Okay,
drag.
see how beautifully it is stopping.
Yes, sir.
Good.
This is very important.
We will go again.
Yeah.
Now this time I am going to take the manual drill.
Yeah.
चलो और कम कर दे, बाहर कर दे इसको. I usually start with 12 mm or 14 mm.
Yeah.
Okay.
Yes, sir.
इसका खींच थोड़ा सा, मैं सेट करना है मुझे. मैं एकदम खींच इसको, है ना.
These are very
खींच,
small
खींच,
tricks.
खींच, खींच, खींच.
And if you will see this, then you will be confident. ये
Okay.
ठीक हो जाएगा, ये होता है.
So my sleeve is inside.
Yes, sir.
Short. And it is slightly cranial. I am redirecting it.
Yeah.
And now I am going. Short. Short. Is not going inside, I think. उसको perforate और करना पड़ेगा थोड़ा.
Most probably sclerotic one is there.
साला सामान भी क्या है, कल बैंच पे.
The second one like if you are doing so
गरम है यार, अभी पकवा क्या रहा है क्या? अच्छा ठीक है, अभी सही है. इसको डाल के थोड़ा सा रीओरिएंट कर लेंगे, है ना. एक्चुअली प्रोसेस ठीक नहीं दे रहा है ना. रुक, थोड़ा सा अंदर कर ले पहले, है ना. ठीक है. Stop. Okay. So now we are going. Okay.
Yes.
I think our direction is also okay.
Yeah.
Always, ask with your assistants
Regarding the direction.
whether they want to correct anything.
Yeah.
Short. Okay.
Yes, yes.
Vipin.
For that
Are you okay with
prerequisites, sir, your assistant should be trained enough like you.
With time, they are going to surpass me.
I know.
And that will be my biggest achievement.
Yes, and you will be most happiest person that day. Yeah.
Short. Okay, we are going good.
Yes, sir.
You can see it. We are going towards the anterior tubercle.
Yes.
And I am getting a very good bony purchase so far.
Yes. Few ml left. Yeah.
Short. Okay, so I almost
Yeah, about the.
reached
Yeah,
there,
yeah,
and now I'll stop and we'll recheck it.
yeah.
Okay?
Yes, sir.
When you reach, you know, the anterior cortex, it will become difficult to go.
Yes. Penetrate the cortical one.
So that is the sign
Yeah,
that you are actually entering inside the cortex.
yeah,
And since you have hit the venous lacunae,
yeah.
be prepared with your bone wax.
Yes.
Okay? So
Yes.
there is no bleeding.
Yeah,
Previously put bone wax has taken care of.
yeah,
Okay?
yes.
And that is our entry point.
Yeah,
Got it?
yes.
Now I'm probing it. And very good, robust, solid purchase inside. Bone all around.
Yeah,
Good?
yes, perfect.
Okay. So for the time being,
Pack it.
I am leaving it, this part.
Yeah,
You can show this. And now I'm focusing on C2.
yes, sir.
Okay?
Yeah,
So since this side of C2 pedicle is quite good, I'll try to take it from, you know, as posterior as possible,
yeah,
so that I'll get, you know, very good reduction.
yes, sir.
So again, the technique is same. Your technique is same. You feel
Yes,
the medial border, the superior border. Okay?
yes, sir.
And you go inside. Sometimes, for a good drilling, you may need to remove that part of lamina to have a better feel of your medial side of pedicle. Okay?
Yes, sir.
So that you can feel that curve easily, where actually it is moving from posterior to anterior side. Okay? So just to feel this boundary. Okay? So here lies the medial part of the pedicle,
Yeah,
and I will start somewhere from here.
yeah,
Okay?
yeah,
And lower down.
yeah.
I want to have a very good purchase. So I'll start from here.
Yes, sir.
Vipin, put your number 4 inside. And you see, my assistant is, you know, keeping his number 4 here, so that I always have an idea where lies the medial part of the pedicle. Okay? Short. For making that medial angulation, you may require, you know, to remove your lower retractor sometime,
Yes, yes.
because this screw is very much angulated.
Yes,
Okay?
sir.
And you may not get a proper coronal angulation, so you may require it. Okay? Vipin,
Yes.
put it here. इसको निकाल दो, इधर कॉर्नर हटा दो, इसको दबा दो इधर, बस छोड़. Sure. You see, now I'll get a good angulation. Okay? Short. Again, you see, in the PIP X-ray images, I am going parallel to the upper margin of the pedicle.
Yes, sir.
You see it?
Yeah.
Okay. And that is the safest area.
Kuldeep, can you ask video person to change the
Short.
images, exchange images, please? Yeah, thank you.
Short.
Sir, Pankaj here.
You see, I have almost crossed the vertebral foramina. Okay, see, I have crossed the vertebral foramina in X-ray, and now I am at the anterior margin of the spinal canal. So
Can you please change the PIP, Mitch?
actually, I have bypassed the vertebral artery. Now I am anterior to that left hypoplastic vertebral artery, and now I am changing it to manual drill.
Sir, from Jaipur, Dr. Pankaj Gupta sir has called, and
Sure.
he's so happy to see your surgery, and he's actually blessing you.
Okay, so he's watching us.
Yes, sir. Yes, sir.
Sir, it's an honor for us. I have learned, the basic tips of surgery from Professor Pankaj Gupta, sir. And it's a really honor that he is looking into, my surgeries. Sir, thank you so much, sir.
Lots of mentors are watching you.
I got a word from, the SMS group that lot of, my seniors and my teachers are actually watching the surgery live.
Yes, sir. That's why I was.
And it's a really honor.
Yeah.
It's a real honor. You cannot ask for more. Short. You cannot ask for more. That's a real honor. No doubt about that. I got blessings from Professor Sinha Saab in the morning itself. Short. So you see, I have crossed the vertebral exit foramina,
Yes.
and now I am lying at the posterior border of the body.
Yes.
Okay.
Yeah.
So the chances of vertebral injuries are not not there, and I will go more and more into the C2 body.
C2 body.
Okay.
Yeah.
And one guy is asking me, if you get a vertebral artery injury, then will you put your screws? So on
Yes.
this side, the vertebral artery is hypoplastic, and
We'll
if
do it.
somehow you got an injury, okay.
Yeah.
So this is the scenario where you try to put your screw.
Yeah.
But on the dominant side, it is not advisable. You take your patient for endovascular repair or microvascular repair. Short. Okay. So I am hitting the anterior cortex now, and I am having a feel. Short.
Yes, sir.
Okay.
Yeah.
So I'm stopping there.
Yeah.
I'm removing this thing first.
Yeah.
And I have asked my assistant to keep bone wax ready
Yes.
in case I have any
Ready for
problem.
lacuna. Yeah.
Okay. So my C1 trajectory is ready. My C2 trajectory is ready. Okay.
Yes.
And now I'll put my C1 screw first,
Yes.
and then I'll put my C2 screw.
Yeah.
कितना था ऊपर वाला? ऊपर भी 24, नीचे भी 24. Again, I'll have 4 mm extra length for C1.
Yeah. So what was the length for
It is
C1, sir?
24 in C1
Yeah.
and 24 in C2.
Okay.
Both.
So tap was 20, I believe.
Pardon?
Tap was 20 and you added
Track
4.
was 24.
Okay.
I am taking a 28 mm screw
Okay. Okay. That's fine.
for
Thank-
C1.
Yes, sir. Yes.
Vipin, put your detector over here. With this only. इसके साथ ही ले लो सब कुछ, कोई प्रॉब्लम नहीं. हमने यहाँ फिब्लार फर्स्ट डाल दिया था ना. चलो एक्सपोज करो, गुड. इधर मीडियल है, थोड़ा सा बस मीडियल है. नहीं, तुम उसी में घुसा रखे हो, तुम ट्रैक्ट में ही ना डाल रखे हो. लो, यू आर इनटू द ट्रैक्ट एक्चुअली, है ना. पकड़ना. Okay, so I am realigning my microscope for putting my C1 screws. Okay. So
Yes,
this
sir.
this is the trajectory. Okay.
Yes, yes.
And now I am going to tap it. This is very, taps are sometimes very dangerous because they have lot of serrations. They can take things, from side. So you should be very, very, very cautious while tapping. विपिन ऊपर की तरफ हो, जिधर से serrations है, उसी पे रोटेट करते हुए आ जाओ. बस बस वही खींच कर रखो. 2 मिनट का काम है. हाँ हाँ बिल्कुल. Okay, for few initial mm.
Yes, sir.
So it's highly mobile joint. Not I say highly mobile, it's mobile joint.
Yes, sir.
So my screw head will make a space for itself.
Yes, sir. Yeah.
Okay.
Yeah.
And it will go down.
Yeah.
By pushing this C2 pedicle down.
Yeah.
Okay.
Yeah.
So I'll not do anything special for that. And this is tapping of the C2 trajectory.
Yeah.
Got it?
Yes.
Now I am putting my
C1.
C1 screws.
Yeah.
थोड़ा बैक से देना, थोड़ा बैक से देना. I don't want any blood. Okay. यहाँ पे रखो थोड़ा सा. यहाँ थोड़ा रखो. यहाँ पे. इसीलिए विपिन थोड़ा सा डालो. यहाँ इस पे C2 पेडिकल पे यार. क्या एक रख लो. हटा लो. हटा छोड़ दो. आगन लेके उधर हाँ खींचो. बस इसमें सेट करना है थोड़ा सा ना. गुड. ऐसे पकड़ो. लो 28.
इतनी पतली आपकी पेपर
28 है ना. Reduction. So again we are using a reduction screw. Okay. And
Yes, sir.
short. It's a very solid bone.
Yeah.
It's a very, very solid bone.
It's looking very solid.
I'm getting very good purchase inside.
Yeah. That is good for us.
Yes, yes. So I'm quite happy.
Yeah.
Short. Direction change तो नहीं है. ठीक है, सही है, उसी में जाएगा. Short. ठीक है, almost है ना. So this is our C1.
Yeah.
Okay.
Yeah.
And now I am going to put my
C2.
C2 screw.
KD, can you ask to put the X-ray in the bigger one?
Pardon?
Yeah. Thank you.
24. See, I am not removing this.
Yeah.
Actually, it is not required in this case, but where you are putting your sub-faster screws, this is of, lot of help. Maybe it would go a bit anterior, but
Yeah.
I don't have any problem with that. Okay.
Yes.
it is a bit anterior. I should have taken, 26 mm screw, but it's okay.
Yes.
Maybe I'll reduce it a bit. It's okay. Chalo, nikalo. You can go like, 5 mm, no problem.
Yeah.
And in your pre-op scan, if there is nothing
No
before,
vascular-
you can go up to 1.5 centimeter.
Yeah.
Okay, now I am, going to do that occipital locking thing because
Okay.
it may be required here.
Okay.
It may be required here, but again, I have to be very cautious about,
Yes, sir,
the
there-
vertebral artery here.
Yeah.
So I will do everything under vision. Okay,
Yes, sir.
I will do everything under vision. कितनी यहाँ से लगा दो। एक 2 mm का डायमंड लगा 2 mm डायमंड लगा। इसका नंबर 4 लेके विपिन थोड़ा सा डाउन कर लो, है ना। इधर से ना ऐसे दबाओ,
Yes, sir. Extra work तो
इधर से जैसे मैंने पकड़ा है ऐसे ही पकड़ो, है ना। ठीक है, ऐसे ही पकड़ लो तुम, है ना, खींच के थोड़ा सा, है ना,
Sir,
ऐसे रखो। ठीक है, ऐसे रखो, लो बस ऐसे।
You are planning to do all the VRM, okay? So rod length, कभी देखिए rod length could be bigger. Okay. And bone is there. It will not allow you to put a bigger length, which is required because या तो आप उसके लिए के जो बिल करते हैं तो लॉकिंग कर देते हैं तो एवरीथिंग विल कम
वैक्स लेना थोड़ा सा ना। वैक्स लो थोड़ा सा बस। नंबर 4 दे दो या वो वाला माइक्रो। Any questions so far? Any confusion?
I think no.
हटा लो उसको, हटा लो। डेल लेना दीपा। You just don't shy away, just don't think that after putting up your screws, everything is, done. Everything is not done till it's done.
Yes.
I think everybody is drowsy after taking lunch.
No, I have supplemented with the sugar. Don't worry, I'm taking care. I'm a good host.
Okay, so I think I have made a quite good gutter. And now I will put my rod. Okay? Chalo, hata lo. When it lift up, that will come here. Okay? Chalo, Dena Vipin. Ram rod lo. Now I'm going to put my rods
Yes, sir.
on this side. And you can see even after having that much of length, you know, still
Yes, we are.
there is a difference. You understand?
Yeah.
So you just consider the scenario where your head is, totally inside. In this case, at least, you cannot do it.
Walker, can you please check for CT for first case?
Dosa devta. Vipin, try to make that into this cutter only. Okay. And again in divergent fashion. Okay. सही है ना? अंदर है ना? ये लॉक सही नहीं हो रहा है इसको. हाँ, अभी सही है. So this system is, patented by us, marketed by HCM.
And the last word I would like to add is we don't have any financial
The
benefit.
commercial aspect.
Don't have any financial benefit. We
Okay,
don't take any
so-
single penny.
Mr. Jaspreet of SCM is taking care of our instruments. And in international segment, we are using Medtronic.
Yes, we should thanks Medtronic sir for the support.
अभी हो गया. हाँ. नहीं इससे करना इसको. ये तुम्हारा सही नहीं है. दूसरा दो. कैसा कैसा सब लाता है सामान, इसको पता नहीं क्या बनवाता है. गटर में है. निकला हुआ है. शॉर्ट देखो. निकला हुआ है ना? मेरे पे निकला कि नहीं निकला चेक करो. है? Okay, so I think it is not in the gutter. Okay. See what happens when you tight your rod.
Yes.
It has a tendency, to go inside. So
Yeah.
you always feel that your rod length is more.
Yes.
But when you reduce it, okay,
The rod is consumed.
the rod is consumed. So always take a big rod. Push, 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 push. मेरे को ढीला करना. Push. Always take a big rod. Yes. Okay. Now it's good. And I've been just gone inside. And now I'm tightening it first. Now it is tightened. And now I'm tightening the second one. छोड़ दे, हटा दे उसको. वो टाइट है, टाइट. It is outside the gutter, but I am able to see it. Actually, it's reducing a lot. Okay. So. ठीक है. But still it is, I'll show you the reduction. Take a shot.
And put it on big way.
You can see it.
Yeah.
You just try to compare it, the pedicular distance from the occiput. It is totally reduced.
Almost. Yeah.
You can see here. Are you able to see it?
Yeah, now. Yeah.
You see the joint.
Can you change this?
Can you see it?
Sir, you ask. Yeah, that's fine.
Can you
Yeah.
see the joint?
Yes. Now. No. Video. Yeah, that's fine.
How much it has reduced actually.
Yeah.
You see it.
Yeah.
Now it is totally open.
Yeah.
The only, thing of concern is that I'm not sure about the rod above. So I'm going to readjust it. Okay.
Yes.
So that I will have, full confidence. Yes. That I have taken a good control.
Yes.
Okay. And maybe I need to make this gutter more.
Yeah.
On lateral side and more down. Okay.
Yeah.
So that is required. That I'll do. Chalo, ढीला करो. Any question from the audience side?
Everybody is very happy.
I think
Oh,
they all,
good.
are pretty tired now.
No.
Or every question
Sir-
has been solved.
Sir, just one question.
Okay.
Each and every time we are watching that you are dissecting from C2 towards C1.
Yes.
So do you come from C1 to C2 as well?
See, I always want, to dissect along the bony surface.
Sir.
And when I come from C1, okay, down, the problem is where the C1 arch is dipping, and become the lateral mass. Okay, at that point, there are lot of soft tissues.
Yeah.
And the veins actually are making a confluence over there. Few years back, we and Rakesh had a discussion regarding how to stop the bleeding
Yes, sir.
of these veins, and we have studied the venous anatomy, and what we find that if it is not from the epidural venous plexus, it is always from that area where the C1 posterior arch is dipping
Yes.
and merging into the lateral mass. So when your venous bleeding is not from the epidural venous plexus, you just direct your bipolar cautery towards that surface
Yeah.
and coagulate.
Yes.
So that area is having, very high venous confluence, and you will fall into a blind zone. And that's why I always prefer to go from down up. Okay.
Yes, sir.
And I always want to see the C2, the vertebral artery exit foramina at the C2. Okay, so that I have the idea where my vertebral artery is.
Yes, sir.
So you got a bony landmark that is pretty fixed. And that is your C2 exit foramina.
Yes.
Okay.
Yeah.
But when you come from above down, you will not get that fixed bony point against which you can identify your vertebral artery.
Yes, sir.
And knowing where your vertebral artery is the thing about this surgery.
Yeah.
So I always want to be secure, and I always feel the exit foramina of the vertebral artery, and then I do my dissection along the bone.
Yes, sir.
So it is pretty safe, and I recommend to follow this maneuver only. I don't do it from upside down. Very rarely, if your anatomy is like this, then you can do it, but otherwise it is not required.
Yes, sir. Agreed.
It is not safe. If you have safe maneuvers, why to do it? You understand what I'm saying?
Yes, sir.
बड़ा ले लेते हैं थोड़ा सा ना. So I am changing my rod. I am taking a bigger rod.
Yes, sir.
5 mm more. 5 mm बड़ा काट के दो सर. देखना check कर. And one important thing also.
Yeah.
If you most of time, your implant guy will give a rod which is smooth from one side.
Yeah.
And cut from one side, because they
Yeah.
always have big length rods.
Yeah.
And they cut and give it.
Yeah.
So I try to put, when I do this drilling, I try to put the softer end
On
the upside.
Yeah.
Because sometimes during this occipital locking, the dura is exposed. Okay.
Yes, yes.
So
To prevent
you want to avoid injury at
Yeah.
any cost to the CSF spaces. You want to avoid the CSF leak.
Yeah.
Oh, बहुत ज़्यादा हो गया. And that is the scenario where you want to put your soft rounded end towards the occipital side.
Yeah.
Okay.
To the cranial side.
थोड़ा सा बस, थोड़ा सा और डाल, थोड़ा सा और डाल, और डाल जाएगा. बस बस. So don't say it done until it is done. Okay.
Yes.
And now it is good. I am seeing it, visually also, that my rod is above that C1 screw head.
Yes, sir.
Got it?
Yeah. Now
Short?
we are also able to see this.
Okay. So it is bit up, and I will lower it down a bit. Okay. Don't say it is done. It is done until it is done. थोड़ा सा लेके, हाँ, लेके हल्का सा नीचे खींच लो, हल्का सा. Short.
Yes.
Short. भी थोड़ा सा अभी आ जाएगा, है ना? Tightener. Okay, I think I should make it fast, otherwise people will not have the idea of how. Shortly. I think it is good enough, and you
Yeah.
can see the rod is reaching only up to the inner cortex of the occipital bone.
Yes, sir.
Okay.
Yeah.
Can you see it clearly?
Yes,
It is
sir.
not inside.
Yeah.
Okay. So I'm going to complete this construct.
Yeah.
Okay. I'm going to break
Yeah.
and then do final tightening. Okay. Okay. Let me do it completely, then I'll decide. Okay.
Yeah.
Let it remain here only. So I'm going to demonstrate you occipital plate in this case.
Yeah.
Okay.
Yes, sir.
I am going for plan B.
Yes.
Okay.
Yes.
I think you should have an idea of how this occipital thing is done. Okay.
Yeah.
Otherwise, you can follow it lower down and you can go inside, but I'll prefer not to. Okay, this all is bone. You can dissect it out. Bipolar. You have to expose. Okay, sorry. Okay, I'm not doing it in a microscope. That's the problem. Okay. सियाम अभी ऊपर कर दो. इरिटेटर फिर से रीअप्लाई कर लो. रीअप्लाई कर लो. क्षितिज उसका थोड़ा सा एक्सियल रन करके मुझे दिखाओ. I want to see, the thickness of cetulamina. Okay, so I am seeing a running video of axial लगा लो. एक ग्लव चेंज करा दो यार मेरा. नहीं इसी का. ये किसका है? ये किसका है? अरे इसका एक्सियल दिखाओ ना. इसका एक्सियल लगाओ.
डबल.
एक ग्लव्स दूसरा दे दे यार. साथ देना है ना. इसमें एक्सियल लगा दो ना. जीप लगाओ.
ये मेरा.
इसको हटाओ. एक्सरे हटाओ.
There is one question from Pankaj Gupta, sir, most probably. He is asking for what kind of autologous bone graft you are using from posterior iliac crest. No, sir, we have used the assimilated C1 arch. We have done the decompression and we have mixed with the some metronic granules, and that one you have used in the first case.
Okay, so you see clearly.
Yeah.
Okay, on the problematic side, the lamina itself is very thin.
Yes, sir.
Okay.
Yeah.
And C2-3 are fused, and lower to the foramina, there is a thick C3 lamina actually. This is the C3 lamina.
Okay.
Okay.
Yeah.
So you may put your translamina here. Left side is quite okay. Left side there is no problem. Left side pedicle, lamina is also very good.
Yeah, but this side is.
But on the right side, the lamina is also very thin.
Yes, sir.
Okay.
Yeah.
So I am changing my plan.
Yeah.
And I am putting a transfacet on the right side.
Yeah.
And that I will connect with occipital plate. Got it?
Okay.
Or you can put a pars screw also.
Yeah.
Okay. But again, pars you have to bit, very cautious because it may hit, and so I will avoid. But you can put C2 pars if you want to. Okay. There is good C2 pars. You can put it.
Yeah.
But I'll try to avoid it, and I'll put a transfacet.
Yeah.
In the right side C2-3 joint.
Okay.
So first, just to supplement my fixation, Okay, let me see. Maybe I could do translamina in the C3 also. Let me see. Let me dissect a bit more. Then I will decide.
Yeah.
यही वाला है हाँ यही वाला okay let me
Yes, sir.
okay सब periosteum कुछ टाइप का चाहिए यही देता
During his surgery, you can see every time when he used to discuss the things, one thing which needs to be learned. Every patient is different. Every CVJ is different. Many of the time you plan differently, and in actual surgery, you have to do something else.
That's why you always say A, B, C, D plan.
There should be always a backup plan in the CVJ. And overall, just what we used to think, C1, C2 fixation, that I will do. But it is not that much simple. C1, C2. You have to plan, you have to backup plan, you have to make something else. Feel that thing, feel that anatomy. Always used to have, if you can arrange, have a C1 vertebra and C2 vertebra. That will be one of the most beautiful specimen which you can have. And that will help you every time during your planning. So every time, Deepak is whatever he is saying. The thing which I wanted to conclude at that particular time, I have learned everything from everyone. From Dr. Atul Goyal sir, from Dr. Sarat Chandra sir, and even with Dr. Deepak. My CVJ surgery is influenced by all these three. And with all the concept behind the given concept with all these three people, with that I used to evolve my own concept, how I have to perform in this particular case. Because every time it is different.
Every case is extremely complex. Every case is different.
करोगे तो बता देना एक मिनट रुक जाओ बोलो
Everything you have to see first before putting anything. So our concept like take every anatomy in front of you and then put it.
करना है ले लिया हाँ लो एक लो चलो करो कर लो
I hope MEP is fine.
Done? It's all fine?
Okay, thank you.
Okay?
Yeah.
There is small venous bleeding from the lateral gutter at C2-3 joint. I am taking control of that. Bueno. Number 4 then. Okay, so this is the lateralmost aspect
Yeah.
of C2.
And
Okay.
yeah.
And this C2-3 is fixed.
Yeah.
Got it?
Yes, sir.
And I am going to remove this soft tissue by so that I'll have a good idea of how the things are there. Mano. Bipolar. Reapply over here your detector. Within. यहाँ लगाओ एक डेढ़ नहीं इस वाले का सॉरी नीचे वाले का एक डेढ़ यहाँ लगाओ ठीक छोड़
This is the soft tissue dissectant technique with bipolar. It is very important here. So you catch the soft tissue in between, burn it, and then push it everything lateral.
bipolar So this is our root.
Yes, sir.
On that side. And number 4. This is the vertebral artery foramina. Okay.
Okay. Yeah.
And bipolar. You can see the transmitted pulsations over there. Okay.
Yeah. Yes.
Are you able to?
Down. Yeah.
Okay. So number 4.
नजरों का धोखा लेकिन कुछ लोग तो ये में तो ये वेट देखी में जा रहा है
So now I have two options.
Yes.
Since our C2-3 is fused,
Yes, sir.
what I can do, I can either put my translaminar screw here,
Yeah.
okay, a shorter one,
Yeah.
a big translaminar screw, because you see, the angulation of the lamina. Here, this part, on the upper part, it is pretty good,
Yeah.
but here it is dipping.
Yeah.
Okay?
Yeah.
So maybe our screw will be smaller on that side,
Okay.
and because this is just, supplementary fixation.
Yes.
It is going to supplement my reduction.
Yeah.
And here, this side, I'll put a long screw.
Okay.
Okay?
Yeah.
So I'll preserve this motion segment.
Yeah.
And if I'll find that I'm not able to get a good purchase into this lamina,
Yeah. Then we'll do
I
the
will go for this transfixate.
Yeah.
Okay?
Yeah.
But you should, understand that this is C3-4 joint.
Yes. Yes. Of
Okay.
course. Yeah.
So this is pretty straight one. I had to be
Yeah.
like this.
Yeah.
Okay, but I'll try to, preserve that motion segment, and let's see.
Okay.
थोड़ा निबड़ देना. Okay. So let's go. Drill. Section look. Okay, so with both hands,
Yeah.
this is important. Okay. Take both hands and let your section be ready with your assistant. Take out the soft tissues, so you will have the idea, and
Where you have to go.
then put your laminar screws.
Yeah.
Okay. I will start somewhere from here.
Yeah.
Okay, and I'll try to keep it down, because in this case, what I yesterday told, that is usually thick on the upper side,
Yes.
but on the right side, it's not like that. So I'll keep it a bit down. Okay.
Okay.
Again, the philosophy is same. You have to hit you should try to hit the outer surface. ये थोड़ा सा ना सियाम हटा लो. Good. Ball देना. Ball. Okay, so far so good. Okay.
Yes, sir.
Now I am taking the manual drill. Manual. कितने पे है? 14 है ना? Okay, I'm trying to, go parallel to the outer cortex.
Yeah.
And I have gone inside up to 14 mm.
Okay.
Now I have increased the length and it's almost 18 degree, 18 mm per change.
Yeah.
So I think my job is done on that side
Yeah.
because that is good enough purchase for me, at least in this case.
Okay.
And I will feel
Yes.
I'm removing the inner part.
Yes,
It's
sir.
20 mm purchase now.
Okay.
And I am trying to feel the bone all around. It's very good, very solid.
Okay.
Okay.
Yeah.
So, kitna 20 hai? Huh? Okay, so it's 22.
That's fine.
I will do tapping and I will put a screw this side.
Okay.
Okay.
Yeah.
I will put a screw this side and then I'll come on opposite side
For
and
the
put another screw.
another. Yeah.
Yes, I think plate lag jayega. Okay, see the important tip from Dr. Vipin, and he has said it rightly that we should apply our occipital plate first.
Yes. Before
And this
putting
is
this.
one important lesson that I just forgot.
Yeah.
And I keep on telling this thing, but I forgot it because I'm using, very less occipital plate in very less number of cases. So I am packing this trajectory. Okay.
Yes.
I am putting now my number. I'm putting my ball probe here. Okay.
Yeah.
And I am going to make my another trajectory from opposite side.
Yes. And then
And
occipital
then I'll put my occipital plate first.
Yes. Yes.
And then I'll put my translaminar screws on both sides.
Yeah.
Okay.
Yeah. Here is the role of good assistance.
So is it in focus?
Yes.
Good. दिल का पेडल मेरी तरफ करो. Okay, so you see the trajectory and I try to stay away from that. Okay. And I will again hit the middle part. Soft tissue हटाने के लिए वो दो, nibbler. Okay. So lamina is exposed before me. Law, drill law. And on that side, I am going to take at least 28.
Okay.
And my assistant is, keeping a watch on the outer cortex all the time.
Yes. He's
That
very
is not perforating.
Yes. Especially Vipin is very like Watchful person, he will say, no, 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 nahi sir, nahi sir, nahi jana.
Okay, so on this side, I have gone for almost 30 mm screw.
Okay, sir.
Okay, so
Fine.
it's 28
Perfect.
and I'm stopping.
Yeah.
Good. So very good bony purchase all around.
Perfect.
Okay.
Yes, sir.
So now what I'm going to do, I will do foramen magnum decompression first.
Occiput.
Then I will apply the occipital plate.
Yeah. And
And then I'll come down.
Yeah.
And put my translaminar screws. Okay.
Okay, sir. Perfect. So now everyone is able to see the all the rescue technique, hybrid technique, everything.
एक ना दीपक एक डायमंड भर बोटा लगा ले यार.
So
बस हो
translaminar,
ही गया है काम almost.
drilling and everything is there.
ड्रिल का पेडल दे दो. Because when you put your occipital plate again, the space become very narrow and it become difficult to, do the foramen magnum decompression. So I'll do it first. And occipital plate देना. I will decide its location.
Yes.
So that will be my location. Okay.
Yeah.
Below the inion.
Yeah.
So it will not protrude, will not cause any, occipital sore.
Yes.
And that will be my position for occipital plate. Okay.
Yeah.
So I will mark it with monopolar.
Yeah. And then.
मार्कर पेन है क्या दीपक? Okay, so this is the marker pen. I will mark my pen दबाना है इसको. My points, and this is my हटा लो. This is going to be the most important place. Okay. So लो भर देना डायमंड. कैरेक्शन ले लेना. Line, not a line. Number 4. You can do it using a perforator also. Section. Number 4. Different section inside. Okay, so section हाँ section पे मोटा section ले लो थोड़ा सा मोटा section ले लो है ना. Number 4. Garrison. ठीक है. Garrison. Okay. बड़ा Garrison देना. Any question, Rakesh?
No,
So
sir, it's
far?
fine. So we all are watching your occipital
Okay,
fixation.
so when I'll put my occipital plate,
Yeah.
then you will have the idea.
Okay, sir.
So from here only, I will make the gutter. Okay.
Okay.
After doing the decompression.
Yeah.
So I have used a diamond burr. Nibbler. छोटा वाला देते थोड़ा है क्या? वो अच्छा यूज हो गया होगा. ये बोन रखते जाना सब है ना. Keep that all bone, you know, with you for fusion. Blood ले लिया. तो blood जो आएगा लेते रहना. ठीक है मैम. ठीक है मैम. लोग जरूर. I am taking some blood from here, you know, to activate. वो मेट्रोनिक वाले का लेना है ना. उसी का लेना. हाँ निबलर. हाँ छोटा ही दे दो. अगर अंदर चला जाएगा तो बड़ा दे देना. बड़ा चाहिए. बड़ा ही दे दो. वही वाला दे दो. इससे जो बड़ा वाला है. हाँ जो नॉर्मल था वही नॉर्मल वाला था. It's simple and safe to come from above down.
Yes, sir.
Clean.
Yeah.
तो से एक बिट दे देना मेरे को. 2 mm का कटिंग बिट लगा के.
सर वो लेकिन हमारे
टाइम लगेगा थोड़ा सा. नहीं करता से. ठीक वही लगा.
महाराजा वो तो तभी हम बोलते
बिट से करते हैं ना.
ये ऐसा है कि उनके कीर्तन से भी अच्छे तरीके से आज बैठी है. He is world renowned. World renowned. आप बुक में पूछे तो भंडारी.
Mark your craniotomy.
100 से around
On this side also. मोटा सेक्शन ले लो. मोटा सेक्शन समझे अरुण. मोटा सेक्शन लो. ये हड्डी रखते रहो.
ये नहीं कि मेरे को चेक कर लेने पहले जाके क्योंकि मेरा नाम जो कलकत्ते में रही दिखाया फिर ऑफिस में ये बोला है उनसे जस्टिफाई करा के तब हम
निम्र ना
नहीं वो बहुत
and try to do surgeries under microscope. Okay.
Yes, sir.
Try to do everything under microscope. That
Yeah.
will reduce the chances of, injury. That will reduce the complication. There's no doubt about that.
Yes, sir.
So you learn it. Microscope will always help you. It is a bit time taking. But again, with time, you'll learn to do things faster. Section. Garrison. 2 mm है क्या? 2 mm. वही है ना? हाँ. Open. There is very, thick fibrous band inside. So this is the case where foramen magnum decompression is actually important. Section. Now I'm completing it by doing from downside. And take a bite.
Yes.
Okay.
Yeah.
Section. Nibbler.
Yes, sir. Yeah. क्योंकि वही से सर एक ग्रुप बना के प्लेट लगाते हैं
Garrison. यहाँ देखो. It is reduced. So I am putting my, Garrison inside without any fear. But otherwise, as I have said, if you do it as a first step, then you have to be very cautious.
Yes. With real
Because
quantity.
there your, nibbler, your 3 mm Garrison, that all things are not allowed.
Yeah.
You have to do it with drill, your curate,
Yeah.
and number 1 Garrison only. You see, it is decompressed just by means of reduction.
Yes.
Okay.
Yes, sir.
And I will do a bit more here. Okay. And here. Vipin, section. This side.
Sorry, we are discussing.
Okay, so this side decompression is complete.
Yes.
And I'll see what is there. I will remain a bit cautious here. Okay.
Yeah.
Because here the vertebral artery is going from inside the canal.
Yeah.
Okay, so I'll remain a bit cautious. Harrison, do दे देना, हटा दे देना. I will not disturb this venous plexus. Okay.
Yeah.
So rotate कर दे हल्का सा यहाँ से इधर नीचे की तरफ, नीचे की तरफ, नीचे की, हाँ बस सेक्शन करना देखिए तो ना मुझे छोड़ 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 छोड़. Section यहाँ करो. I will remain this spicule only. I will remove this one only, and that will, conclude my decompression of the foramen magnum. से पकड़ लो, ऐसे दबा लो, ऐसे पकड़ो, ऐसे पकड़ो. हाँ ड्रिल देना, पतला वाला वो लगा लो, डायमंड लगा लो. हाँ ठीक, कटिंग नहीं, डायमंड चाहिए, ज्यादा दबाना नहीं. ठीक. Okay, now give me Harrison. हाँ हटा लो, रिपिन हटा लो. One mm देना. Section, oh sorry, section रिपिन. Cured देना, cured देना. Section. Actually ना ये मोटा है, छोटा नहीं है इतना. एक मिनट हो जाओ. अरे ये कैसा क्यूरेट दिया यार, नीचे वाला थोड़ी चाहिए, डाउन थोड़ी चाहिए, सिंपल क्यूरेट दो ना सेक्शन दो.
Yes.
तो साला तुम तो लेकिन हाँ सेक्शन.
This one. No, just one cross match. Yeah, yeah. वो भी अपने blood bank.
ऐसे ना साला डेंजरस है ना, पूरा घुसा हुआ है, उसको काटने में ना डर लगता है.
याद है हम 4 लेके आते थे.
हाँ रिमोट
और उसको
सॉफ्ट टिश्यू पकड़ में आ जा रहा है.
मुझे पता है तुमने क्यों पूछा.
चलो सेक्शन.
शाम को अगर 2 सीबीजे लगा हुआ है तो
So I have removed this spicule.
3 में से हमारा काम रहता था एक आदमी
Okay.
में सेटिंग तो ऊपर से शुरू कर देता था.
And now I think
कर देना, फिर शाम को जाएगा
my decompression is over.
ताकि
You know?
सर के सामने चारों से ब्लड लेके जाएगा.
Number 4.
लेके सर खुश है. गुड. हाँ.
Number 4.
मतलब खुश हो, बढ़िया काम कर रहे हो तुम. 4 यूनिट 8 यूनिट ब्लड लेके आ गए आप.
You see, the dura is decompressed. This venous plexus is, I think, around the vertebral artery which is inside. Cotton. So, so I think this vertebral venous plexus is around the vertebral artery which is inside, and this bony fragment I will just remove. Okay. Okay. So you see this venous plexus, Rakesh?
Yes, sir.
I think he's not listening.
Yes, sir. We are listening.
This venous plexus, you see,
Yeah.
this is a cause of concern. Okay.
Okay.
This is very big.
Yes.
Okay. But the problem is, this is the paravertebral venous plexus
Yes.
of the part that is running inside.
Yeah.
Okay. So I cannot, remove it,
Yes, sir.
because somewhere here lies the vertebral artery.
Yes.
So we have to leave it as such.
Yeah.
And now we'll proceed with our occipital fixation.
Yes.
Okay.
Yeah.
So इतना हटाना पकड़ना. कैल्शियम देना दीपक 2 mm फिर से 2 mm. You can remove it a bit more if you want to, because now you are in control.
Yes.
Okay.
Yeah.
So now you are in control. Your venous plexus is going down.
Yes.
And you are quite above it. So you can remove if you want to.
Little bit more.
So decompression thing is over.
Yes, sir.
And now I'll
I
put
think-
my small bit of fiblar
Yeah.
till the time I'll complete my fixation. Okay.
Season. Yes, perfect.
So everything is going as per plan so far. Okay.
Yes, thanks, sir.
And now I will make a gutter for putting up my
Auxiliary
screws.
plate. Yeah.
Got it?
Yeah.
So that is my intended place
Yeah.
for putting my inside out. वो दे दो यार, कटिंग लगा दो, मेरे बहुत टाइम लगेगा, वही वाला जो दिया था.
We'll make gutter and then we'll slide this.
Cutting.
वो नहीं जाएगा.
Okay, so that is my intended place for putting up my central inside out flat head screw,
Yes, sir.
and I will make a gutter for that
Yeah.
using a high speed drill. बहुत wobbling हो रही है बीच में कभी इसमें. वो टक टक अजीब हो रहा है। नहीं परेशान मत हो,
तो कल पूरी चीजें क्यों करती
एवरीथिंग इज फाइन सो फार।
क्रिकेट में मच इम्पोर्टेंट
लो kerosene देना। So now I have taken the kerosene and completing that gutter.
एक दो तीन चार चार तीन
Okay. So our gutter is complete.
Yes, sir.
And now I'm going to put my flathead screw from inside. Okay.
Yes, sir.
So you see how easily it is going inside. Okay.
Yeah.
Above the dura. And now it's in place.
Yes.
Okay.
Yes.
So you may need to, widen it more a bit, but it's okay. Let me widen it more.
I think it's fine, sir.
Okay, so it's in place.
Yes, sir.
And now I apply my plate.
Yes.
The plate now. Sometimes you need to do the contouring.
Yeah.
Okay.
Yes, sir.
So that it, sets
Proper.
flat.
Yeah.
Okay.
Yeah.
And every time the person who's not looking from the microscope is very, very, very helpful. Like my assistant who is seeing, from outside also, he can always give you an idea that your, placement, your angulation, everything is perfect.
Yes, sir.
So that is very important.
Yeah.
मेरे को एक ना मैच स्टिक भर दे दो, मैच स्टिक या 2 mm वाला एक कटिंग, ये वो लगा के डायमंड लगा के दे दो। स्क्रू का डाया कितना है उसका? 3.4 कितना है? 3 mm है ना डाया ऑक्सीपीटर का? ज्यादा ही है, तो 4 के आसपास है। हाँ तो ठीक है, मैं एक डायमंड भर लगाऊंगा। नहीं डायमंड मोटा भैया लगा लो, ये ठीक है। कितना है ये? 2 mm होगा। ठीक है, विपिन पकड़े रहना, ठीक है? हाँ ठीक है। So I am doing my, cortical marking now.
Yeah.
This is just for sake of marking,
Yes.
उधर भी. And now I will remove the plate.
Yes.
प्लेट हटा लो. And I will complete the things first.
Yeah.
ये क्या है तुम्हारे? बहुत वॉबलिंग हो रही है यार इसमें। विपिन कुछ प्रॉब्लम है यार इस अटैचमेंट में। कोई दूसरा दे दो, कोई दूसरा addendum, कोई भी दे दो। कुछ हो रहा है, प्रॉब्लम उसमें हो रहा है, ये दे दो, यही सही है, लाओ। ठीक ठीक, वॉबल करेगा क्या? हाँ जाओ, ज्यादा वॉबल कर रहा है, देखते हैं, रुक जाओ। नहीं फिर भी ठीक है, नहीं भी वॉबल कर रहा है। सेक्शन दूसरा कहाँ था अपना? ये थी, हाँ ये था ना,
उसके ऊपर
इधर वाला कहाँ गया?
ये
कहाँ पे? पहले उससे कर लेते हैं, एक कर लेते हैं, उसके बाद कर लेते हैं। हाँ ठीक है, तुम एक हैंडल लो, कितने पे है? हैं? ओके, 6 नहीं, बढ़ा दे यार, 8 कर दे। ओके, सो आई एम नाउ टेकिंग द हैंडल।
ये
6 तो चला गया यार, एक करो पूरा, 1 करो 1। एक इसको लगा के ना, फिर बाकी लगा लेंगे। टाइम है, आराम से निकालो। हेड को ना बार्स तक कर देकर रखो। हैमर देना दीपक। Sometimes to perforate the inner cortex, you may require to, gentle hammering also.
Yeah.
Ball देना. It is still not bicortical, so I'm going to increase it. 12 करो.
Yeah.
Hammer देना दीपक, या कुछ देना. हाँ. You require a gentle hammering.
Yeah.
Sometimes.
With the top hammer.
Okay, so now I'm bicortical.
Yeah.
It's 12 mm, so very good length I'm getting. And this is bicortical now. Okay.
Okay. Okay.
Now I'm going to dilate the tract by
Yeah.
using the tap. Okay, so now it's a bigger drill first.
Yeah.
It's a bigger drill first.
Yes, sir.
And now I'll
And
going
tap.
to use the tap.
Yeah. And it's for whole length.
बारह. Screw load कर लो. And tap it in whole length.
Yeah.
Okay.
Yes, sir.
This is not like common screws where you need to tap only initial part.
Initial part. Yeah.
No. Here you have to tap the whole part.
Yes, sir.
Okay, so now you see, if it will not break my C1 screw now,
Yeah.
it will create a problem.
Okay.
Break करने के लिए C1 को. So I am going to break the head of C1 screw.
Sir, first and then.
तोड़ने वाला C1.
Sir, we have already done final tightening there.
Pardon?
We have already done final tightening at one.
I'm not getting you right now.
Sir, you have already done final tightening at C1 screw or no?
I'll do final tightening one more time.
Okay.
After breaking it.
Okay. That's.
Okay.
Yes, sir.
I think I have pretty much space now. I will again go for.
Yeah.
नहीं, tight करने का. And still not tight. इसको निकालो. So I'll do C2 tightening first. And I'm doing final tightening right now.
Okay.
This is C2.
Yeah.
I'll keep this here only.
Yes, sir.
Okay, and then I will do the completes. Here, what? Coordinate. I will finish my C1 tightening also. Section करो. देखो उसमें rod निकला कि नहीं निकला. अंदर तो नहीं घुस गया rod. ऊपर ऊपर बहुत रॉड होगा है ना? हाँ हाँ ठीक है ओके सो सेक्शन सेक्शन ऊपर ऊपर बैक रॉड दिख रहे हैं ओके सो आई हैव कंप्लीटेड the C1 tightening and I will tighten in one more time after breaking it.
Okay.
Now I have broken one leaf
Yeah.
and now I am cutting it. Okay.
Cutting the second one.
Yeah. And now I am going to finally tighten it. पहला थोड़ा सा इसी पे कर लेते हैं हटाओ So it's pretty tight now.
Yeah.
Okay, so final tightening is done. And now I'll put my occipital plate.
Yes.
You see, these all things are important. Otherwise, you'll stuck up.
Yeah.
So now I'll put this screw. Okay.
Yes. It's a 12 mm.
This is 12 mm.
Yeah.
You can use 2 mm bigger size.
Yes.
But since I'm using the inside out plate,
Yeah, that's fine.
there's
Yeah,
no need.
please. Yeah.
Okay, so I'll do the final tightening later on
Yeah.
after putting my rest of screws.
Yeah.
Drill, So my assistants are telling every time that I am in the midline.
Yeah.
Everything okay? Everything fine? So this is for the second screw.
Yeah.
That's it. And before doing this, you have to remove
Rod.
this, otherwise this
Yeah.
will get locked into that position
Yes, sir.
and you will lose the ability to move that head. Okay.
Yeah.
निकाल लो उसको. You just rotate it in the manner your final rod will come, and then you do इसको 8 पे देना. हाँ. मुल्ला बड़ा करके दो, ज्यादा बड़ा नहीं है ये, ठीक जाएगा. बड़ा दो, बड़ा दो, बड़ा दो, बड़ा वाला. हाँ. और बॉल दे देना तब तक. दीपक बॉल ले लेना. अच्छा ओके ठीक है. हाँ लो मेरे को स्क्रू 10 का दो, या चलो 8 ही का दो. ठीक है 8 ही में हो जा रहा है ये. 8 ही है ना. टैप लो. So it is 8 mm.
Okay.
On this side.
Okay. And now I'm going to put my screw. Yeah.
Screw 8 mm का. Okay.
Yes, sir.
And now this sequential putting is very important.
Yeah.
I tell you why. If you make all your trajectory before,
Yeah.
even a slightest of movement of this plate
Will
cause a problem.
Yes.
Okay, it
Yeah.
will shift a little bit from here to here.
Then
you see the previous marking was quite up
Yeah.
and now it has shifted.
Yeah.
So it's very important to put all these occipital screw in sequential manner. Put one first, then mark second, then mark third. Okay.
Yeah.
Otherwise,
You have to change or you have to do again.
there will be problem.
Yeah.
So you have to do it in sequential manner.
Yeah.
Do one, then second, then third. ला भैया दे तो 8 पे करके दे कुछ है प्रॉब्लम साला मुझे लगता है अच्छा ठीक ठीक 8 है विपिन उस पर लगा के रखना बस सिर पे ही हो गया 8 में ही है 8 8 हो गया भाई कॉर्टिकल हो गया इसे चला जाएगा ठीक है ठीक है ठीक सो बिगर ड्रिल
Yeah.
and now I will take the tap
Yes.
again 8 mm screw here also.
Okay.
Lower you go, less will be the thickness, obviously.
Yeah.
And this is tapped in whole length. Okay.
Yeah.
And now I'm going to put 8 mm screw here also. Now I'm doing the final tightening.
Yeah.
It's quite, very tight. It's bicortical. It is taking good purchase over the opposite cortex also. And it's very tight, very tight. Good. Now I'm going to put my washer.
Yeah.
And this is my washer. And you see how beautifully it is locking all the occipital screws.
All the screw. Yes.
You can see.
Yeah.
And now I am putting this nut and I am going to tighten it. My colleague will hold it. And I will tighten it. This is just to prevent, the rotatory movement. This all, these instruments you can get from any puncture shop.
Yes, sir. That's why they are always saying there's a very cheap.
I am pretty sure
And
one of my dear friend will someday,
and no,
make
no
a very
international company is
sophisticated
interested.
instrument for that.
Yes, sir.
That will look good, look aesthetic.
Yes.
So you should be cautious because it will compress the cancellous bone. It will cause the thinning of the cancellous bone, and you can tie it till eternity depending on your strength. That will compress the occipital bone between the flat head and this plate. So you must understand where to stop. It is quite tight now. And I am stopping now, okay?
Okay. Yes.
So
sir.
this is how our occipital plating is done. Got it?
Yeah.
Okay. So now I am going to put my
You are going to cut rod and then.
the minor screws.
Yeah.
I will cut it later.
Okay.
कट करने का जुगाड़ उससे नहीं दे पहले कटवा तो दो वो बढ़िया वाला कटर दो अब इससे तो काटोगे तो दूसरा कटर दो ना वाला जो तुम्हारा ये वाला है हाँ कट जाएगा इससे मोटा है सो पहले तो लो पहले वो लगा ले ट्रांसले माइनर इधर 20 mm था ना 20 mm था ना नहीं इधर का 22 है उस साइड का नहीं उधर का 22 है इधर का 28 है so I am putting a 22 mm screw.
Yeah.
Okay.
Yeah.
On the right side.
Yeah.
Tap. Left. Ball.
And left was most probably 30, sir.
Ball. And that side it is almost 30.
Yeah.
Chalo. So
Direction.
section करो. Trajectory कहाँ गई? Here ही, है ना? 20. Good. Tap लो. Tap लो tap. Open tap. लॉ स्क्रू लॉ 20 अच्छा 22 था ना, ठीक 22 से
Is going with very good purchase.
yes, it is good, having very good purchase. Okay.
Yeah. Length was
So-
very good also.
Huh? Now my colleague will put it from other side
Yeah.
after doing the tapping. Ball put देना. Section करो. Section कर दे. Section कर लो. ले चल. Section तू छोड़ दे, दोनों हाथ में ले ले. ठीक है? चल, डाल दे. ठीक वहीं जाएगा, कहीं और नहीं जाएगा. Going easily? Good. नहीं तुम एक पतला सा पुराना कोई बिट लगा लो. ठीक है, अब उसको मैं कट करना होगा. चलो. Okay.
Yes.
So
Beautiful.
this laminar fixation is complete now,
Yeah.
and we'll connect the rods. After cutting that extra length, वो मेरे को gauze देना है.
The length.
गीला gauze. See, somehow we dropped the cutter of that rod.
Oh.
So we are going to do something else to prevent the metal slippage.
Yes. Yes.
Okay.
I know.
So I'll put a lot of gel foam here.
Yeah.
Abgel. बड़ा एक बड़ा पूरा जब जेल मुझे दो. Okay, so I'll put a lot of gel foam here.
Now you are showing all the technique and tips and tricks.
Okay,
Yeah.
to prevent the metal slippage.
Yeah.
I have to resort to this cutting. I have to cut it using a metal cutter.
Yeah.
I will use a metal cutter. Okay,
Yeah. Yeah.
and but there will lot of slippage here. I mean there are lot of spillage of metal, so I am putting that just for sake of preventing it. Okay, so give me drill. Okay. Generally I do it after cutting,
Yeah.
but I will explain you what is my philosophy. I just drill. It's a titanium,
Yeah.
it's very soft. It's very soft metal. Okay.
Yeah.
See, using a simple old cutting burr, how easily you can drill it. The more pure it is,
Yeah.
the purer it is,
थोड़ा सा छोड़ देते हैं.
the
पूरा
easier
cut
it
नहीं
is
कर
to
पाते.
drill.
कट नहीं कर पाते पूरा फ्लैश इसमें. थोड़ा सा बस रहेगा, लेकिन वो नट के साथ ही रहेगा तो बस.
Okay,
Yes.
I am thinning it from outside. Saline, lot of saline. Give me that old cutter, simple cutter. So now this cutter will work. This cutter will work.
Yeah.
It is for
Rod cut.
Oh, okay. So now we'll drill this extra part also.
Yeah.
Okay. So that it will not protrude.
Good.
And you see what I'm going to do. पानी डालते तो गॉड पे सेक्शन करो नहीं तो जल फॉर्म खींचेगा. I am pushing, see, you can see, I am
Yes.
just pressing in the center.
Yeah.
And so the metal is expanding.
Yes.
Okay. And that is creating a lock on that one also.
Okay.
It has expanded. Okay.
Okay.
It will not come out now.
Okay. There is a check.
This is pretty much expanded now.
Okay.
Got it? So it's done. And now we'll connect the rods. Okay. Got it, Rakesh?
Yes.
Okay. So see, now it is done and I'm removing this. And see how beautifully the gel foam is protected. Section बढ़ा दो थोड़ा सा. But before that, we'll do a lot of washing. चलो wash करो, खूब अच्छे से wash करो. Still there's a lot of metal, but you can now suck it off. Okay. लो रॉड लगाते हैं. राम रॉड लो. तुमको थोड़ा सा इसको घुमाने के लिए देना पड़ेगा. हेड को. इसका भी हैंडल थोड़ा भारी बनवाओ यार. ना तुमने हल्का हैंडल बनवा रखा है ना. लो देना. कहाँ गया? Okay, so it is pretty, polyaxial. You can rotate it. थोड़ा स्वीपिंग इसको लेके घुमाओ हेड को. इस हेड को घुमाओ. हाँ घुमा घुमा. बस रुक जा. Okay.
Yes, sir.
So that's good.
Yeah.
That's quite good. I think that's perfect. You can उस पे कनेक्ट करो.
That is the concept for hybrid bus. Because if you try to do all the maneuver and
We'll do final tightening later on.
reduction with this one, so you have to do
दूसरी
lots
वाली?
of things. But we are just
This side?
supplementing. And we are doing a 3-point fixation, so settling down, especially in this patient. We are not
पड़ेगा.
bothered about this.
बहुत
settling
ज्यादा
down.
है.
So 3-point fixation down, and then we
बहुत ज्यादा है.
do one other C1 C2 for
एक मिनट.
realignment.
ये एक काम करो. इधर से 1 सेंटीमीटर इतना और इधर से 5 mm. ठीक है. काटो.
फिर देखो कितना हुआ
इधर से
है,
5 इधर से 1.
इस्तेमाल पर करते समय फिर नीचे का नहीं आया फिर देखो.
So this is hybrid fixation. Okay.
Yes, sir. That's why I was explaining.
सुनो और काटो. राम इसको 5 mm और काटो बड़े वाले को. इतना 5 mm है ना. गुड, ला ठीक, उधर वाला भी ठीक लगा है ना, कनेक्टर वाला ही था ना उधर, ठीक है, ला दूसरा लो।
कॉफी ठीक,
थोड़ा सा पकड़ लो ना, स्लिप कर रहा है यार थोड़ा सा, ठीक है, चलो फाइनल टाइट, इसको और छोटा कर दें क्या, लंबी लग रही है। सो वी आर रिड्यूसिंग द लेंथ बिकॉज यहीं से कट जाएगा, जाएगा नहीं, रुको काट ही दो ना, क्या फर्क पड़ता है। ओके, इट्स क्वाइट लॉन्ग, सो वी आर गोइंग टू कट इट, इसको निकाल दे रहा हूँ, काट के कम करो। सुनो, ऊपर से भी 2 mm काटो, छोटू सा, और इधर से इतना। हाँ बहुत बढ़िया, नीचे से भी काटो, नीचे से उससे थोड़ा सा ज्यादा काटना। ला,
लेकिन
ला निकालें पर इसको यार, ये ऊपर वाले का है, हाँ? ठीक, ये रखो संभाल के, कनेक्टर का है ये, है ना, अभी ठीक है ना, ज्यादा छोटा तो नहीं हो गया, नहीं ठीक है, परफेक्ट है, लो, हाँ परफेक्ट, अभी आ जाएगा, सही हो जाएगा, लो दो,
इससे नीचे
दो दो, नहीं ये रहा।
यस ऑफ कोर्स।
Okay, so this is perfect length.
Yeah.
And now I am doing the final tightening. इसका भी है, उसका भी है कि नहीं, उसका भी तो था, इसका यही है, चलो ठीक है, हिल रहा है पूरा, ये मुड़ रहा है, चलो ठीक, कोई बात नहीं, ये एक्चुअली टाइट हो गया उसमें, ये राम थोड़ा सा ना ये खींच रहा है यार, ये ना विपिन, पहले इसको जो है ना, इसको लॉक करना पड़ेगा, रुक जाओ, रुक जाओ, इसको मुझे ढीला करने दो, हाँ वो है, तो वही तो मैं कह रहा था, रुको ना, पहले इसको करना पड़ेगा यार, नहीं ये स्लिप कर रहा है एक्चुअली, थोड़ा सा नीचे गया है ना, स्लिपेज बढ़ गया है इसमें। है ना, चलो इस पे लगाओ, इसको टाइट करो, लो टाइट कर दो पहले, फिर देखते हैं, हो गया,
ठीक,
ओके गुड, ला 4 दिन राम तुम बाहर क्या रहे, तुम तो भूल गए सब, भूल गए कि इसका भी लॉकर है तुम्हारे पास, है? ठीक, so our fixation is complete, and now I am going to put a lot of bone graft, you know, in my only exposed side, because this is the place which is going to secure your surgery in future.
Yeah.
Got it?
Yes.
So I put a part of section fibular here, section 4. Okay, and you see your joint, how it has reduced beautifully. Okay,
Yeah.
and now I'll do a good wash before putting up my bone.
Yeah.
खूब खूब wash करो antibiotic saline से. Blood चाहिए और blood का जुगाड़ कुछ कराओ. फाइनल ले लेंगे अभी, बिफोर आई मीन अब बोन ग्राफ डाल के ले लेते हैं बस, है ना.
Most probably you are able to hear some cheers for you. सब जगे हुए इसका सबूत है सर.
So I am joining you in 10 minutes.
Yes, sir, please. We have a good photograph with champion and then we'll
Yes.
say bye-bye.
Please ask everybody, to stay.
Yes, sir, that's why I have ordered tea for everyone.
We
I'm
will
able to
take a
host,
good
I know.
photograph.
Yeah.
And I'd like
Yes.
to extend, my personal regards to everybody who has attended this workshop.
Yes, sir. So we all are waiting.
It's definitely an honor for us.
Yeah. मैं अभी सबको चाय पकड़ाया था ना, 5 मिनट तो पियेंगे गरम गरम चाय, क्या कर.
थोड़ा सा पतला लगाओगे क्या? अब बिट कोई भी लगा लो, डायमंड लगा लो, कुछ भी लगा लो. विपिन इसको थोड़ा प्रोटेक्ट कर लो फिर. नहीं पकड़ लो ऐसे, है ना. ठीक है. अरे बहुत मोटा दे दिया. 2 mm दे दो, डायमंड दे दो. अच्छा वो मैचस्टिक वाला ही दे दो, कोई बात नहीं. मैचस्टिक वाला डायमंड दे दो. वो सेक्शन भी पतला दे दो. सेक्शन पतला दे दो. बस हो गया, खत्म हो गया केस. Okay, so I am going to do a bit decortication. Okay. बहुत है ना.
Yes. Gentamicin.
I am removing the cartilage over here.
Yes, sir.
Okay.
Yeah.
And I'll take a final MEP. Final MEP एक ले लो, हटा दो, हो गया. एक final MEP. ठीक है. Okay, it's all fine. So I'll ask my anesthesia colleagues, to give the relaxant.
Yes, sir.
बच्चा दे दो relaxant, है ना. ले अभी यहाँ ले आओ, कटोरी यहाँ ले आओ, डालो. नंबर 4 देना दीजिए. हाँ, डाल देगा. ना ये नजदीक ले ना, गिरा इस पे ना, इधर इधर ले. कोई बात नहीं, बड़ा वाला नंबर 4 दे देना मेरे को. अच्छा ये दे दो, नंबर 1 दे दो. ले आओ ले आओ ले आओ. सब बाद में सेट कर देंगे ना. चल हटा. सेक्शन कम हो दो अरुण.
सर आपको
कॉटन हेड.
मैं 10,000 में
फिर भी एक समझ में आता है कि ये किस तरह का डिफरेंस है ताकि और ऑनेस्टली वही तो
ठीक है, चारों तरफ सीधे रख दो। लीवर और सेक्शन उठा देना। Okay, so it's all done.
Yes.
And I'm going to close it.
Yes, sir. Sir, we are waiting for you here.
Sure, sure.
Yeah.
ठीक है, चलो विपिन क्लोज कर दो। ठीक है,
Any final question?
हाँ, obviously. Take a final shot. Final X-ray. Remove the microscope. Take the light.
हो गया?
I will keep the. I know. I will post the CT scan.
Yes,
So,
yes.
so this is the final picture. Okay. You can see everything. You know, the upper screw is bicortical.
Yeah, yeah.
And the flat head is, you know, just compressing the inner cortex of the occipital bone.
Yeah.
Okay, so it's pretty solid fixation.
Yeah.
And now we are going to close it.
Yeah. Thank
Okay?
you, sir. Thanks a lot.
Good. चलो क्लोज करो, ड्रेन ले लो। चलो भैया, थैंक यू एवरीवन।
बस सर जल्दी से आ जाइए आप।
बस 2 मिनट्स। कुलदीप अरुण क्लोज करके वहीं आओ, है ना।
एक सबसे और रिक्वेस्ट है कि जो भी जब जाके सर्जरी करेगा सीवीजे, एक बार सबको पोस्ट तो करके दिखाए प्लीज। भाई सबको क्यों सर, भाई इट्स अ वे फॉर इम्प्रूवमेंट, इट्स वे फॉर लर्निंग। तो भाई कि ये सर मैंने किया, ये हो गया, ये हो गया, एंड दैट विल द बेस्ट पार्ट टू ऑर्गेनाइज दिस। कि अगर भाई 4 लोग जाके वहां कर रहे हैं, फिर उसके बाद 6 हुआ, फिर वहां लोग 18 वैसे ही फटाखट आने लगे। Yes, 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 yeah, yeah. So you all are welcome for any confusion, any like you want us to plan for you, we will do that. No worries. उसको थोड़ा सा और आगे कर दो ताकि अपन सब ऐसे बैठ जाएं, कुछ ले लेंगे और ये कर लेंगे। बैकग्राउंड नहीं है यार। ताकि सब लोग ऐसे खड़े हो, ये हट सकते हैं इसको